we did consult the surgery team. So those cases involved foreign body ingestions, caustic exposures, animal bites and stings, and all cases that involved or could have involved compartment syndrome. So the results that we found were that most of the cases, the majority of the cases, 54.5% were related to caustic exposures or ingestions, followed by foreign body ingestions, animal bites, and finally burns. For foreign body ingestions, the majority of those were related to button batteries, followed by high-powered magnets, and then we had water beads and some other ingestions that were involved. In conclusion, we identified 198 cases that were managed by a poison center that would have required or involved issues with surgical relevance. Poison centers don't usually consult the surgery team, and however, regular consultation with surgeons in certain relevant cases would improve patient management, would decrease the time needed to emergent surgical intervention, and would be both informational to the surgical team and would help establish kind of a pathway of communication between the poison center and the surgery team for all future cases. Any questions?
Thank you. Any questions? Thank you.
The next one.
No.
Okay.
Our next presenter is Dr. Bruno Bergarben, and he will be.
Good afternoon, everybody. As you know, acetaminophen is the most prescribed drug worldwide, but there are dangers related to repeated supratherapeutic ingestion, and this is still an issue because it is poorly known by the general population. So our objectives with this study were to report a case series of acetaminophen-positive patients resulting from repeated supratherapeutic ingestion admitted to our ICU in Paris, and to analyze the risk factors, the observed complications, and the final outcome of the patients. We conducted a retrospective single-center observational study on about 10 years, including all acetaminophen poison patients from repeated supratherapeutic ingestions admitted to the ICU. We defined this situation by the ingestion of a supratherapeutic dosage. That means more than 1 gram 4 times per day with a minimum of 6-hour intervals between 2 successive oral intakes. Of course, in the absence of self-harm or suicidal attempt as assessed by a psychiatry consultation. So we were able to identify 22 patients, mainly women, median age 35 years. The presumed ingested dose was 15 grams during 24 hours. Patients were admitted to the hospital with a median delay of 48 hours after the first ingested dose, and generally they were admitted due to abdominal pain and vomiting. On admission, the usual biological parameters were in the normal ranges, except transaminases, which were elevated, and with a slight decrease in prothrombin index to 61%. Of course, as expected, serum acetaminophen concentration was almost normal, at least very low. So we identify the presence of individual vulnerability in 7 patients who were chronic alcoholics. None of our patients received cytochrome inducer drugs or were anorexic. Of course, all the patients were immediately treated with N-acetylcysteine as soon as the diagnosis was suspected. Unfortunately, despite the treatment, severe complications occurred. Acute liver injury, 88%, metabolic acidosis, 27%, liver failure, 23%, acute renal failure, 23%, and deaths in 3 patients. These 3 patients were not transplanted because they arrived with a delay to the hospital and in the presence of multi-organ failure, requiring mechanical ventilation and high-dose norepinephrine infusion, and these were contraindications for liver transplantation. So our series confirm, of course, probably you know that chronic or staggered intoxication is acetaminophen is much more severe than voluntary ingestion. You see here this historical series comparing both situations. You see that in voluntary intoxications, if the patients ingested a median dose of 20 grams, so in one ingestion, and the death rate was 2%. While in accidental situations, they ingested 12 grams, so almost half of the dose, but the mortality rate was 19%. So accidental acetaminophen ingestion is much more severe, as confirmed in our series with 3 deaths among 22 patients. So acetaminophen repeated accidental or supratherapeutic ingestion may result in severe liver toxicity, life-threatening presentations, and high-rate fatality. And this is relatively easily evitable by public information to limit misuses. And recently in France, about 2 months ago, the health authorities decided to stop the possibility of the pharmacist to deliver acetaminophen without a prescription. So now acetaminophen prescription is mandatory in France. Thank you.
Experience with therapeutic excess of paracetamol, do you think or otherwise that the morbidity and mortality associated with it is more than that of acute because of ongoing consumption of glutathione, or that just a theoretical proposal has no reality in it?
That's a good question. I don't know exactly the mechanism. I'm not sure even if there is any knowledge about the exact reason why this supratherapeutic overdose with acetaminophen is more severe than self-harm ingestion of a huge amount. Probably the fact that you ingest repeatedly acetaminophen will consume all your protective antioxidant in the cell, and you will not be able to regenerate it rapidly, even if you are treated with N-acetylcysteine on time. Because many of these patients receive relatively rapidly acetaminophen, sometimes less than 2 days after the first ingestion, but despite this, they developed acute liver failure.
Thank you very much. Ahmed Al-Abri is going to discuss the utility of salicylate levels for all cases of paracetamol overdose.
Hello. Yeah. Hello, everybody. Thank you for your introduction, Dr. Ajay. Welcome, everybody, to my presentation. I'm actually going to present my research, which is about the utility of sending aspirin in all cases who are coming with paracetamol overdose. So there is a common practice among emergency physicians. They are sending salicylate for any cases who's coming with paracetamol overdose. Although there were a lot of study came later, it showed that the routine testing for salicylate may not be required for fully conscious patient who is denying any history of aspirin intake and who showed no clinical features of salicylate toxicity. Now, what about Oman? That's why, because there were no much study in Oman, so we create our own question. What is the utility of sending salicylate level for all cases with paracetamol overdose who present to Royal Hospital, which is a tertiary care hospital in Oman from 2007 to 2017? So we did a retrospective chart review study during this period from 2007 to 2017, and this is the data collection sheet. We found that total of 338 patients presented with paracetamol overdose. The emergency physician, they were divided among those cases. So in 189, actually, the emergency physician, they sent the salicylate for them, while in 149, salicylate level was not sent. Among those 189, salicylate was positive in 6 cases. Let's go through them one by one. So in 4 cases, there were very clear indication for salicylate to be sent. Actually, because 2 of them, they gave history of aspirin ingestion with the paracetamol. And one of them, he showed that a clinical picture, he was altered mental status, which is also, you need to screen for other toxicity, not only paracetamol in this case. And one patient, she showed that she's having a metabolic acidosis and respiratory alkalosis, which is also, again, one of the clinical features of the salicylate ingestion. The 5th case gave only abdominal pain. Now, this patient presented only a few hours after the paracetamol ingestion, and it was not clear that only paracetamol was ingested. So the emergency physician, that's why he go ahead and send the salicylate for this patient, and actually it came positive. The only patient where there were no clear indication to send anything other than paracetamol was the last one, because he denied any history of intake other than paracetamol. He was fully conscious, no clinical picture, and the salicylate came positive for this patient. Among those 6 patients, only supportive management was given for them, i.e. there was no dialysis, no sodium bicarb was needed for them. Now let's go back to those cases where salicylate was not sent to them. 149 cases, salicylate was not sent. So in those cases, none of them came back to ER later if they got discharged with a salicylate-related toxicity. And also, if they got admitted, if salicylate was sent, none of them also salicylate came to be high for those cases. What about the last case, the 6th case? 1 patient was missed. Now, this case was discussed with a toxicologist and discussed with a statistician, and from their point of view, it's insignificant to miss 1 case out of 338 cases. So, in general, our research looks like it's going in favor of the latest research that there is no need to send salicylate routinely for all cases who are coming with paracetamol overdose. Thank you.
Thank you very much. Any questions? Yes.
Thank you for your presentation. On a hindsight, why do you think that there's something else in the presentation of that case that it was
the last one?
Yeah, that would have triggered you to test for salicylate at the time presentation? Because despite this, as you said, the statisticians and the toxicologists said it's not significant, but the life worth saving is important. I agree with the notion that you don't need to test salicylate unless you have a clinical history or whatever suggests otherwise. But I'm interested to know if, on hindsight, would you have done it in that particular case?
I don't think so, because as I said, only he said, I took the paracetamol, he was fully conscious, no clinical features, that's it. So in this case, if I decided to go with salicylate, why don't also I go and investigate also other drugs, like the opioids, other medication? I will do the full screening for toxicity panel. So that will open that door also. Shall we send those investigation or not?
Okay, thank you very much.
Welcome.
Next presentation is going to be evaluation of patients with iron toxicity in the emergency department. Dr. Amin Emektar.
Good afternoon. I'm Dr. Emine. I'm from Ankara Keçiören Training and Research Hospital. The study title of, I am so exciting, by the way, evaluation of patients with iron toxicity in the emergency department. There is no conflict of interest. Acute iron poisoning is common in our country, in Turkey. In this study, we investigated demographic, clinic, and laboratory featured treatment modalities and complication of patients present to our emergency department with iron toxicity. This is a retrospective study. We enrolled the patient aged 18 years and older, admitted to our emergency department last 5 years, who had been diagnosed with iron toxicity. Patients with missing medical data were excluded. We recorded the demographic information, vital signs, amount of iron intake, additional drugs, blood iron levels, hospital outcome, admission and during hospital stay. We divided the patients 2 groups by the amount of iron intake. Doses below 20 milligram kilogram were considered as non-toxic. About 21 milligram kilogram were considered toxic. 61 patients were included in the study. 45 patients were female, and median age of the study population was 32. About half of the patients had taken additional medication. Most common group were analgesic. The mean amount of elementary iron taken by the patients was 1,000 milligram, and 4th-hour iron level was 246 milligram. None of the patients died. Evaluate the blood iron level and amount of iron. There was weak, statistically significant positive correlation between the amount of iron intake and blood iron level. Comparison of blood parameters at admission and during the follow-up 4 hours showed the significant decrease in hemoglobin, BBC, platelet, and creatine levels, and significant increase in the INR level during the follow-up compared to admission. No significant difference was the other blood parameters. Also, no significant difference was found between the toxic and non-toxic group, all blood parameters. In this study, we reached 2 findings. Firstly, although about half of our patients had taken toxic dose iron, there was a weak correlation between the amount of iron intake and blood iron level. About half of our patients had taken toxic dose of iron. Toxicity was mild, majority of patients. Secondly, we detected decreased some laboratory parameters, but we don't consider as clinically meaningful. Also, we didn't find any difference in renal and hepatic function test follow-up in the toxic or non-toxic group. We also found increase the INR level. We believe may indicate tissue affection at cellular level without any clinical affection. Thank you.
Wondering if it has to do with the fact that you said the most common co-ingestion was analgesics?
Yes. Maybe INR increase related to analgesic. Maybe.
Because I'm just I'm sorry. I was just wondering if maybe that would have been, you know, an NSAID or something.
NSAID. All of
The analgesics, were they non-steroidals?
No paracetamol. All drugs is NSAID.
Okay, okay, thank you.
Good afternoon, everyone. So the third study and the last study that I'll be sharing with you is looking at the incidence of fipronil-related exposures that we've had reported to the Qatar Poison Center. So again, I have nothing to disclose. So fipronil is actually an insecticide that is commonly used in Qatar. We've had a few exposures reported to our center over the past year. It's a newish insecticide. It actually works by inhibiting GABA-A chloride channels in insects at a higher affinity than it does in mammals and in humans. So technically should have, or does have, lesser toxicity to humans than it does to insects. However, there's not a lot of data related to exposures to fipronil. There have been very few case reports in the literature. There's one case series. But other than that, there's not a lot of data available regarding its toxicity. And the aim of this study was to look at the acute clinical effects associated with fipronil exposures in Qatar. So we looked at the cases received at our center, and we collected information related to the exposures that include patient age, the route of exposure, how critical the case was, and the clinical effects related after the exposure and that were detected on follow-up. And additional descriptive data was also collected and analyzed. So we had a total of 19 cases reported to the Qatar Poison Center. The median age for all the patients that we collected the data on were 2 years, and all of the patients were pediatrics, or less than 12 years of age. The majority of them, 57.9%, had no clinical effect. 42%, however, had a range of effects, from GI effects, those were 31.5%. Some also had neurological symptoms, but those were lesser, those were 10.5%. And the neurosymptoms that most of the patients had did not include seizures. Most of them were mild, like drowsiness, lethargy. And finally, dermal symptoms were also common, or less common at 5.2%. So fipronil exposures are associated with mild clinical effects, including GI and neuro symptoms, based on the data that was reported to the Poison Center. We did follow-ups on all of those patients and determined that none of them progressed to medium or even severe toxicity. However, poison prevention approaches should be widely implemented to educate patients or users or the public about the toxicity or the potential for toxicity with fipronil in Qatar. And actually, a lot of the products, I don't know if I have a picture, a lot of the products that we have that include fipronil are actually don't have enough labeling on them. So this is something that we're working on at the Qatar Poison Center to increase awareness of these products.
Thank you very much. Any questions? Thank you, Dr. Amin.
Okay, thank you.
Presenter from Kuwait could not join us. Our next presenter will discuss hospital mortality due to acute poisonings in Azerbaijan. Dr. Ismail Afandiev.
Thank you, dear colleagues. Thank you for the invitation, opportunity to speak. I represent the Poison Center of Ministry of Health. It's only medical institution in Azerbaijan that is responsible for treatment and prevention of all kinds of poisoning, both in adult and children. There are several departments: ICU, pediatric, dialysis, efferent therapy, hyperbaric oxygenation, laboratory, diagnostic, and poison information unit. The epidemiological data on fatal poisoning in Azerbaijan is very limited, so the aim of the study was to evaluate and analyze the characteristic of hospital mortality due to acute poisoning in Azerbaijan. Investigation was performed on data of poisoned patients admitted to Poison Center in Baku from the 1st January 2009 to 31 January 2019. The total number of PCC admissions was 21,911, and number of deaths was 542. Despite the predominance of female patients admitted to PCC. It's 56.5%. The inverse proportion was observed among fatal poisoning. And in age distribution, the largest was the age group 50-59 years old, 22%. Or then considering the mortality rate in certain age group, there's clear and reliable tendency to increase this indicator with age. So if the age group 15-19 years and 20-29 years, the percentage of mortality was only 1.04%, then in age group over 70 years, the indicator significantly increased to 9.25%, and P, it's less 0.001. As you can see in this chart, the largest share in structure of lethal poisoning belongs to poisoning from corrosive liquids, which 93.7% are vinegar essence, acetic acids. Acetic acids, being 70% organic acids, is available in each grocery shops in Azerbaijan and used for preparing domestic pickles. And it's common xenobiotic for committing suicides. And it caused deaths of patients both from acute renal and hepatic failure developing as a result of blood hemolysis, as well as from exotoxic, hypovolemic, and post-hemorrhagic shock in early first, third day stage of poisoning, and in late complication as gastrointestinal bleeding in 35.3%. The mortality of this nosology was 10.7%. Only the lethality of poisoning by alcohol surrogates exceeds this indicator. However, the total number of hospitalization of these patients was small, only 33 patients. And corrosive, as conclusion, corrosive substances and particular concentrated acetic acids is the main reason of hospital mortality in Azerbaijan. Acute narcotic drug poisonings and toxic gas inhalation poisoning are main reasons of toxicological mortality directly at the site of incident, while hospital mortality of these nosologists was relatively low. To reduce lethality of carbon monoxide poisoning, all rooms with gas appliance must be equipped with CO detectors, as free sale of concentrated acetic acids in the stores should be prohibited. Thank you.
Thank you very much. Any questions from the audience? Yes.
The majority mortality is coming among the patients who get corrosive and corrosive substance.
Yeah.
But your age, the exposure, the age was between 15 and 59. This is the highest one. As we know, the person who get corrosive, they are almost young. But in your studies, they are about 16. What do you think about this? Do you think is it suicidal?
Yes, exactly. It's suicidal for last years in our country due to a drop of oil prices, what big bank crisis, and many, especially men who had credits in banks, they cannot pay money for banks, and they committed suicide using acetic acids. So it was the rise of this age group.
And I just have one question to understand. So one of your slides indicated you have 21,911 admissions or deaths. So that means cases or hospital admissions and deaths are 21,000?
Yeah. 21,000 patients with severe poisoning that admitted to ICU department in this period of time. And of this, it's 524, it was death. We not include in this investigation our outpatients.
Okay, thank you.
Thank you.
Any other questions? Thank you very much.
Thank you.
Of therapeutic effect of psilocybin in experimental corrosive esophageal burn model by Dr. Sinan Pasli.
Good afternoon, everyone. I am Sinan Pastor from Karadeniz Technical University, Department of Emergency Medicine. I will talk about an experimental study we have made on rats. This study was conducted to investigate the effects of silibinin on corrosive esophageal burn caused by sodium hydroxide. To remember, silibinin is an active substance contained in the seeds of Silybum marianum plant. Due to its high antioxidant and anti-inflammatory effects, it's currently used as an antidotal treatment, as we know, for fungal poisoning containing cyclopeptides and also liver and gallbladder diseases. Its main mechanism is antioxidant effects, preventing lipid peroxidation and protecting the body against glutathione reduction. When we look at our study, we have 4 groups. Each consists of 7 rats. The first group and the second group received no burn, and the third and fourth group received 0.2 milliliter, 12.5% sodium hydroxide. Rats were first anesthetized with 50 milligram per kilogram ketamine and 5 milligram per kilogram xylazine. In order to reduce pain, 1 milligram per milliliter paracetamol was given to the rats by drinking water. As a treatment, Group 1 and Group 3 received 1 milliliter normal saline, and Group 2 received 30 milligram per kilogram silibinin intraperitoneally, and Group 4 received the same with Group 2. At the end of the third day, blood and esophageal tissue samples of all rats were taken for histopathological and biochemical evaluation. What we looked histologically: inflammation, epithelial loss, hemorrhage, damage to the muscularis mucosa, increase in mucosal collagen, and damage and collagen deposition in tunica muscularis. Also, we measured total histopathologic damage score. I will mention next slide. And the stenosis indexes are calculated esophageal wall thickness to luminal diameter ratio. Here are our group's results. Total histopathology score is this one. Inflammation, epithelial loss, all these scores obtained all together, sum up all together, and we obtained the total histopathologic score. And as we looked at the results, Group 3, to remember, we made the burn group and received normal saline, and Group 4, we made burn and received silibinin. There are significant differences between the results, the hemorrhage and stenosis indexes. There were significant differences, and other parameters were not significant. To sum up, I can say it has therefore been found that silibinin has positive effects, in part on burn healing, partially. Thank you.
Okay, thank you very much. Do we have any questions from the audience? You actually have 2 more
Yes.
presentations.
And again, an experimental study, very similar to previous one I mentioned. And in this study, we performed in order to examine the effect of N-acetylcysteine and ethyl pyruvate, both known with antioxidant and antioxidant effects. And we used again sodium hydroxide to make corrosive burn. In this study, we have 5 groups. Again, each consists of 7 rats. Group 1 received no burn, and Group 2, 3, 4, and 5 received 0.2 milliliter, 25% sodium hydroxide. Again, rats were first anesthetized with 50 milligram per kilogram ketamine and 5 milligram per kilogram xylazine. In order to reduce pain, we gave them 1 milligram per milliliter paracetamol. And again, inflammation, epithelial loss, hemorrhage, damage to muscularis mucosa, increase in mucosal collagen, damage and collagen deposition in tunica muscularis were evaluated. Again, total histopathologic damage score was measured. As a treatment, Group 1 and 2 received no treatment. Group 3, 4, and 5 received treatment. Group 3, 30 milligram per kilogram N-acetylcysteine intraperitoneally. Group 4 received 50 milligram per kilogram ethyl pyruvat, and group 5 received both of them together. Here are two tables, but I will talk about the second table mainly. The first table, all the parameters we have looked on the rats, and the second table, the total histopathologic score and stenosis index. I will talk about total score. Total score was significantly different between group 2, and we compared group 2 and other 3, 4, and 5, fifth groups. There were significant differences between group 2 and 3. As to remember, group 3 was taken N-acetylcysteine, and group 5 received N-acetylcysteine and ethyl pyruvat. There were no significant differences between group 4 and 2, and the stenosis index score was similar to total histopathologic scores. Again, to sum up, we found that N-acetylcysteine use alone or N-acetylcysteine use together with ethyl pyruvat has may be useful in healing esophageal burns associated with sodium hydroxide.
Any questions? Yes.
Did you give the N-acetylcysteine intraperitoneally?
Yes.
What's the action mechanism of intraperitoneal cysteine for esophagus burns? Because intraperitoneal region is not a connection with esophagus. I didn't understand the mechanism.
You say anesthesia?
No, I say, did you said you give the N-acetylcysteine intraperitoneally?
Yes.
What's the action mechanism of N-acetylcysteine intraperitoneal region to esophagus?
We sedatize them and then form the burn model with gavage to sedatize them.
You give the drug to intraperitoneal region to
Yes.
heal the esophagus burn.
Yes.
I didn't understand the mechanism of intraperitoneal anesthesia to heal the esophagus.
No. Anesthesia is not given to heal the
I understand.
Maybe I can help him. We gave NAC therapy because intraperitoneally, because you cannot give NAC therapy to an experimental study intravenously, IV rat. That's why the reason why, because it's the system, it shows the systemic effect when you administer it intraperitoneally. So it's the same in the rat study. So you cannot give IV procedure for an experimental study. Yeah, that's the reason why. Okay?
An experimental study and the effect of resveratrol on ischemic tissue injury in experimental carbon monoxide poisoning. The aim of this study was to investigate the protective effect of resveratrol on the ischemia, inflammation, and oxidative injury on brain and heart tissue, experimentally induced carbon monoxide intoxication. To remember, resveratrol is a natural polyphenolic molecule with known anti-inflammatory, antioxidant, anti-apoptotic, and anti-aging effects. We have 6 groups in this study. Each contains, again, 7 rats. Group 1, 2, and 3 received inhaled room air for 60 minutes, and group 4, 5, and 6 received 4 liters per minute, 5,000 ppm carbon monoxide inhaled. And as a treatment, group 1 and 4 received 1 milliliter normal saline, group 2, 16 milligram per milliliter dimethyl sulfoxide, and group 5 received the same. Dimethyl sulfoxide is the solvent of resveratrol, and group 3 and 4 received 25 milligram per kilogram resveratrol intraperitoneally. Carbon monoxide level, we measured it from the tail vein with 1 milliliter blood. At the end of the 48 hours, rats were sacrificed by decapitation method. Blood, brain, and heart tissue samples were taken. In brain tissue, histopathologist looks neuron damage score, percentage of degenerative neuron, apoptosis rate of cortex, and hypothalamus were calculated. And In heart tissue, myocyte degeneration, vascular congestion, and myocyte apoptosis rate were calculated. Also, biochemically, total antioxidant score, total oxidant score, and oxidative star index were calculated. Here are the results of our study. To compare the group 4, to remember carbon monoxide and normal saline, and group 6, carbon monoxide and resveratrol, there were significant differences between neural damage score, neuron degenerating rate, cortex apoptosis rate, and also a myocyte apoptosis rate comparison were significant. Biochemically, I said we have looked at total antioxidant score, total oxidant level. There were no significant differences between these groups, and so I didn't put the table here. As a result, I can say resveratrol administration in experimental setting may be beneficial in treatment injury to secondary to carbon monoxide tissue in brain. Thank you.
Thank you very much. Any questions from the audience? Thank you very much. We'd like to thank you and all of our presenters in the oral research session. Good afternoon.
Okay. Hello, everyone. Good afternoon. First of all, I want to say I am very happy to be with you in this great organization. I want to thank you, Mena Talks, Ziad Kazi, and Bashir Al, and İpet, Big Boss, Bashar Jander. Today, third day of great organization. Our session is in the golden hour management in the emergency department. We will talk very important topics from valuable speakers. I want to invite our first speaker, Dr. Eren Gökdağ, will make a presentation on carbon monoxide. He's working as an emergency medicine consultant at Yeditepe University Hospital. He's PhD student in toxicology at Yeditepe University of Department of Pharmacology. Yes, please.
Okay. Hello, this session is about golden hour management in the emergency department, but because of the nature of majority of carbon monoxide poisonings, it's not that possible to start the treatment within the first hours. I think everyone knows what carbon monoxide is. It's well-known toxicant. It's colorless, odorless, and tasteless gas. The carboxyhemoglobin levels for non-smokers can be up to 5%, and for smokers it can be up to 10%. Carbon monoxide poisonings is a leading cause of accidental poisonings, but we are bad at data management in our country, so I don't have national data. But according to Global Health Data Exchange 2017 report, the worldwide cumulative incidence and mortality of carbon monoxide poisons were estimated at 137 cases per million and 4.6 deaths per million, respectively. And it also published in Lancet 2018. Clinical manifestations are vary, and these manifestations and severity of clinic doesn't correlate with carboxyhemoglobin levels. Because of this the variation of clinic manifestations, even most of the time, patients even don't know that they are affected from carbon monoxide poisoning. Treatment is simple. We give oxygen, 100% oxygen as soon as possible. If there is a cardiovascular compromise, we can give IV fluids, inotropes, and if there is a life-threatening dysrhythmia, we initiate the standard advanced cardiac life support protocols. And also we give supportive treatment for seizures, benzodiazepines for seizures. half-life of carbon monoxide changes with method of oxygen delivery. We know that it's in room air, half-life is 4 to 5 hours, but with 100% oxygen, it decreased to 80 minutes, and with hyperbaric oxygen therapy, it will reduce to 20 minutes. Pardon. We have very oxygen delivery methods. These are the high flow nasal cannula is a new method, and non-rebreather mask is our traditional way. CPAP is also one of the newer methods, and hyperbaric oxygen therapy is the most effective weapon against carbon monoxide poisoning, but it has some challenges in itself. These are the newest studies about high-flow nasal cannula. Oxygen via high-flow nasal cannula is a newer method, like I said, but they found useful in some cases. This is one case, a young male patient, and they found that high-flow nasal cannula can be useful for carbon monoxide poisoning, and it is more comfortable than traditional methods. And this one is also another study, but they compare with it conventional face mask in this study, not non-rebreather mask, but it also has lower half-life than room air. And this one is also a new study, but their sample size is low, so they say that this is promising alternative, but we need further studies to earn its place for the treatment. And this is, I think this is the only study that I can find for CPAP. They compare the CPAP with non-rebreather mask, and the half-life is significantly reduced by CPAP. But like I said, in high-flow nasal cannula, it will only for suitable cases. It's not that comfortable like high-flow nasal cannula. Hyperbaric oxygen treatment is controversial. We know that it's useful, but we don't know how useful. Hyperbaric oxygen therapy increases blood oxygen content rapidly, and it has additional effects on neutrophil adhesion to blood vessels, on restoration of mitochondrial, oxidative, and immunological disturbances caused by carbon monoxide. But the fight continues about how useful hyperbaric oxygen treatment is and in which cases we should use it. Despite the fight, we have suggested indications. You can see that. These suggestions generally covers for serious patients like coma, seizure, altered mental status, and abnormal cerebral function and fetal distress in pregnancy. But it doesn't prevent from the patient from delayed neurological sequelae, 100%. Even the patient had mild symptoms and relatively low carbon monoxide carboxyhemoglobin levels. Delayed neurologic sequelae can still be seen in these patients. So we still didn't know the exact patients which we should use the hyperbaric oxygen treatment. This is a study of ours. We found that initial neurologic examination, if there is a pathological initial neurologic examination, has a predictive value for delayed neurological sequelae, but carboxyhemoglobin levels weren't correlated with delayed neurologic sequelae. There is too many studies which conflict with each other about hyperbaric oxygen treatment on carbon monoxide poisonings. At least we know that hyperbaric oxygen treatment is useful in some degree, especially if start within the first 6 hours. So we are continuing to use it as a standard. Thank you for your attention.
Thank you, Dr. Eren Gökten, for this very well presentation. Do you have any question or adding?
I think no. I think.
Have an opinion in ECMO for carbon monoxide?
Sorry,
ECMO.
ECMO. It is because of the subject is golden hour management of emergency department, and ECMO isn't generally used, so I didn't cover the ECMO in our presentation.
Okay.
But there is studies that blood transfusion and like ECMO is useful for carbon monoxide poisoning, but it's not that practical. So,
thank you.
Yeah.
Awake. I'm Ziad Kazi, and it's my pleasure to bring you today a special course, a new course for MENA Talks called RIMIC, which is Recognition and Initial Management of an Illness Cluster. This course is based on several incidents and events that happened to me as well as to the region. As you know, we are now facing a new normal in our region, unfortunately, where we have chemical weapons and we have chemical attacks. When I was a fellow in toxicology, of course, all toxicology fellows study chemical warfare and chemical weapons. We usually study them, and historically. I never imagined that in the 2000s, I was having to think about attacks in Syria and see if they were actually chemical attacks, or in Iraq, or other parts of our region. The other factor that led to this course is that over the years, I've been involved in situations where several people develop an illness of unknown cause. And we have to think through the cause of this illness. And many people teach about these type of illnesses, but they usually focus on viruses, bacteria, chemicals, radiologicals. But this doesn't help us in the ER, right? In the emergency department, does this help us? We are sitting there, a patient shows up with an illness. They don't tell us I'm a chemical patient, I'm a biological patient. They come undifferentiated. And only through proper history and physical exam and proper thinking can we really find out what's going on with the patient. And this is why we decided to create a course that really focuses on the clinical manifestations. Primarily that. You will not see a lot of treatment information. This is more a course to help you remember what could this be. What other things can be causing this illness. Even if they're not likely, but possible. And just the fact that you think about these possibilities, I think is an important thing. The chemicals that we can see in these incidents can be varied. And from Syria, for example, we know that initially we had nerve agents. And then when we had the tragic incident in Ghouta, they signed the Geneva Convention, and then there was a ban on destruction of the nerve agents. But then we saw more what? Chlorine being used. So there's a variety. And we even saw sulfur mustard in Syria. Of course, Iraq has many cases of sulfur mustard and other chemicals that we will talk about later on. Now, disasters usually are defined as an act of nature or an act of man, which is of sufficient severity and magnitude to warrant emergency assistance. This is kind of a nice, big definition. But really a disaster at the community level is any incident that overcomes or is beyond your capabilities or capacity to deal with it. And an incident that disrupts your day-to-day activities or normal functioning in your emergency department. There are natural disasters and there are technological disasters. The natural ones are not going to be discussed today, but of course are an important type of disasters. The technological disasters are what we will focus on today, and those are usually either overt or covert. Covert is like what Dr. Hamoudi will see with thallium poisoning, for example. It's a covert incident. Overt is when there's an explosion, for example, and release of chemicals. It could be accidental, like a release of chemicals from an industry, or intentional in an act of terrorism. A cluster is what we're going to talk about today, is a group of unusual aggregations of illness amongst people in a community. These people usually are affected or exposed in the same place or similar place potentially. They have things in common, place, or they have time in common, occupation, and those are usually called a cluster of illness. And those can come to your emergency department, and that's why we are going to go through the differential diagnosis of such patients. CBRNE is a term that replaced the old term in World War II, which was NBC. So CBRNE is chemical, biological, radiological, nuclear, and explosive. Now these are usually military weapons, for example. Some of them are used only for military purposes. Others have dual use. An example of a military CBRNE chemical is chlorine, which is also used in industry. But those are not the only chemicals we have to worry about, or agents that we have to worry about. There are toxic industrial chemicals and toxic industrial materials and toxic radiological materials. Those are all over the place. They are around you at hospitals, at industrial sites. And those are the ones that can be also used easily. And if they're intercepted, if the chemical security is not robust around them, or the biosecurity or the radiological security is not robust around them, they can be apprehended by a terrorist and used. This is why today Dr. Andy Nelson is going to talk about that in more details, about how to think about the security of these materials in your environment, in your community. So let's look a little bit at the chemical, biological, and radiological characteristics. And I'm going to actually turn around here so I cannot see that far. If you look at chemicals versus biological versus radiological, the first thing is, can they be disseminated over a wide area? Chemicals can, especially when they are gases, for example. Biological, on the other hand, are difficult to disseminate over a large area. Usually, they tried to have these biological bombs, for example, in the past by dropping them from airplanes and spraying brucella or spraying other type of tularemia. But they don't really work that well. And heat can deactivate them as well, so that's a challenge. And also, how do you store them and to use them in the battlefield? Radiological may or may not affect a large area. A nuclear weapon detonation, for example, can affect a large area. A dirty bomb can affect, a significant area. But a radiological device that you put in a room can only expose people around the device. And the further away you are from the device, the less radiation dose you get. As far as security is concerned, chemicals and biological agents have low security because they are used on a day-to-day basis, and they're available at hospitals, for example, and they're easily manufactured or grown in a lab. So the security of these is low, and I would not say more than that because I think Dr. Nelson will talk more about this. Radiological agents vary. There are some radiological agents that are very secure, like uranium, for example, or plutonium. Some are less secure, like, let's say, technetium, or things you use in nuclear medicine, or things you use in industrial settings. As far as the delayed presentations, so this is important for our course, RIMIC, what can cause a delayed presentation of illness. The chemicals usually are going to cause an acute effect, although there are some that cause delayed presentations. A great example of that is dioxins. Another example of that is methyl mercury, and those can have delayed onset of illness. Okay? The biological agents, yes, can cause delayed illness. There's an incubation period, and then there's an illness. Except if you're thinking about a biological illness due to a toxin, like botulinum toxin or ricin, those may have an earlier onset illness. Radiological agents, by definition, have a delay. Radiation rarely causes very severe or overt acute symptoms, usually delayed. As far as the transmissibility of these agents, chemicals are not transmissible usually. But biological, yes, you can transmit the disease from one person to person, depending on what the agent is. Radiological, you could potentially transfer contamination, but that's not really transmissible. So usually we don't think of radiation as transmissible. Biological agents induce immunity. Chemicals and radiologicals do not. Decontamination is important for chemical and radiological, more for chemical than for radiological. It's more important for chemical events than for radiological events. Biological usually does not require decontamination unless you have, for example, anthrax spores that you're trying to clean up. Finally, treatment. For chemicals and radiologicals, it's primarily supportive care with antidotes or countermeasures. For biologicals, now you're thinking about antimicrobials, antivirals, and then vaccines. So I hope with this in mind today, you will use this information every time you see a cluster to try to differentiate, whether it's chemical, whether it's biological, whether it's radiological, depending on this type of information. And also broaden your mind, because the dose is what determines the poison. Really, everything can be poisonous depending on the dose. So don't just look for the ones that are definitely poisonous. Look at any chemical and assess the situation specifically. Is this situation, one where it's a not toxic chemical, but the dose is high, and therefore it can be explaining the effects? You also must really look at the physical properties. We probably don't do that a lot, but you should look at the pH of a substance. You should look at the boiling temperature or the freezing temperature, the vapor pressure at room temperature. What are the warning properties of this chemical or this radiological agent, for example, which usually is very poor for radiological agents. They don't have warning properties because they don't smell funny, they don't look funny, and certainly they don't glow. Chemical agents, on the other hand, may have an odor or may cause an irritation, but it depends on the chemical and how good these properties are to warn people when they are exposed to them. Also, when you look at biological agents, it's important to understand the incubation period. And is it transmissible from person to person? And then how long are you infectious? And what is the time course of this illness? So having this information in your head, I think, is important. If you can't remember it, you have to look it up when you're facing a situation to be better able to respond to the needs of your patients. Let's talk a little bit about warning properties. So the warning properties, such as, for example, odor, may or may not be sufficient or protective. What is the point of you smelling something when the concentration at which you smell that chemical is lethal? Right? Ideally, you want to be able to detect the smell of a chemical at a concentration that is very far from the lethal dose, right? So that you smell it and run away. The other problem with smell is that some people don't have a good sense of smell for certain chemicals as well. It's a lot of genetic factors involved. And there's something called olfactory fatigue, where the nose stops detecting a specific chemical. A great example is what? Which chemical? Thank you, hydrogen sulfide, which causes this olfactory fatigue. And people would smell it for a short period of time, and then they get reassured that it's not there when the smell goes away, when actually it's still there, it's getting higher and higher, and they're gonna die soon. Cyanide gas is thought to have a bitter almond smell, but people cannot smell that. Not every person can detect the bitter almond smell. So those are poor warning properties, for example. I hope you remember to use the agent-host environment tool in your response. Every time you are faced with a disaster or a cluster of illness, stop, pause, and think about what is the agent, who is the host, and what is the environment. This is an old epidemiological tool used in public health for infectious disease outbreaks. where they use it when they're dealing, for example, with a malaria problem in a location. We use it for the chemical and radiological in the following manner. First of all, assess what is the agent. Think about it. Could this be a chemical? Could this be a biological? Could this be radiological? If you don't go through this exercise, you'll miss it. I'm not saying every case it is going to be an exotic radiological event, but at least think about it for a second, okay? And think agent, okay, let's see. Could this be a chemical? Could this be a biological? Could this be radiological? And okay, let's say you know what the chemical is or the substance is. What do we know about this substance? Is it, you know, a gas, a solid, a liquid? Is it radioactive material in a solid form? Does it emit gamma rays or beta particles or alpha particles? What is the decay products of this radioactive material? Is this a bacteria or virus? Okay. How much of it are we talking about? Is it a lot, a little bit? Is it potent or not? What is the toxicity? What is the route of exposure that is really bad for this specific substance? The next thing you could go through is the host. Who is the victim? Is this a person who is wearing a mask because it's a military person wearing a gas mask on a battlefield? Or is this a child, a pregnant person? Is this somebody who already has immunosuppression that's been affected by radiation? All of these should go through your mind as you are assessing a situation. And what is the environment of this exposure or this event? Was this at a bus stop like we saw yesterday in the outbreak investigation workshop? Was this outside or inside of a building? You know, because inside of a building, theoretically, you don't need as much substance to affect people as if it was outside the building, because outside, you know, it's going to evaporate. What are the environmental conditions? What was the temperature? Sulfur mustard in Iraq and Iran caused more respiratory effects than in Europe because of the environmental temperatures conditions. So you need to analyze all of these factors when you look at the incident. An example of that is Bhopal in India. In Bhopal in India in 1984, what was the agent? Methyl isocyanate. What do we know about methyl isocyanate? It's an irritant. Does it contain cyanide? It contains a cyanide molecule, but it doesn't cause cyanotoxicity. What else do we know about it? We know about it, it's highly water soluble. And what else do we know about it? Amount, large amount. This was a chemical used to make other chemicals, so they stored a lot of it in that, on that site. So large amount, irritant, water soluble. Does it get absorbed into the body? Unlikely. It's more of a irritant without significant absorption. Who is the host? Poor people living in structures that are not very protective and living very close to the actual plant. Not very, nothing else special about them. They're just normal people, families, children, adults, men, women, but probably with poor access to care. Knowing, you know, some of these rural areas in India, they probably have poor access to care. What is the environment? The environment was outdoors, open air environment. However, there was an environmental condition which led to temperature inversion, which led to the methyl isocyanate not evaporating and dissipating in the environment. It kept it kind of a lid on a pot, hugging the ground and affecting more people. So analyzing this event using agent-host environment helps you understand the event better and potentially helps you look for specific injuries based on your assessment. Let's think about Georgia, the Republic of Georgia, where there were two woodworkers, people that collect wood from the forest, in a very remote area in Georgia. These people found these two canisters in Georgia, and the agent here was strontium. It's a radioactive compound, strontium. It emits radiation, gamma rays, and it also emits heat. And it's usually used in these remote areas to generate electricity. They're radiothermal generators that are placed in remote areas where it's hard to get electricity to, and they generate their own electricity. They were left behind by the former Soviet Union, because Georgia used to be a country in the former Soviet Union. They were found by these woodworkers. So who is the host? 2 woodworkers, 2 people, healthy. Nothing else unusual about them, but at least just only 2, not 100. What is the environment? The environment was outdoors. They found it. It was a remote area, very cold. And because of this, they wanted to heat themselves, and this was emitting some heat, so they thought this is a heat source. So they carried it on their body and to their tent and slept close to it. So that's the environment. And because it's a radioactive material, when you think about what is the agent, gamma rays are going to expose people at a distance, and that's what happened to them. They developed the radiation injury to their back with the cutaneous effects, as well as the bone marrow suppression. One of them died, the other one survived. So finally, just want to pause a little bit here and have you think about this. How prepared are you for a CBRN incident? Think about that. Are you prepared? Well, we have some research that shows we're not. For example, Dr. Bashar talked about or Dr. Samih Korkut talked about the large number of volunteers in Turkey for disasters. We did a survey in the US of our volunteers and asked them about their attitudes and comfort level with a variety of disaster scenarios. And clearly, they were much more comfortable responding to a weather-related emergency than they would be for a chemical or biological or radiological. They're more scared of responding to that. And I think that'd be a good project maybe in Turkey if it hasn't been done to assess the volunteers here's perception and comfort level with these events. I did a survey amongst emergency medicine physicians several years ago and asked them about radiation, knowledge questions and comfort level, and the results were surprisingly, surprising because they were uncomfortable and unaware of many of the basic knowledge of radiation injuries. So I think we have a long way to go in this area, and we need to certainly try to train our colleagues in this field, because without knowledge, you cannot have preparedness. You can have all the PPE and all the antidotes and all the ambulances of the world, but if you don't have the knowledge, how are you going to respond, especially when you're a physician, required to assess, analyze, and treat. Now, that may be difficult when you think about the thousands or millions of potential scenarios out there. Thousands of chemicals can show up through your door. Thousands of types of radioactive material or viruses or bacteria. It can be overwhelming. And there's no way you will be able to remember every single chemical or radioactive material. And it's no shame in looking something up and trying to get some more information about something. So finding the right resources is important in your response. But you do want to at least start thinking about what could this be. And you cannot wait too long. These are emergencies. So you must start assessing the situation and getting the appropriate laboratory analysis. But that's going to take time if it's available. Some chemicals or biological agents, have diagnostics that are not always available, and some require several days to result. In the meantime, you must take care of the patient. So you need to look at the clinical picture, and you need to know at least which category it fits under, and then start managing it safely and effectively as you get more information as time goes by. So we recommend using this approach of RIMIC, which is really the toxidrome-based approach or syndrome-based approach. And the knowledge that you get today in other training courses helps you enrich your differential diagnosis so that you're able to go through a list and see which one is possible, which one is less likely, and which one is more likely. And the CDC, for example, has published a list of chemical toxidromes, for example. And this is available online for free, and you can look through the list just to help you, define some of these categories. But today, we'll try to hit up some of these categories. irritant is something we are going to cover. Asphyxiant, maybe less so, but we'll talk about anticholinergic. We'll talk about sedative, opioid, stimulant. We'll talk about corrosive. And then we'll talk about a little bit about radiation exposure. This is not an exhaustive list. There are potentially other syndromes out there, but this is a place to start. And the more important thing is to learn how to think through this process rather than go through every single category. So I hope you'll enjoy the rest of the day, and I think we're gonna try to stay on time and hopefully finish maybe an hour or 30 minutes earlier than what is scheduled. This is a CAM website, which is available online for free by the National Library of Medicine. It's also an app. It's a resource to help you put together signs and symptoms into different boxes and guide you towards a potential toxic draw. Thank you. Any questions? And then we are going to take questions today as they come. So Dr. Brent Morgan is a professor of emergency medicine at Emory University and is the vice chair of education. What is the new title? Vice chair of strategic initiatives at our department and the residency program director for medical toxicology at Emory. Dr. Morgan?
I need module 2. And this says module 3. Maybe this is still it. Okay, cool. Yeah. All right, so our objectives today, you'll be able to list 2 reasons why the GI system is uniquely susceptible to toxicological insults. And then also be able to name the cause of the largest bioterrorist attack in the history of the United States. And so we're going to be talking about GI clusters, so how different exposures potentially result in a GI illness. You can see the GI tract in the diagram there, starting at the mouth and ending down at the rectum. And the GI tract is uniquely susceptible really for a couple reasons. I mean, one, it's a site of contact, right, where a lot of pathogens or toxins can first come in contact with the body. And then also the amount that's going to come in contact is going to be at the greatest at that time when it's touching the GI tract. It also has rapidly dividing cells, and so toxins that make it so that you can't divide anymore, and we'll talk about some of those, are going to affect there, and then you're going to start seeing the symptoms. And then the effects and symptoms are pretty readily apparent, right? So we're talking about people having abdominal pain, vomiting, or diarrhea. And so clinically, we can see that, right away as soon as those symptoms develop, whereas opposed to the other organ system, the hematopoietic system, that's our bone marrow making cells. It also has rapidly dividing cells. If both of these 2 systems are having adverse effects from a toxic exposure, you got to wait until you start seeing the problems with the bone marrow. So the cells that are in their blood are still going to be there, and you got to wait for those to naturally decline, and they're not able to replace them. So you're not going to see that. We're going to focus mostly just on the GI tract in this, but obviously there are other organ systems in our gastrointestinal system, including our pancreas, our bile ducts, and our liver. Just a little bit about liver. It also gets exposed to a relatively large concentration of a substance that we ingest because it gets the first pass effect that you absorb those things through your gut, goes right up to the liver. So it's going to get a significant exposure. And the liver is also metabolically active. I mean, a lot of tissues in our body are metabolically active. The liver is by far the most metabolically active. And so when it attempts to metabolize these substances, sometimes it can form a more toxic compound. Then that can have adverse effect on the liver itself or throughout the body. So again, we're going to focus mostly on patients that are having abdominal pain, nausea, vomiting, and diarrhea. And you can look into different tables about the color of the vomit and the color of the diarrhea. I'm colorblind, so it doesn't help me, but you can always look those up. And we're basically going to go through a series of cases of real events that occurred and whenever we kind of discuss this and talk about differential. But a broad differential, there's obviously the infectious, and usually that's where most of the money's going to be, right? When you have someone comes into your emergency department or you get a cluster, several people, it's usually going to be some sort of infection. They had food together that was contaminated, and most of the times you're going to be correct in that. And so you're looking at different bacterial infections. There can be ones that produce toxins, such as like staph toxin, and those are going to be more rapidly acting because the toxins there is going to start causing the adverse effects, versus ones that are more infectious, and those can be a little more delayed as far as they're invasive. You ingest them, then they have to invade into your intestines and then start causing the symptoms of the infection. Obviously, a lot of virals out there, like rotavirus, for example. Parasitic, which can be even slower in onset. Radiation can certainly affect the GI system and result in abdominal pain, vomiting, diarrhea, and so we'll talk further about that. And then we get into some of the toxicants, so things that don't occur naturally, and potentially be man-made, or they're not made by a living organism, I should say. So there are a lot of metals that can have adverse effects on our GI system. Things that enhance serotonin potentially can cause GI symptoms because we have a lot of serotonin activity in our gut. Cholinergics, the big one being like organophosphates and carbamates, besides having other symptoms, can obviously have a predominant amount of GI systems. Things that cause cell death or interfere with your cell's ability to divide by making it stick in mitosis because the microtubular apparatus can't work, can also then affect the GI system. And then just your plain irritants, things that kind of irritate, and that would be like your laxatives, for example, can make you have the diarrhea. And then toxins, so substances that are made by living animals, or living organisms, I should say. So obviously there's a variety of plants that it should not be ingested. If they are ingested, it can cause GI symptoms. English ivy would be a good example of that. Different mushrooms or fungi. There's a lot of mushrooms that just cause GI effects, and that's it. There are other ones that can cause GI effects and then cause problems with your liver, like the Amanita species. And then the marine toxins that we think about, such as ciguatera, brevetoxin, the ones that are from shellfish poisoning. In addition to having some other symptoms, including like neurologic symptoms, they will present with the GIs at first. So a pretty broad differential. If you get more than one patient who were there kind of together at a certain place, who are having problems with their GI system, such as nausea, vomiting, diarrhea, then that's when you need to start reaching out for help to do some epidemiology about what's going on, and it's immediate importance. Obviously, the main cause of these events are going to be infectious, and that's when you're going to want to reach out then to your infectious disease colleagues. And then at some point that you may want to order an infectious disease officer at your hospital. And then at some point you may need to get your government involved, because they're the ones who have the resources and the capability to really investigate it, to leave the hospital, to go to where the site was, where the infection inoculation initially occurred, and then try to do the work there and help in identifying what was going on, and then potentially hopefully to limit its spread so other people don't become sick, or identify other people who may be sick, but they're just at home toughing it out, and you may be able to give them proper care. All right, so we're going to run through, again, a few cases here of clusters of GI illnesses. So this one occurred way back in 1984 in Oregon, which is a state in the northwestern part of the United States. And in September, many people started developing an illness, a GI illness with diarrhea, fever, chills, vomiting, abdominal pain, and having blood in their diarrhea. And this was in a rural area. I think the main town there had roughly 12,000 people, I think, as their population. And then by the end of September, there were over 700 people who had developed this infection. And they'd done some lab testing on them and determined that it was a Salmonella species that was causing this infection. So the State Department of Health started an investigation, and they ended up finding out that all the patients had dined at one of 10 local restaurants, in the area. And the investigation identified this Salmonella species at those restaurants and their salad bars. And they concluded that the outbreak had been due to the food handlers there having poor personal hygiene, that these food handlers also had caught the disease, the infection themselves at some point before most of the people in the community did, and that they didn't use good hand hygiene, and that's what continued to spread the infection. And so they shut down the salad bars and all these restaurants, and then assumed that had taken care of it. I guess kind of reasonable suspicion, but the locals there had other suspects. They didn't believe what the state had told them. And at the time, there was a community that had recently moved in to their rural area of several thousand people, and they were following this guru, or this spiritual leader, and they're called the Rajnas. And you can see here the picture of him in his car driving up, and all of his followers lining the road for him. And then here's the speaker himself. And they were highly suspicious of that this group had something to do it. As I said, they had moved into this community for a few years before that. There was a smaller town in this community called Antelope. And they had essentially, once they took this over, they ran for office in that smaller community. They won the electoral races, and then they actually changed the name of the town, after themselves to the Rajnas. And then they were running candidates in this upcoming election that was going to be coming up in November, the beginning of November as well. And they were trying to sort of take over the county, government. Ended up being that in the election that occurred in November, they had a massive turnout of locals, and they actually were pretty strict then as far as who they allowed to vote. You had to prove that you had residents there, proved you had to be a citizen of the country, and so they end up the followers of the Rajnas did not win the election, but again that was more in November. A local U.S. congressman from that area was also convinced that there's something going on, and that it was that it wasn't just the salad employees or the employees of the restaurant that caused this. And so they actually called on CDC to further investigate and asked U.S. government to try to investigate. However, most of the government officials thought these locals were just being kind of bigots against the Rajnas and were prejudiced against them as well, and so they didn't give them a lot of concern to their pleas. However, then that following summer, this leader of the Rajnas, again the spiritual guru, he actually at the time had been on a 4-year period of public silence and self-imposed isolation while he was doing his thing. And then shortly after he came out, he started talking to his followers and heard that some things had happened while he was in this period of silence, and that some of his followers had in fact been responsible for this outbreak of the Salmonella. And so this was actually a little a trial run they were doing to see how many people they could infect. And then they were going to try to do a bigger one in November when the election was, to see if they could get even more of the community ill with this from Salmonella or some other type of infection, so they wouldn't be able to go and vote. And then their followers wouldn't have the infection, and they'd be able to vote more and get more of their people elected. And so after he announced that his group was responsible, then the authorities came in and they had their own medical clinic, and they actually found vials of the Salmonella that were an exact DNA match to the Salmonella that people in the community had developed. And what they had actually ordered it, and they had the receipt from a lab in Washington State, the Salmonella species, and they continued to kind of grow it there at their clinic. And they had went to the salad bars and sprinkled the Salmonella there on the public salad bars, and then people would come and consume it, and that's how they got infected. There were no deaths from this, and which is great. Very fortunate. And they ended up doing prosecution against several of the members of the group. The leader claimed he didn't know this was going on, again, that he was in his public silence period, and so he was not charged. And this ended up being the single largest bioterrorist attack in U.S. history. The next cluster that I want to talk about, this would be a patient who presented to the emergency department with nausea, vomiting, having profuse diarrhea, and also happened to having chest pains. She had a past history of having fibromyalgia and back and neck pain. And she had been going to an alternative practitioner, or what we call a naturopath, in the United States. These are people who kind of sometimes do some weird things that's out of the mainstream as far as what most physicians would do. And she was receiving these infusions once a week for her back and her neck pain. Her symptoms started about 1 hour after her last infusion, and once the symptoms started, actually the naturopath, their office told her, well, go to the emergency department and see if they can do for you. Initially, her labs were unremarkable, except for an elevated white count, and then she got admitted for IV hydration and observation, and they were concerned about infection, so they sent cultures on her. A repeat white count that was done several hours later was also even more elevated and had a lot of immature forms on it as well in the differential. But then over the next 72 hours, her laboratory analysis and her condition continued to worsen, where she developed multi-organ failure. You can see that she developed low white count, low platelets, so she's having bone marrow suppression. She developed acute renal failure. She developed rhabdo. She developed a lactic acidosis, and she developed some hepatotoxicity, and then also had a pretty dramatically elevated troponin. Any thoughts on what she could have been receiving? Ricin, okay. It's a good thought. Well, ricin is something that shuts down cell replication, so through ribosomes and elongation factor 2, so that's something that potentially maybe this naturopath was trying to give a little bit of that. Or colchicine, yeah, colchicine would be a great differential here as well. Colchicine affects your microtubular system so that your cells can't divide. That also shuts down cell replication, so you're going to see the GIs and then bone marrow suppression and then multi-organ failure. So on the third hospital day, she developed ARDS, then hypotension, cardiac arrest, and unfortunately died. And then they had gotten the history of what this naturopath was administering. Ended up sending to post-mortem level. It came back at 32 nanograms per cc. And you're right, as that was colchicine that she was receiving in this alternative medic clinic. This was something that was, again, some of the alternative medicine practitioners in our country were using colchicine for different back pain, neck pain, fibromyalgia. It has its anti-inflammatory properties that it has. And then the state of Oregon, then were able to look into this a little bit more, and they identified 2 other people who probably had died also in the intervening months from this therapy. And they looked further into it and found that these alternative practitioners, they were where these deaths were associated, were buying this colchicine from a compounding pharmacy. And those are pharmacies in the United States where they're not highly regulated, they're not big pharmaceutical companies, and you can contract with them to make a medication for you. And sometimes they have problems with infectious outbreaks. They're not as highly regulated, and then also sometimes with concentration issues. And ended up being that they got the vials of the colchicine that were actually being administered in that lot that they had ordered, and find out that they had 8 times the amount of colchicine that they were supposed to have. And we know that colchicine has a very narrow therapeutic range, and so that difference in dose, can potentially be lethal. And so because of this event, and again, this was in the early 2000s, the FDA had some rulings on this. And so they first made it so that individuals who were making intravenous colchicine had to stop. And then they were not allowed anything they had there with them. They had to stop selling after 180 days. And then after that, all injectable colchicine products had to be FDA approved. So compounding pharmacies were no longer allowed, just to kind of make it up on a whim and send it out, that they're going to have to be approved by the FDA and go into pretty rigorous standards. So this is an important point also as well, that don't assume that when you have an outbreak and you think it could be tox related, that what on the label is correct, right? So you need to really go there and you need to look at the concentration of everything they've been getting, and whether it's even mislabeled, and maybe they're getting something else. And so that's an important part. And do you guys still have IV colchicine available here in Turkey? Okay, so again, the FDA instituted this in the United States 2008. Before that, we could give IV colchicine pretty readily in the hospital if we wanted to for an acute gout attack, for example. And then in 2006, this is even before this outbreak occurred, colchicine, has been kind of, was never really FDA approved. It just got sort of grandfathered in because, as I said, it's been used for centuries, and just got kind of accepted as a medication without having to go under rigorous studies to get FDA approval. But 2006, FDA came up with this new process that they call the Unapproved Drug Initiative, so drugs that are out on the market. If a pharmaceutical company wanted to go and do the study to show that it was effective, then they would be giving priority over that medication, and so they'd be the only one then who could distribute it, and then thus they can set their price. Whereas if something's been there and approved or been out in the market for a long time, then smaller pharmaceutical companies that makes generics, can make the drug themselves as well, and that usually brings the price down. So then in 2009, a drug company in the US then did the studies and published it, and they got FDA approval for the oral colchicine. And then so since that was only got FDA approved, then no one could come and start giving IV colchicine because this is the only form that has FDA approval. So someone would, if they wanted to make a different form and have an IV, then they'd have to do that study to show it's effective, and then they get FDA approval to have it on the market. So that's since 2009, we don't have IV colchicine as well, which is fine. But then the problem is it went up dramatically in price, like over 2,000% in the U.S. It used to be pennies as far as a dose, and now it's not outrageous. I think it's like $5 a tablet, but still, it's the amount that it went up was was pretty dramatic. So as we said, colchicine, it comes from a couple different plants, from the autumn crocus and also from the glory lily, and it's been used for centuries to treat gout and a few other diseases. I know the ancient Greeks in this area used it, the Egyptians used it, so again, it's been used for a long time. And as we said before, the microtubular apparatus, through its mechanism, how it works, and then it makes it so the cells can't divide, and that's why initially we see the GI symptoms, bone marrow suppression, and then eventually multi-organ failure. Also has potential for a lot of other problems. Has a very long half-life, anywhere from 20 to 40 hours. It also, in addition to binding the microtubules, it can interfere with the cytochrome 3A4, and then also likes to bind to P-glycoprotein as well. So other drugs that are inhibitors of 3A4 or that affect the P-glycoprotein, can really wreak havoc with people who are on colchicine and can result in toxicity in them. There's been deaths that have been reported from as little as 5.5 milligrams of it in a cumulative dose, so we know it has a very narrow therapeutic range. And then also older adults, probably people have pre-existing renal and hepatic disease, aren't going to eliminate it as well, and the levels can build up and then result in toxicity and death. All right. The next case occurred in the opposite part of the U.S., so sort of in the northeast, most northeastern state in Maine, a town called New Sweden. And here you had a 50-year-old gentleman who attended his church services, and then frequently after church, so have some treats and, you know, coffee in the back where people can kind of mingle a little bit. And he went back there and, you know, had some snacks and started a cup of coffee. And then minutes later, he started feeling nauseated. Kind of told his wife, hey, I don't feel good. So his wife drove him home, and then as soon as he got home, he started having vomiting and diarrhea. And kind of toughed it out through most of the day, but, you know, was just feeling awful. And so that evening, he got brought to his local emergency department. And unbeknownst to him, you know, 11 other people from his church had also shown up to that emergency department with vomiting, diarrhea, and some of them had low blood pressure. So they all got, you know, kind of IV therapy. A few of them seemed to improve and were discharged. You know, but then about, you know, 7 of them, you know, did not improve that much. And so they decided that, you know, we couldn't let these 7 go. The infection control practitioner of the hospital, who was a nurse, contacted a division of the CDC that was there in Maine that had been set up only after a 9/11, when the states got kind of money to help with preparedness and some things like that. And so they you know, contacted the CDC Maine, and they talked about the case, and they had sent, you know, cultures on everybody, and then the CDC Maine said, all right, well, tomorrow we'll go to the church and see if we can get some of the, you know, things they were eating, et cetera, and kind of test them, see if we can figure out, you know, what's going on. However, these patients who remained at the hospital, several of them continued to get worse. They needed, you know, continued fluid replacement, and actually a few of them started needing to have pressors. 4 of them got admitted to the intensive care unit, and 3 of them were transferred that evening, kind of Sunday night into Monday morning, to a higher level of care at a referral hospital that was about 2 hours away, because again, this is kind of a small community. And then in the early morning hours of a Monday, an elderly patient who was like 78 years old died. And so when word of this you know, occurred, then this infection control practitioner recontacted the CDC Maine and said, hey, you know, we don't know what's going on. People are getting worse. You know, we don't think, you know, my physicians here don't think this is infectious because people aren't responding to normal therapy. You know, they're getting worse. And at that time, then the CDC Maine reached out to a local poison center, kind of trying to broaden their differentials. Like, well, maybe this isn't infectious. You know, that's what we think it is most of the time, right? When 12 people show up, you know, with vomiting and diarrhea. And so they contacted the poison center, and they discussed a differential about what could be going on. Any differentials on this case? Aconite, so aconite would be a good potential, yes. And where to get aconite from? Okay. Any other thoughts? So iron causes like GIs, okay. Vomiting, diarrhea, hypotension, okay. Okay, so certainly that one's there. Yeah, I mean, it's a really aggressive, you know, form of infection, invasive, and you know, one person died of sepsis. Okay, what about other metals? You said iron. Arsenic. Okay, so they this investigation then, you know, started going full throttle. Then that next day, they got some clinical samples and had sent them off for analysis. You know, the CDC, the health department went to the church, looked at the baked goods that had been consumed, and, you know, the things that were kind of there, you know, they looked okay. They weren't like moldy and looked contaminated, but they sent them. Maybe someone had somehow spiked them. And then a nurse back at the hospital had gotten more history from people and was being really diligent. What did you have? What did you have? And found out that everybody who gotten ill had drank the coffee. And then she reported that then, and that made the chain up the CDC, and so there was some leftover coffee that was there, and so they got that for analysis as well. Ended up being that it was arsenic on testing. that was in the bitter brew at this church. And so here's kind of a timeline of events that was in their publications. You can see that 12 people who presented. There actually were 17 total who got symptomatic. 5 of them toughed it out and just stayed home. You know, maybe they didn't drink as much coffee, they didn't get as bad. And then again, they made this call to the CDC then on that Sunday. And then on Monday, as we said, you had an unfortunate death. And the CDC staff arrived. And after they had talked with their poison center, the differential of arsenic came into there. And they had the antidote for arsenic, the BAL, mobilized and sent to the hospitals. And they decided to, appropriately, so high in the differential, to start treating them for arsenic before they got the laboratory test back. But then the subsequent lab investigation did, in fact, confirm that that arsenic, was the culprit here. And then you had to figure out kind of, well, who did it and how to get there. And then about 5 days after this event, a resident of the town wrote a note and said that he did it, and then he killed himself. And so that, don't really know the local politics exactly why he did this and what was his motive, but it ended up being that it was, a massive arsenic poisoning event. And so arsenic, is a water-soluble powder that produces a colorless, tasteless, odorless solution. It's been used for centuries as a means of poisoning people. And because before, we knew it was very effective, and people who wanted to murder other folks, that's why you'd have tasters. If you were someone high up in the authority that someone might want to kill, they'd let them taste it and see whether they get symptomatic first. But then we developed the ability to test for it then in the early 20th century. It's also a human carcinogen, so it can cause bladder cancer, lung cancer, skin cancers, several different types. And it's also a pharmaceutical. And so what's arsenic used as a pharmaceutical? Yeah, so for acute proliferative leukemia, and I think it's used also for, yeah. Okay. So it's a multi-organ, multi-cell toxin. Has the ability to injure the cell so that the cell decides to kill itself. It can induce cell apoptosis. It interferes with ATP production through the Krebs cycle, and that's why it's a multi-organ toxin. It can bind to a lot of different sulfur hydro groups, which are involved in a lot of enzymatic processes in our bodies. Again, that can result in multi-organ failure. It can substitute for phosphorus because it has a similar structure. The arsenic, the pentavalent does, and so that can shut down a lot of different reactions. And then it also can block, there are potassium channels, so it's at risk for causing a prolonged QT and causing torsades, and that can be what some of the immediate death is within the first 24 hours can be of a dysrhythmia. So there can be different types of arsenic poisoning, right? We're talking about acute here. There's also can be subacute, and then there can be chronic, where individuals who have it in their low levels and their well water, and then being exposed to it, like in Bangladesh, then can develop all kinds of adverse health effects from that. But with acute, you get a rapid onset of gastrointestinal effects. You get hypovolemia from capillary leak, multi-organ failure, cardiac dysrhythmias, encephalopathy, and again, it can be lethal within in a 24-hour period. Treatment involves fluid resuscitation, supportive care. You want to send testing for it, although you may have to make your clinical decision, based on your high index of suspicion, before you get that back. Initially, you can just send just collect some urine and send it off. We call that a spot. But arsenic secretion can vary a little bit, throughout the day. Usually, if you're acutely ill and got massive poison like these people did, a spot's probably going to be pretty good. You're going to detect it, but you want to send that first urine off right away, and then start a 24-hour collection of their urine, and then send that off as well. Since it can prolong the QT, you probably want to try to stay away from other medications that can do that, such as a lot of our antiemetics can do that. So you just got to be wary of that. And then again, if you have a significant acute ingestion that you're pretty sure about, because it's either an intentional suicide or it's just high in your differential, then you want to start chelation therapy. And the chelators that we have for this are British anti-Lewisites, or BAL, which is in the US, that's the only parental form that we have available for arsenic. It's available intramuscularly. It's hard to give Suxamer or DMSA if they're having a lot of GIs, right? They're already vomiting, having diarrhea, how much are they going to absorb? So we're pretty much left with BAL. And then once they can tolerate Suxamer orally, then we'll switch to that, because it's BAL can have a lot of different side effects. I'm not sure what chelators you guys have here. I don't know if you have DMPS or do you have BAL? Anybody know? So there, in a lot of countries, we'll have Unithiol, also known as DMPS, and that can be given either IV or oral. So that's a chelator that's available in Europe and several Asian countries. We don't have it in the U.S., and it's a compounding pharmacy makes it.
They have BAL in Turkey because we used it before for a patient in Georgia.
Okay. All right. Now our last GI case that we're going to talk about, again, occurred in last 2 decades ago, right, 2006. He had a 44-year-old male who said his name was Edwin Carter, and I got that in parentheses, and you'll see why. Presented to a hospital in the UK with vomiting, profuse diarrhea, and weakness. And this illness started, a couple days before in the evening of November 1st. He couldn't walk without assistance, and was having a lot of abdominal pain, and so he asked his wife to finally call in an ambulance. So he gets evaluated there at the hospital. He gets initial diagnosis of gastroenteritis. His initial blood test showed essentially normal platelet count. His hemoglobin and his white count were a little bit high. His bune and creatinine were a little bit high, and thought that, well, he's just kind of hemoconcentrated, a little pre-renal, so he's dehydrated. And he got started on Cipro for presumed gastroenteritis. Then he tells his providers that really his name is Alexander Litvinenko. And he happened to be a former Russian security, a member of the Russian security service, which is what the present name of the KGB is. He had defected to the West about the year 2000, and the day of his illness, he had met with a couple of Russians for lunch. And so, anyone familiar with this case? Yeah, so I gave it away. Litvinenko, yes. So broad differential now, right? I mean, as toxicologists, we love the Russians. They give us all kinds of new things to think about with carfentanil gases and ricin pellets and now in radiation. So, masters. Over the next few days, his blood counts started to fall to abnormal levels. And this obviously brought in a lot of concern as far as what's going on with this. Why is his blood counts getting lower? That he's getting leukopenia, low platelets. And so his wife asked his attending physician or consultant physicians whether this could have been results of poisoning. And he happened to be a pentathlete as well in his earlier days and was still quite athletically vigor. But the attending at that time told her the symptoms were common, and an infection, that poisoning was not likely. A new consultant kind of took over the care then after he'd been there for about 10 days, and they continued to try to look for additional causes of what could be going on. They contacted the poison center, poison unit there in the UK, and discussed a potential differential. Dr. Victoris, this new attending, had thought that all this bone marrow suppression was going on, was kind of familiar to him and patients that he had previously taken care of who were getting intensive chemotherapy for their cancer, and then also getting total body irradiation, prior to having a bone marrow transplant because they had like leukemia or something like that. And so he became really suspicious of that. And then so he talked with his radiology department about you check for radioactive sources of poisoning, and they came up with their Geiger counter and kind of went over everything and didn't get any activity. And then he started losing his hair. And so when he gets his alopecia, then that kind of made them expand their differential a little bit, especially it made them think about thallium, because when we think about a toxin that can cause alopecia, hair loss, then certainly thallium kind of rises up in the differential. But when we think about thallium poisoning, I mean, you do get GIs. Is this going to play? How do I get that to play, Ziad? Do you know? The video? No mouse? Okay. So you do get gastrointestinal, effects. You get alopecia, which he had, but then you also get usually a really painful peripheral neuropathy, which he did not have. You usually get encephalopathy, but he did not have that. And it also does not cause bone marrow suppression, which is what was, really remarkable about this. I mean, his ANC, was below 500, and even, lower. And so it didn't exactly fit, with that. So then they started thinking, well, could he have gotten radioactive, thallium? And, we give radioactive thallium, right, for our cardiac markers, right, when you're getting a thallium test on somebody. But it's just a little bit of radiation. So they're thinking, well, is it possible that somehow they could give him this massive amount of radioactive thallium, and that's what caused it, because we're not detecting, any radiation, on him. And so that was kind of in their differential. Yeah. Sure. It's a video that Ziad had found.
Actually, yeah, can you play the music? So this is actually, I want to spend the back.
Sure.
This is a video that was made by Syrian doctors in refugees in Lebanon when there was a family that was poisoned with thallium in cookies.
Oh, I didn't know that.
Died, and about 20 people got affected.
Mm.
It's a sad story because the mother who did not get affected was because she did not want to eat. She saved the cookies for her children because of the hardship in Syria. And she survived, and she is not safe.
Wow.
So they made this video on their own to raise awareness about this. Can you please click it?
And so they decided to go ahead and start treating him for thallium and give him the thallium chelator Prussian blue. This case, maybe this was some sort of weird thallium isotope that they weren't aware of that could have resulted in the adverse health effects. Even though his thallium level, he had one level that came back just like a little bit high, and then a subsequent level came back that was nothing. But they decided to go ahead because they really didn't have much else at that point to offer him. Then he got transferred to a higher level of care when it became more and more apparent that this was probably some sort of poisoning event. He got placed under armed guard. The investigation got transferred to Scotland Yard's counterterrorism. And then they started looking at taking more samples and then taking it to higher authorities as far as looking for radiation in him. He ended up dying then on November 23rd, and just right before his death, they ended up finding that he was poisoned with polonium. a radioisotope, which we'll talk just a little bit about. And so polonium is a little bit different in that it emits alpha particles. And alpha particles, again, this is intimidating for me talking about radiation when I got one of the world's experts here right beside me, Dr. Kazi, but I'm sure he'll correct me if I'm wrong. And so alpha particles are not really, don't penetrate very well. So like even a piece of paper or your skin can stop alpha particles. And Geiger counters are not set up to detect alpha particles. So they're looking for gamma radiation mostly, and they emit very little gamma radiation. And the thing about polonium, it also is only produced in significant amounts in state-regulated nuclear reactors. So it kind of tells you that it was some sort of a government or state-sanctioned to be able to someone get that polonium and then be able to give a toxic dose to somebody. And so what had happened is that the investigation revealed that it was probably at a restaurant that he went to with these two Russian agents, that they had sprayed the polonium into his tea that he was drinking, and that he consumed it then, and then that internalized it. And so it became internalized, and so that's why he could still get the effects from the radiation because it absorbed into his body, as opposed to, normally it wouldn't be able to penetrate even our skin. You want to play this video too?
Some type of radioactive material, he or she can be exposed to the radiation emitted by this source. However, he or she does not become contaminated. One way to think about exposure is to think about X-rays. When a person has a chest X-ray, he or she is exposed to radiation, but does not become contaminated with radioactive material. A person can reduce his or her exposure to radiation if he or she is shielded in some way from the radiation. For example, if the person is behind a concrete wall, or if the radioactive source is inside of a lead container. In order to become contaminated, radioactive material must get on the skin or clothing or inside of the body. For example, if radioactive material is incorporated into a dirty bomb, a conventional explosive such as dynamite that has been laced with radioactive material, then people could become contaminated when the device is detonated. Radioactive material on the outside of the body is called external contamination. When a person becomes externally contaminated, simply removing the clothing can remove up to 90% of the contamination. Gently washing the skin and the hair can remove most of the remaining contamination. If a person ingests or inhales radioactive material, it can become incorporated in the organs of the body. This is called internal contamination.
This is what happened to him.
When a person is internally contaminated, depending on the type of radioactive material with which they were contaminated, certain medications can be administered to speed up the rate at which the radioactive material is eliminated from the body. Such medications include Prussian blue and DTPA.
So, the aftermath of this, one of the things they were able to find were 3 distinct contamination paths. One was Limvincto, where he would go, he probably still had like someone's mouth and had washing his hands and then, was touching things, was contaminating this with the polonium. And then also these 2 Russian agents, that wherever they had gone, they thought that maybe they didn't know what they were actually carrying. It seemed like what they were was leaking. They think that they actually had tried 2 other times to poison them, but it just didn't. They didn't have the right scenario to do it because they found it in other hotels that they had stayed at, in previous visits, like the month before to the UK. And they found it on the airplane. They found it again in their hotel rooms, the restaurant where the poisoning occurred. And so they're able to link it to these 2 guys, quite readily. And so this became, a public health problem, and they had to look at the people who were taking care of him in the hospital as well, because they were potentially getting exposed, to radiation, and had to do all those assessments. But in general, they thought that no one was going to have a significantly increased risk of adverse health effects, from this. The Kremlin and Russia, denied all accusations that they were involved with this, and then has refused to do extraditions of other citizens for trials. If there's going to be a trial, it's going to have to be here in Russia, and so nothing really developed from that. Any questions about this case or any of the cases? I think we'll probably stop here then. Okay. Yeah.
Even if it was detected early, would it be treated?
I'll let you answer that.
It's inevitable death, I think.
So I think polonium, there's no treatment for it. There's some mice studies looking at BAL, but the dose he got was lethal. So there was no way. So he had a very super lethal dose of radiation exposure.
The effect of the contamination where the spies went and where he...
So there were 28, so I'll tell you about the healthcare providers. There were about 28 healthcare providers who took care of him using just level D PPE, using standard precautions. And they measured urine samples on them to see if they've internalized any polonium, and they found nothing beyond the usual background levels. So that was good. And whatever levels they found, they were higher a little bit in the janitors, who are basically cleaning the trash can or changing the sheets, and the nurses. The least exposure was on the contamination was on the doctors, because probably they are the least contact with the patient. So basically, they found some levels that were within accepted occupational limits. Nobody's had any issues. There were about 150 or 200 U.S. citizens that happened to be in these areas that ended up being tested in the U.S., and they were fine as well. So.
Yes.
I have two questions. First one, the colchicine oral, will this same effect of the IV colchicine?
So usually it's going to take a larger dose, but yes, it can have the same adverse effects. So the early GIs that you get, from getting too much colchicine, may limit the amount that is absorbed. So it can be a little bit protective, but if you get it IV or IM, you're getting 100% absorption, so it's certainly a more lethal route. But what oral can certainly cause death.
To radiation? To radiation?
Radiation, chemicals, medication, IV, but there is no symptoms at all. Is there any role of emergency department or toxicologist or labs? Is there any specific investigation that we can do to discover early before the symptoms come?
That's a pretty broad question. It kind of depends a little bit on what you're suspicious, of. And he comes in and he thinks he's just poisoned because he's a Russian agent, and I know they made me just drink this stuff, right? No, I mean, that's.
I had similar things.
How did you handle it?
We contacted the labs, and we did all the investigation that we have in the world, because he was a high-level guy. But I'm asking now in the future.
Yeah, if it's an acute ingestion, you could think in your mind, is there something I could do to prevent absorption? So I'd go down that pathway. Do we think that charcoal, something like that, could help somebody, like that?
Radiation is easy. The radiation is easy because you can detect it with the Geiger counter. The trick here was that polonium was a unique alpha emitter, but if he ingested cesium, you can just wave a radioactive. You can wave a Geiger counter on the stomach, and you can. Metals are, metals you can do like a 20. Typically, when people come to us with these complaints, we do a heavy metal 24-hour urine collection for heavy metals.
Yeah, so there's no magic kind of like test to screen for everything. So you can have certain panels that you wanna order based on symptoms usually. I don't know if NMS has, there's a lab in the US, National Medical Services, that we send a lot of our tests to, and they have a lot of panels that by cluster of symptoms you can send. I don't know if they have a homicide panel that you're aware of. I wouldn't be surprised if they do. If they don't, they're very, very creative and very good. But again, you're kind of telling them what you want to test for. So if you have someone who comes in with a sympathomimetic toxidrome, you can kind of tell them that, and then they have a panel of tests to look for, cathinones or bath salts, amphetamines, cocaine.
Yeah, you have to have some symptoms.
Yeah, you have some symptoms, or where they work, or so because we have a clinic where we see people, and we see a lot of people who are what we call worried well, and they think they're being poisoned with something, and so you kind of talk to them about it and what a differential is, and then you decide whether you want to send something based on what their symptoms are. But if you're thinking about poison with the Russians, I mean that's a broad differential.
All right, thank you, Dr. Morgan.
Yeah, great questions.
All right, so let's take a break.
Okay, a bit too high. Lower it a little bit. Okay, so the next cluster we are going to face together is the cluster of skin problems, which is probably the least favorite of emergency physicians. Emergency medicine doctors, they don't like skin problems because we don't know enough about them, and we just want to send them home and have them follow up with dermatology. But I am going to try to go through this with you and see what we can do to look for potential CBRN exposures that lead to skin problems. This is a real case that we took care of when I was an intern in Atlanta, so this was not my case. This is a patient that came to our ER. I was there. I happened to be working in the ER as an intern. He was Spanish speaking, and he said he has this hand. This is what happened to his hand. And he was hurting, and literally he came with this hand. He wouldn't tell us, what's going on. He said that we asked him, did you burn your hand with a fire? He said no. Did you burn your hand with electricity? He said no. Did you, crush it with some trauma? He said no. He refused, he denied all of this. We said, did you put your hand in an acid or a base? He said no. Now, he was a janitor at Georgia Tech University. Now, at the time, I was not, sensitized to CBRN, or I didn't have, but my colleague, Michael Schwartz, who's a toxicology fellow at Emory at the time, he was a very smart man. He was very clinically solid, and he suspected that this could be a radiation injury, because this person works as a janitor at Georgia Tech University where they have radiation sources. So he thought maybe he handled a radiation source, and because of the delayed onset of injury from radiation, forgot that he touched it, and now he has the radiation effects. And he was very astute about that, so he called the FBI, the Federal Bureau of Investigation, Georgia office, and they went to the Georgia Tech University and did a radiation survey looking for potentially the source on the floor or in a trash can. And they could not find it. They could not find anything. But they published it as a case, as how they investigated this. The patient had to have a finger amputation, like hand ray amputation, and recovered. And it turns out that he actually was lying to us. He was actually an electrical injury. He was stealing copper wires from the rail and got electrocuted. But he did not want to say that because he was stealing it. But I like this case a lot. I've used this case every time I talk about this because it really highlights the importance of maintaining a broad differential and getting a good history, which Michael Schwartz did in this case. He asked the person, where do you work? He knew it was Georgia Tech University. He realized the university, like Georgia Tech, does indeed have radiation sources. And went to the differential of biological, chemical, radiological, and thought about radiological. If you don't do that, the agent-host environment, you will miss things. That's just a tool for us to retrieve information from our brain. And that's what we're going to do today by looking at the skin together. The skin has the epidermis, the dermis, the hypodermis. The skin is important for us for many reasons. It protects us from multiple factors, toxins, bacteria. It can also keep heat in our body, keep water in our body. And when we lose the skin, we lose all these protective functions. Now, there are burns that affect the integrity of the skin, but there are also rashes that, although may not necessarily cause a significant skin deficit, but they will have skin manifestations, okay? The differential is really broad, guys. It's really broad. It could be an infectious disease, a thermal burn, an electrical burn, a cold-related injury can cause a skin damage. An allergic reaction, so an immunologic process can cause skin damage. Or chemicals can do that, and don't forget radiation. And we will go through these different scenarios and appreciate what is common or what is different. Let's think about the biological question a little bit. You know, here we are looking at usually rashes, okay? And we are looking at potential causes for these rashes, okay? If not a rash, sometimes you see maybe a lesion. You can see a lesion, which is kind of a rash, but it's more like isolated or specific. And we have to think about what potential causes for these rashes. You know, bacteria, for example, you know, are definitely an important cause of these rashes and lesions. Plague is a good example. Anthrax is a good example. Tularemia. These three agents, which are category A biological agents of concern, cause skin manifestations. When you think about viruses, of course, many viruses cause rashes. The ones that are concerning, for example, smallpox, viral hemorrhagic fevers, okay? Viral encephalitis type infections, all of these can have some rashes with them. Now, toxins, on the other hand, like ricin and botulinum toxin, do not cause rashes. Toxins are less likely to cause rashes, except, for example, if you're thinking about a botulism case where you have a wound infection from somebody who's injecting drugs or some other type of wound, gets infected with Clostridium botulinum, like you see on the slide, they can create a toxin. Now, poison ivy is an allergic type dermatitis, so we got to talk about that a little bit. That's a good question, good point. So you need to appreciate the shape of this rash. Is it macular, papular, vesicular, ulcers? And also the pattern of spread is very important in infectious rashes. You know, a chemical rash is not gonna spread in a centripetal or centrifugal fashion. Infectious processes will do that, and you have to appreciate that. And patients with a rash from an infectious process or a skin manifestation of a rash of an infectious process usually have some sort of other associated complaints. They're usually in incubation period, of course, that's tricky, where people may or may not be infectious, where people may or may not have any symptoms, and may be several days and may vary from one person to the other. Plus, you have to think about the sick contacts that have been involved as well, so asking history about other people that have a similar rash. These are clues to take you down the biological path. So follow these clues, ask about them in your history, ask about the sick contacts, ask about the recent travel history, what's going on in the world, are there other infections that are ongoing in the world or epidemic or pandemics? Does the patient have any prodromal symptoms? You know, do they have other symptoms like fever, headache, sore throat, runny nose, myalgias, arthralgias? So when you go through this history and physical exam with the patient, if you find these, then you ought to be thinking more of a biological cause for the illness. For example, smallpox. I love smallpox because it has a beautiful type of complex of prodromal effects, incubation period, and rash. The incubation initially is 7 to 19 days, but the average is 10 to 14 days. this is the incubation period. And typically, during the incubation period, patients are not contagious. Okay? Then they develop some non-specific symptoms for 2 to 4 days. That has a very high fever, head and body aches, occasionally vomiting, and they could be infectious in this time, but not as much as when they actually have the rash show up. The rash has an early phase, which is about 4 days, and here you have these small red spots in the mouth that disappear, leading to the rash, these same type of red lesions all over the body. And they actually start on the face and spread on the arms and legs, and then the hand and feet. The important thing about smallpox rash is that it rapidly spreads all over the body, and then when the rash shows up, the fever starts going away. The other thing that's important that you see on this slide is that all the lesions are at the same stage. So remember, this rash spreads rapidly from the mouth, disappears in the mouth, and then the body quickly, and they're all together like a symphony, like an orchestra. This is different than what other infection? Chickenpox. Well done. The second phase, the 10 days phase, is where you have the pustules and scabs. Again, all of these phases are infectious, or contagious, and the contagiousness, that's a good term, the contagious period goes away as your rash scabs off and then goes away. So typically by the end of the second week, after the rash appears, most of the sores have scabbed over and you're no longer contagious. And some pictures, historical pictures of smallpox rashes from the CDC website. 1978, I think, is the last one. And we hope we don't get new ones, but we have to be alert, and we have to differentiate a smallpox rash from the chickenpox rash. You see here, there's no orchestra. The next example I want to talk about is plague. Plague is Yersinia pestis. It's a category A agent of concern. And it's interesting because the rash is a little bit different. It's no real rash. It's not a rash per se. The most common form of plague is bubonic plague. And you can get it by a rodent bite or an infected flea. And the bubonic plague is the most common. And you see those buboes, they call them buboes, in that groin area. So if you see something like that, you must recognize it. If you see that, you should look at it and say, okay, this looks like plague. This is a bubo. And if you see the fingers with these kind of emboli, this is septicemic plague. The interesting thing about plague is that it's not transmissible from one person to one person except one condition. Which one? Pneumonic plague. Pneumonic plague is transmissible, but bubonic plague is not. You have to be exposed to it from the tick, the flea, the affected flea, or the bite from the rodent. Tularemia, on the other hand, is different because it does not have a person-to-person transmission. Tularemia is due to Francisella tularensis, and this is basically a bacteria, and you get it by handling contaminated animal tissues or fluids, or by the bite of an infected deer fly or mosquito or tick, or with direct contact or ingestion of water, food, or soil. The classic scenario here is a hunter that, for example, killed a deer and was working on getting cutting off the meat and skinning the deer on their own, and they get a little cut in their skin or something, and they get infected. And again, no person-to-person transmission. So taking a history about what they do, not just occupation, also hobbies, may take you down this route. And then when you look at the lesion, though, here, it will be a little bit more challenging than plague. Remember, there are multiple forms. There's intestinal, pneumonic, typhoidal, and the cutaneous lesions. The lesions are tricky because they're not, they're not like a rash, and they're usually ulcerative, typically. So you see here a papule on the left upper corner. On the right corner, you see how it ulcerates. One hint in tularemia is the glandular disease. So it's an ulceroglandular disease. And the gland behind this person's ear on the neck would be a bit more typical and will give you a hint that this is tularemia. But if you don't have this gland, really you're just looking at an ulcer on the body or a papule. Anthrax is another important rash or lesion. This is Bacillus anthracis, and it evolves from a vesicle to a pustule to a necrotic ulcer. And it evolves over several days, over 15 days. It is also associated with surrounding edema and erythema. So when you see that, erythema, edema, with the progression over 2 weeks, you have to think of anthrax. Also, you have to think of anthrax when you do a chest x-ray and you find a widened mediastinum, for example, in somebody who has an infection, because it causes mediastinitis. And potentially cutaneous anthrax will have these necrotic ulcers. And I've pursued this in my career. One time, I had a patient that had like this lesion that was still early. It was more like a pimple, kind of pustule. And the reason why I pursued it, not because of the rash, I pursued it because he came in with a respiratory illness, and we scanned his chest. And the CT scan result said that he had a widened mediastinum and some mediastinal lymph node enlargement. I asked him what he did, and he told me he's a farmer. So I got all excited. I said, perfect, I got my first anthrax case, I'm gonna be famous. But I asked the question, farmer, maybe horses, got some exposure to the horse or, cow. This is in the US. But again, it wasn't, so I was wrong. It wasn't anthrax. It was just another cause of mediastinal lymph node enlargement, and that pimple was just a pimple. But you have to be aware of what's in your environment. In Georgia, Republic of Georgia, for example, anthrax is common. So you have to be alert to it depending on your environment. I don't know about Turkey, if you see anthrax cases in Turkey, natural anthrax with cutaneous or pulmonary. So it depends where you are in the world. You do see that? Yeah. We see a lot of anthrax cases. I'm just kidding, but they're actually brought to our attention as brown recluse bites. The brown recluse is a spider in the US. It's also potentially around the world too. But the brown recluse is a recluse. Recluse means a shy spider. I don't know why they accuse the spider of running around, biting people. But they come to us and say, I've been bitten by a brown recluse. And again, the brown recluse will cause a lesion similar to the cutaneous anthrax. So that's another part, the similarities to cutaneous anthrax, brown recluse, and also nowadays, methicillin-resistant Staph aureus infections. And the ones we see in Atlanta, they come and tell us, oh, this is a brown recluse bite. Most of these end up being a Staph aureus infection. But they accuse the poor spider. So what I usually say, did you see a spider? If they say they haven't seen a spider, I say, okay, it's Staph aureus. Well, they cause bites, but not as common as you see these Staph aureus infections. So it's difficult to differentiate, whether it's a spider bite or it's anthrax, etc. But this one is actually an anthrax because you see the necrotic ulcer and you see the redness and erythema and swelling around it. This is more typical of anthrax than a brown recluse spider bite. But again, the differential here is really broad. And this is not meant for you to read it, but just want to show you how broad the differential of these type of lesions is. So moving away from the biological area, let's think about other causes of more severe skin damage, that basically tissue loss, what we call a burn. The burn, again, it could be thermal, could be electrical, right? It could be radiological. It could be allergic. It could be cold-related. All of these can cause tissue loss and a burn. The burn usually is assessed in terms of its depth and its size. The depth is important because the deeper the burn, the more vital structures are lost in the dermis, epidermis, dermis, to the hypodermis. And the deeper you get and you lose more of your hypodermis, you lose your stem cells that are supposed to come back and heal the burn wound. And that means a deep burn will not heal and will require a skin graft. Burns that are less deep, more superficial, they can heal. with potential for contractures sometimes, but they may be able to heal because they have enough stem cells in there. The size of the burn is important as well, because a large burn is going to cause systemic effects from fluid loss, heat loss, risk of infection, and even systemic effects on the lungs, on the kidneys, and protein wasting that can happen from these large burns, let's say 20% body surface area and above. Finally, the burn depth will also affect whether the burn is going to be insensate, where you lose sensation if you lose the sensory nerves, or not. So this is the example of a superficial burn, or first degree. There is no tissue loss, there's tissue inflammation. The cells are angry, that's why it's painful, but the cells are not dead. It's a transient situation, transient injury or stress on the cells. The partial thickness burn, here you have some loss of dermis, and here you have to think about how deep it is. It's very painful because the sensory nerves are injured, but they're still there. It's wet because it's got all the cell content is leaking, and it can actually get infected, and it can also produce loss of water and heat. The full thickness burns are usually insensate because you've lost the dermis, and now you're actually deep, and you're gonna actually develop contractures, and you're gonna need grafting. The burn itself is pale because it also lost the capillaries. And the best way to detect a full thickness burn is to look carefully at the erythema. If it's red, it's not full thickness. If it's pale, it's full thickness. If you get a probe and you touch it, if they don't feel it, it's a full thickness burn. Why it's important to differentiate that again? Because of the prognosis. A full thickness burn is going to require a graft. Now, the electrical exposure can cause burns as well. Remember that. And those burns, though, are interesting because, for example, the electrical current can produce heat. The heat can cause the thermal burn. But then deep, you also have the electrical current causing deep tissue damage that is not visible to the outside. This is a guy we had in Alabama when I was in UAB in Birmingham. This man has thermal burns and has electrical burns. You see, you see the current on his chest. This is the one of the wounds of the electrical burn. And what on his back is a thermal burn because his clothes caught fire. Okay? And here you have more issues to deal with because you have rhabdomyolysis from the muscle damage, kidney failure, compartment syndrome, many other things here beyond just thermal burn issue. So he had all of these together, unfortunately. He was a mechanic and then got electrocuted. Cold weather can cause tissue loss as well. So, you have to ask, were you exposed to a cold environment? Cold and wet environment can lead to these frost bites. Okay, this looks like a burn to me. Could be also a thermal burn would look like this. One is hot liquid, the other one is cold environment. Or chilblains. Chilblains were basically, in some people, they have exposure to a wet, cold environment. They can get this reaction. This is a woman there on the right, I think who she had her feet in an ice bath, caused this chilblains. Or frostnip, which is a very minor, early response to exposure to a cold environment that can eventually lead to beyond that, to more deeper burns like a frostbite. So as you see, a burn can be due to all of these. And you have to go through the thought process of what could it be in this specific patient. And you gather clues from the temperature, from the history, and they'll tell you, yes, I spilled some hot liquid on me, or not. And remember our guy Grady, he denied being exposed to electrical current. He denied being exposed to hot liquid. He denied being exposed to chemicals. Is he allergic to something? Unlikely to cause severe manifestations. Usually contact dermatitis, like this one that Ala mentioned earlier with the poison ivy or poison sumac or poison oak. They cause these typical rashes that are kind of like a linear a little bit with pustular. And yeah, potentially there's a history. Sometimes you don't have a history because people don't remember being exposed to the plant. Or sometimes their pet is exposed to the plant, and then they rub the pet and they get it on them that way. And these are annoying rashes because they're very pruritic and they are tough to get rid of. And they're due to this substance called ursochiol, which is in these plants. Don't forget about chemical exposures to metals, like nickel allergy will cause that. Somebody on their belt buckle area will have the allergy, or on their watch. So the location of the rash can give you some clues as well. And allergic rashes can be severe with erythema multiforme or even Stevens-Johnson, and those require a burn care. A Stevens-Johnson case will require to be at the burn center. Chemical burns, on the other hand, are going to cause a more burn-like picture, like a thermal burn. And chemical burns can be liquefactive or coagulative. What does that mean? Liquefactive is the chemical digests the tissue as it penetrates deep. So you have deeper and deeper liquefaction of the tissues. An example of that is bases. Bases can do that. Acids, on the other hand, they cause a coagulative burn because as they contact the skin, they cause a coagulum. And the coagulum crusts it off and kind of stops the deep penetration of the liquid. Okay? So acid versus base, coagulative versus liquefactive. Bases are usually deeper in their reach than acids. Now, we think of chemical burns from acids and bases, but that's not the only way you can burn the skin with a chemical. Think about sulfur mustard, think about lewisite, phosgene oxime, particularly sulfur mustard and lewisite. They are not acids or bases. That's not how they cause the damage. And I shared with you yesterday some of the mechanisms that the way they do it. For those of you who did not attend the lecture yesterday, current understanding of lewisite mechanism of action involves genetic changes, so genetic expression changes from the lewisite that lead to the unfolding of proteins, and the unfolding of proteins causes the clinical manifestations. And the way you stop that is potentially by preventing the unfolding of the proteins. And there are some countermeasures that are being developed to do that, but an old countermeasure is cold water. This is why when you burn yourself, you put your hand on the cold water, the cold temperature prevents the unfolding of proteins. That's why it works sometimes, limiting the size of a burn when you stick your hand under cold water. So vesicants, again, like sulfur mustard and lewisite, are going to cause burns, and they're not acids or bases. And the burns from chemicals usually are immediate. Okay, usually they're immediate. The delay in the onset is not typically a chemical burn. Okay? Radiation, on the other hand, is a classic example of a delayed onset burn. So anytime you have a delayed onset burn, think radiation. Most of these chemical burns are local in their effect, although some have systemic complications. Classic example is what? Hydrofluoric acid. It causes a chemical burn and it causes systemic effects. We also have special cases that we know as toxicologists. A yellow burn. A yellow burn. What causes a yellow burn? Which acid? Nitric acid. So, white phosphorus is a special case. I mean, we have some special chemicals too that we need to know about. This is a guy I had in Grady. This is a sulfuric acid battery. So he, I don't know, messing around with the battery, he splashed him with sulfuric acid. And the reason why I show you this is you see the crust. I don't know if you can see it. See the crust on his forehead? This is the best example I could find of coagulative necrosis. That's a close-up. And you see it looks like a thermal burn, right? What's the difference between this and a partial thickness burn? But the history here is important. And of course, you have to look at the eyes, because the eyes can also be affected. and you have to irrigate those eyes when this happens. And this is the guy that he did well, and that burn on his forehead is really managed like a thermal burn. There's nothing else you got to do. So we don't do much toxicologists with this. You don't need a toxicologist for this case. All you need from me is to tell you that what is the pH maybe, or what is, they call us to find out what the chemical is, because we have the resources, we can look it up online. This, on the other hand, is a deep liquefactive burn. This is a patient of Dr. Morgan when he was in Charlotte, North Carolina. And you see how the beefy red liquefied burn on her face. Now, on the other hand, hydrofluoric acid, as we said, is going to cause systemic effects. It's not a great acid in terms of the burn itself. I mean, the burn itself is not that bad. But the pain is very severe. Why is there so much pain, Ala? It goes to the bone. It's in the bone. So fluoride ion is small, so it penetrates. The acid is not the main issue in hydrofluoric acid. It's the fluoride and the bone causes hypocalcemia, as you said, and hypomagnesemia. And then you complicate the whole picture with hyperkalemia. And hyperkalemia leads to the cardiac arrest. And of course, hypocalcemia can lead to torsade de pointe. Torsade de pointe or polymorphic ventricular tachycardia. And the management is what? Calcium, calcium, calcium, depending on the severity of the lesion, of course, and the route. You can pick intradermal, intraarterial, intravenous, depending on the severity. Topical, on the eye, by nebulizer. It really depends on how severe the case is. I've never seen a very severe hydrofluoric acid case. The ones I've seen were more from low concentration hydrofluoric acid in the 10%, 15%. And they typically have pain. And the way I manage those is by either topical, if I can get away with it, but it's hard to get away with it. Most of the time, they keep having pain and they don't feel better. So you have to do the intraarterial calcium gluconate. If you have finger burns, it works really well because you insert an arterial line, and like you see here earlier, and then you intraarterial line, and you give calcium gluconate. Don't give calcium chloride intraarterially, calcium gluconate. And they do really well with that. And the last case I had a few years ago, the guy came twice to the ER, and I felt bad. I was like, okay, I'm done with this. I'm going to just put the arterial line, because we tried to do the topical stuff. We put some topical, we sent him home, he came back the next day still feeling bad, and we put more topical, taught him how to do it better, and he still came back the next day, and finally we did the intraarterial. Yes. Yes. And also remember, the hydrofluoric acid may be under the nails, and who wants to pull nails? Do you really want to pull the nails? I pass out if I'm pulling a nail. But you have to, you start wondering, do I need to pull the nails? And so that's why intraarterial is better. But, we had to admit him to the ICU for this intraarterial. I tried to put him in the observation area, but they refused. So I had to put him in the ICU for this. I was trying to avoid this whole process, but, eventually that's what I needed to do. No, so that's a great question. So Bara is asking what's the difference between calcium gluconate and calcium chloride. Calcium chloride per ampule gives three times as much calcium per ampule as calcium gluconate. So if you have crashing patients who you need to give calcium quickly by amp, give chloride. But chloride, if it extravasates, it causes tissue necrosis. So you must have a nice IV, 18 gauge anticubital fossa, probably placed IV, and you can give it, or central line even better. Calcium gluconate you can give intradermally, if it extravasates, it doesn't cause any problems, but it has less calcium per ampule. And calcium gluconate you can give intraarterially as well, not calcium chloride. Okay? So moving along to the other types of burns, let's think about some of these blister-forming chemicals. The king of that is what? Sulfur mustard, the king of World War I, causing the largest number of injuries in World War I from the chemicals is mustard, more than chlorine. The issue with sulfur mustard, though, is that it has a relationship with ambient temperature. So first of all, if it's hot, like it was in Iran and Iraq war, it can evaporate and cause more pulmonary effects than it did in Europe in World War I, where the temperatures were colder. It also has a freezing point that makes it vulnerable when in low temperature environments. So you cannot really use it through aerial dispersal or aerial bombing in the cold environment. So that's why they added to it other chemicals such as lewisite. Okay, that's why, for example, the Japanese added lewisite to it when they were using it against China. The good news about it is the mortality is not very high. It's about 5%, 3 to 5%. But the bad news is that patients are going to be sick for a couple of weeks, 2 weeks to 4 weeks, and then that means they're going to be occupying a hospital bed. They're going to be requiring care by a nurse, by a physician, and they will not be able to fight for that period. The toxidrome of a vesicant is, of course, the skin blister, but also the eyes and the lungs. They don't all have to come together. A few years ago, or maybe either 1 year ago or 2 years ago, I got a call from a colleague in the Republic of Georgia. He actually sent me he called me at like 4 in the morning. And I was like, why is he calling me at 4 in the morning? I was awake though, because I was going to a race. I wasn't racing, I'm not that fit. I was going to a medical tent for the race. It was July 4th. We have a race in Atlanta on July 4th. Then he sent me a message on Viber. He says, hey, can you send me some stuff about sulfur mustard? I was like, why is this guy asking me about sulfur mustard at 4 in the morning? So I called him. I was like, what's going on, man? He's like, we have sulfur mustard cases in Tbilisi. I was like, what? It was workers at an airport that saw a leakage of liquid in their kiosk. They have a travel agency kiosk. And I don't know, somebody maybe touched something. We didn't have all the history. But this doctor had in his ER 2 patients, and then the 3rd patient was at another ER. And then, of course, a total of 11 patients presented by the end of this process. They were not injured, but they were concerned, so they came in to be checked out. And those patients that he had this very small pimple on his arm, very small, like less than half a centimeter in diameter. The other guy that was in the other hospital had a bigger lesion, bigger pimple. And it's interesting, they were exposed the day before. So this thing happened on, so July 4th was when he called me at 4 in the morning, which was afternoon in Tbilisi. These guys were exposed the day before on July 3rd. Okay? And they didn't develop symptoms till several hours later. One of them developed some eye burning. Okay, some eye burning, conjunctivitis. Then he developed the pimple. None of them had respiratory effects. Probably because the amount was very small, and which is reflected in the size of the blister. You know, the larger the blister, the more likely you had a large exposure that's probably causing respiratory effects. Typical symptoms. And I said to him, this is sulfur mustard, classic. And he had found out because actually they found the bottle and it said on it Ipperite. And he's like, what is Ipperite? I said, Ipperite is Ypres in Belgium, the first place where the chemical weapons were used in Belgium. And that's why they call it Ipperite. Anyway, so that's the long story short. They did okay. Those 2 patients did okay. They had a classic progression of their lesion into the rash. And in a little bit, I'm going to ask Dr. Ala Mohsen and other Iraqi colleagues, Dr. Hammoudi, to talk a little bit about their experience in Iraq. And we have some slides from Dr. Ala Mohsen who shared them with me that will show them. But this is interesting about the mustard, the progression. Now, lewisite was made to cause more immediate effects. Okay, but we don't have a lot of experience in lewisite, unfortunately. Well, fortunately and unfortunately, because it was really never used in a battlefield, but it was more in the lab when we have a couple of case reports. But look at these blisters, how they are, again, like a thermal burn. You know, this could be a thermal burn. This could be a chemical burn, like an acid or a base. And eventually, as they heal, they have changes in the pigmentation. They can be hypopigmented, hyperpigmented. These are pictures from the Borden textbook of military medicine of Iranian, most of these are Iranian casualties. Now, this is from Ala. Ala, you want to share with us a little bit? Can you come up here? So they can hear you well. Do we have a microphone, please, for the... you have a microphone, like handheld? Oh, you can just go up to the... tell us about this guy.
This is one of several people who came to the ER, but this was on the field.
Yeah.
Okay. Anyway, good morning.
Dr. Ala Mohsen is an emergency physician and CBRN expert from Iraq. He's currently in Muscat.
Thank you. Do you have the other picture or just this?
Maybe one more.
We had several cases coming to the ER in Baghdad Teaching Hospital. We have several events of mustard chemical exposure in the war against ISIS from 2014 to 2018. This is one of the people who was decontaminated at the field, and you can see two sides of blisters on his shoulders. He carried an object which is
leaking.
It was contaminated with mustard particles or mustard
liquid
debris, and immediately this is the second day, I think, because you can see he was I think he was a civil defense officer.
And remember, it goes through the clothes. It can penetrate through clothes. So he could have been wearing something and still the liquid seeped through the clothes.
We found typical, the first presentation was that they all had respiratory problems, especially the people in, I think Dr. Hussein had more experience in that in Taza, because he went in the field at that time. The first event was in Taza, 2014. And then after that, several attacks appeared in different parts of Iraq, especially in Mosul. Typically, they start with respiratory problems after inhalation of the yellow gas. Sometimes it was with chlorine gas, not just mustard. They use two types of missiles. But they present with respiratory problems, mucosal irritation, conjunctivitis, red eyes, secretion, and then second, third day, sometimes to the fourth day, blisters start to appear. That's when actually we diagnosed it was mustard gas after the blisters appeared. Because at the beginning, because several times they used chlorine. It was suspicious of chlorine. But in Taza event, blisters start to form, and then the mustard was diagnosed as the first time. Then several attacks appeared using mustard gas.
There's another picture.
Yeah, these were in the ER in Baghdad Teaching Hospital. They had several attacks. They were admitted in burn unit hospital, and they treated as burns. Only one had respiratory complication from, I think, 14 to 17 patients we had. He developed pneumothorax. I think a blister inside the lung bursted and made a complication of pneumothorax. Some of them had eye problems, referred to ophthalmology. Dr. Hussein gave a trial of the N-acetylcysteine, but most of them were treated conservatively. The only death was a child, which was from the event of Taza. She was very little, had comorbidities. Child, I think 6 years old. I had the pictures for her. That's the only death from mustard we had.
Good. Thank you.
Thank you.
We checked for bone marrow suppression. If you have significant exposure, the bone marrow is suppressed because remember sulfur mustard can cause that. And usually it follows the same type of nadir and recovery that you see in radiation injuries. So this is why there's a similarity between sulfur mustard and the radiation exposure. So if you have a blister from a radiation exposure, you may think it's a sulfur mustard exposure because both of them will cause bone marrow suppression. So be careful with this. But however, the mustard will cause the conjunctivitis and the pulmonary effect, potentially, which you do not see in radiation exposure. Okay? So that's how you gotta differentiate between the two when you take your history or do your physical examination. And these are some pictures of the long-term healings of these mustard. Like I said, lewisite was made for its immediate effect, immediate action, and immediate effect, but was never used. Now, I want to clarify one thing that I may have not said clearly. Sulfur mustard action on the cellular level is immediate, within minutes, but the clinical manifestations are delayed. Remember that, because often if you show up to the ER after sulfur mustard exposure, it's too late to decontaminate. Okay, because already the mustard is entered the body and causes damage. So, and the blisters do not contain mustard. That's another common misconception, that the blister is full of mustard. No, there's no mustard inside. Okay, that's another important thing to remember. Lewisite also acts immediately, and the clinical effects are within minutes. That's important to remember. And we don't have a lot of experience with it, because really we have no use in the battlefield. There's one exposure in a China construction site to mustard lewisite combination that led to 1 death and several dozen exposures. But we don't have like more experience like we do with mustard. But Dr. Kosnet, who's a colleague of ours from ACMT, past president of ACMT, he shared with me when he did a grand round about this recently, some pictures of lewisite that is in the lab or in a case report. You see similar blister to what would the mustard be. Apologize for the quality of these pictures, but that's all we have. These are really old reports. And you see here also the rapid onset. Within 2.5 minutes, you know, look at the progression, 15, 30 minutes, 12 hours, 24 hours. And it took a couple of weeks for them to heal off. This is not the case report that he was able to find. I think Dr. Kosnet had to go to the library or something to pull this case. And you see the severe burn in the leg, about 25% burn surface area. This required a skin graft after the patient was treated for the acute illness that he had from it. Finally, in the chemical world, we have to think about white phosphorus. White phosphorus is very interesting because it's actually going to cause 3 things. So in your toxidrome, you are going to appreciate 3 things. One is a thermal burn, because it ignites easily. It's going to cause a chemical burn because it becomes phosphoric acid as it hydrolyzes. And the third thing is going to cause systemic effects because it's absorbed, and it's going to cause hypocalcemia. And on top of that, it's also going to cause a phosphorescent light and smokiness of the wound because of the burn and the reaction with the tissues. You can see there's some smoke coming off of it. And I'll show you some pictures here. This is, I've never seen a white phosphorus case, but I was consulted on the phone on somebody who died. There was an industrial engineer in Sacramento, and he was exposed to white phosphorus, and he had an airway compromise, and he died basically. This is a soldier who was exposed to white phosphorus in training. You see the phosphorescence on the right under the UV light, and you see the burn there in his head. You see the signs of a chemical burn and a thermal burn. Of course, the picture on the left is much more severe airway injury. I also used to have a picture where you can see a little bit of smoke coming off, but I don't have it here, I think. Oh, here it is, yeah. You see a little bit of the smoke where the arrow is. It's really hard to see smoke on a photographic still, but you can see a little bit coming off. Finally, radiation. Radiation, again, is always going to be the one that you want to not miss because it is not going to have a lot of overt signs initially. So if someone is exposed to radiation by handling a radioactive source or being close to a radioactive source, they will not have any effects in the several hours, maybe days or weeks, until they develop the skin burn. So they will forget what they were exposed to, and you have to really do a good history and take them back several weeks to try to see if they actually potentially were exposed to radiation. Usually these radioactive sources are unshielded, okay, so they are removed from the container that shields the radiation. Typically this happens accidentally or maliciously, okay? And these radioactive sources are going to be emitting gamma rays. Gamma rays can travel hundreds of yards, depending on the, the activity of the source that's emitting them, and they can penetrate through the whole body. And so it's really hard to shield from gamma rays unless you use, lead or steel to try to shield the environment from their effect. This is on the right. This person is an Iranian worker who was working at a plant and found a radiation source. He didn't know what it was. He placed it in his side pocket for a few hours, and then removed it. And then he started, over several days later, developing erythema, which is the first phase that you see. And of course, it's dose dependent. The higher the dose of radiation you receive, you can start with erythema, or you can get blisters. These are patients from Goiânia, Brazil, that were actually handling in their hands cesium-137, which also emits gamma rays and beta particles. And again, I'd like you to appreciate that this looks like a thermal burn, right? This looks like the patient I showed you at the beginning from Grady. This is why you need to ask these questions. And this is weeks later. This doesn't happen immediately. This is not going to be the first day, not the first week, sometimes the second week when you start seeing these effects. Whether you see moist desquamation or dry desquamation, or necrosis. So that's the one cause that is going to trick us, because it's delayed, it's so delayed. So in summary, what did we learn? We learned that burns and rashes are common in our emergency departments. We have to maintain a broad differential when we look at them. We have to think of the biological causes. We learned how to think through the viruses, the bacteria, some typical patterns that they cause, like Yersinia or tularemia or anthrax. Smallpox is a great example to differentiate from chickenpox. And we talked about the importance of the other symptoms that occur with it, the prodrome, the incubation period, and the challenges like infectivity and transmission, person-to-person transmission. Then we talked about chemicals and thermal burns. We went through a variety of chemicals, acids and bases, and those with special properties like vesicants or hydrofluoric acid and white phosphorus. And finally, we finished off by looking at the one that tricks us every time, which is radiation, because of its delayed onset. But as I said, at the end of the day, you saw how they all can look similar. How anthrax can look like a brown recluse spider bite or an ionizing radiation exposure. How tularemia can look like potentially a chemical burn if it's localized. So I hope you enjoyed this presentation, and the next one is going to be done by Dr. Chuck McKay, and he is going to tackle for us the irritant toxidrome. Any questions before he gets up on the stage? Dr. Barra. The picture for sulfuric acid, yes.
I want to show it for me, please, sir. Yes, the previous one. No, the previous one. There's a tube inside the eye. This is for water irrigation?
Oh, you mean this one?
Yes, this one.
Yeah, so this is, we call this Morgan lens. It's basically a kind of a contact lens made of plastic, soft plastic. You put it inside the end, and the other side you connect it to IV tubing, and you can irrigate, because you have to irrigate the eye with a couple of liters of saline.
Which type of fluid?
Saline.
Saline.
But you have to you have to be generous to get the pH of the eye back to 7.
Thank you, sir.
Thank you. All right, Dr. McKay, would you like to walk around with this, or would you like to stand up? You walk around?
Of the American College of Medical Toxicology. He's also the past director of the Connecticut Poison Center, and is academically affiliated with the University of Connecticut still until now.
Yes, still, yeah.
And he is one of the leading experts in, I think, hazmat and chemical emergencies in the US, and consults for governmental and non-governmental agencies on this topic. So we're really fortunate to have him today tackle this topic for us.
Thank you, Ziad. All right, so
in keeping with the way that Dr. Kazi set this up, we're going to try and keep an idea about the presentations, the clinical presentations, that can help you decide both that there may be shared exposure, so there may be more patients who may become sick if they're not already presenting to you, and then try and sort that out from possible infectious radiation-induced or chemical exposure etiologies, and a little bit of the treatment in there. And I think there's going to be some overlap with what we've already talked about in terms of the skin issues and respiratory, because if you think about it, those are both very large surface area organs to which we expose ourselves every day. Inhalation becomes, I'd say, more important because of its effect on systemic issues, but it is, the skin is said to be the largest organ, right? But if you take the lung out and put the surface area of the alveoli across an open plane, then it's the largest organ. And that's what you're exposing yourself, or patients are exposing themselves to once they start inhaling. And of course, we have to breathe. So in terms of how the lung or the respiratory system reacts to exposures of any kind, you could think that it's really fairly limited, but some of the problems get to be the words that we use. So dyspnea, as an example, or dyspnea, as you might spell it, it really means difficulty in breathing, but what we usually are talking about are what we see as far as the patients experiencing difficulty or what they describe. And so what we see would be somebody breathing fast or over-breathing. The patients are saying, I can't get enough air, or they're having trouble even completing a sentence as they're trying to tell you their problems. So that's certainly difficulty in breathing. But if you think about it from a physiologic point of view, somebody who's not breathing enough is also having difficulty in breathing because they're not ventilating adequately enough to oxygenate their tissues. So then they would suffer from hypoxia. But hypoxia, again, could be the symptom the patient has of just air hunger. I'm not getting enough air or oxygen. Or it might be the inability of the air to hold oxygen, and that we talked about when you listed the first grouping of syndromes, the simple asphyxiants, you just don't have enough oxygen in the air. Or it could be that you can't pick the oxygen up and carry it around to your tissues because of a hemoglobinopathy, carboxyhemoglobin, methemoglobin, those kind of things. Or it might be a problem that the cells can't use the oxygen once it's delivered, and those are the mitochondrial toxins in terms of chemical effects. Or it may just be that you're outstripping the ability of you to supply the oxygen by the tissue demand, that may be occurring with systemic illnesses. Or maybe you found an infiltrate on an imaging study and you think, well, that person must be having some pulmonary difficulty of some kind or other because they've got white out of their lungs. But is that water in there? Is it inflammatory conditions? Is it actually occupied by tissue? Is it, is this a fibrotic process, or I guess on long term even, is it a cancer? Compressing maybe the airway. So there are all kinds of different things that might be summarized by somebody as a single word, and if we focus on the word, we're going to miss potentially the causes. So try to split this up into these three major areas and just go through some examples in the next 40 minutes or so. So I'll start with radiation because, in a sense, in contrast to the skin issues, radiation is maybe a little bit easier. Radiation exposure and respiratory complaints, you would not expect anybody to show up with a primary respiratory syndrome following an acute radiation exposure. But in terms of dealing with people who have had radiation exposures in the past, it becomes a major issue in terms of impacting a system's ability to deal with them, either from the hospital basis or even from a societal basis. And we see this in small part, in kind of in miniature, with the patients who received radiation treatment for their cancers. Successfully curing a cancer, but then months to even years later, they may show up with a delayed radiation syndrome that is the outcome of injury that happened months to years earlier, when again you have problems with destroying the cell's abilities to replicate
and inducing some fibrosis, which then gets to be an obliterative arteriopathy, and now you end up without being able to adequately support new tissue, and you end up with a fibrotic lungs. From the pulmonary aspect, you can end up with fibrosis in a number of different organs, in that sense, anywhere that the radiation field was. But certainly for a whole body radiation exposure, you can end up with complications that include radiation pneumonitis delayed effects, as a delayed effect. Just to mention this as Health Physics. It's a journal I don't read regularly, but they had a whole issue in the spring of 2019 focusing on the spectrum of delayed effects following or of acute radiation exposure, which, if you're interested in, is there for you. From a point of view of infectious diseases, again, I'll focus that somebody coming in who is looking tachypnic, that they're air hunger or that they're having trouble with their breathing, and one of the things we tell all our residents is don't just assume that they're hyperventilating, right? Somebody who's tachypnic has a severe metabolic acidosis with respiratory compensation until you've proved otherwise, because that may be your early warning signs that they are actually undergoing sepsis or other systemic process. And the worst thing to do for them is to assume they're just anxious, and now treat them by not paying attention to their underlying illness. And certainly, if there were this infectious source, you would expect that there would be other symptoms going along with that, perhaps referable to the very nature of where their infection is. Do they have urinary complaints as they're coming in? They should have a fever. But a lot of times you're going to end up with a person who may be somewhat altered because of their underlying infection. They may not be able to provide you all the history that you're looking for, especially in terms of some of the prodromal symptoms. But then, I think as Ziad's mentioned, you want to search for that history, and that may mean getting a hold of family members who are able to provide that. If the patient can't talk to you, perhaps somebody who's been spending some time with them can. Perhaps, since we're talking about clusters of illnesses in terms of clusters of patients presenting, an infectious disease would be less likely to present in that way, because everybody is going to have somewhat different latency period to develop their infection and all. But depending on, again, if you look at a cluster over a short period of time, then you can certainly have infectious diseases responsible for that. We think of the flu epidemic every year is a cluster of illnesses that are spread out across the world over time, but they will tend to be within a particular region over a short period of time, a few months if you're going to look at it that way. And the reason to kind of keep that in mind is that there are some infectious diseases, as Ziad mentioned, in terms of, say, bubonic pneumonic plague, that would be potentially transmissible. So you don't want to just assume that the group of people who have this funny looking pneumonia and a few skin lesions and we're out on a hunting party together are not related. They may very much be related, and you don't want to ignore them. Important to emphasize that other things that cause very, very prominent pulmonary findings on X-ray, or at least chest X-ray findings, more of a mediastinal widening, which we are taught to be indication of anthrax. That's not a pneumonia, and it's mediastinal lymphadenopathy and hemorrhage, and so that is not something that's transmissible person to person. So it's important to keep those in mind as well. And also chemical exposures can occur that will allow a secondary contamination. It's not really an infectious transmission, but it can cause a secondary contamination. So it's important to keep these in mind. So then we'll move to the chemical exposure, and there are many, many chemicals that will cause respiratory symptoms, but they are not ones that you typically think of in clusters. Would not be usual for somebody or for a group of people coming in after they'd all been poisoned with aspirin. But could that happen? Well, sure, if there was a medication substitution and everybody thought they were getting, Tums, and they were getting an antacid, and they ended up getting a salicylate instead, their stomach pains would worsen, and they would take more, and I suppose they show up that way, but that would be very unusual. There are a number of medications, though, that certainly can cause tachypnea, with or without associated pulmonary injury or pulmonary edema, for example. So salicylates would fit in that. Metformin, will cause a metabolic acidosis, and people will show up then with the respiratory compensation, perhaps as a significant finding. And then there are other medications which, like say topiramate, which actually has activity as a carbonic anhydrase inhibitor. So after an overdose, patient will show up with respiratory symptoms, usually the next day. So a delayed onset of respiratory symptoms. But again, you wouldn't expect those in clusters. So do medications just kind of fall off of your list as far as a differential? Well, not really, because we've talked over the last few days quite a bit for those that are here about the opioid issues. And so fentanyl analogs in the drug supply are showing up as clusters of severe respiratory symptoms, usually hypoxia, anoxia, pulmonary edema, related to a shared exposure. And then Dr. Thompson yesterday Trevon was talking about the e-cigarette and vaping associated lung injury that we saw in actually every state in our country last year, mid to end of 2019, that was probably largely associated with a single group of individuals who were sending out these cartridges, which they'd obtained from China, and then filled with homemade liquids, cannabinoid liquids that were over-adulterated with a vegetable oil. And basically people were inhaling grease, although there's some debate as whether that's the full explanation or not, but this one source in Wisconsin ended up having tens of thousands of cartridges in their home when they were arrested because of, again, awareness. People in the neighborhood had seen a lot of traffic in this area and thought that it was suspicious, so they called police and then found basically a home manufacturing site without any of the controls that you would want for manufacturing drugs. This would be, I guess, another clue that maybe there's a chemical exposure going on to the people that are involved in this. So this is a multi-vehicle crash up in the northern part of our country a couple of years ago where there ended up being several deaths, about 150 vehicles involved, tanker cars. As you can see, obviously a lot of fire and smoke that was being generated from that. Actually, one of the trucks was carrying fireworks, and so that's why you're seeing these little streamers kind of going up in the air there. So a very explosive situation and with a lot of potential for exposure. But if you're going to go into that, or if responders are going to go into that, they're going to want to know what it is that they're facing and what the patients are going to be experiencing as they come out. So taking a look at the spectrum of chemicals that can be inhaled and then cause some kind of illness, I'm going to focus mostly on the simple asphyxiants and the respiratory irritants, but there are other agents that can cause problems that are inhaled, and I already talked a little bit about some of these, but things that will induce carboxyhemoglobin. Well, fire is a good source. Chemical asphyxiants, so cyanide, and if you have a fire, you're going to generate cyanide if it's a structure fire or any modern building because of the mixture of plastics and rayon and other kind of material which will liberate cyanide as it's burned. And of course you can inhale not only the particulates cause pulmonary injury, but other systemic toxins as well through the respiratory route. So we've always talked about dose as being the determinant of toxicity. When you're talking about something that's been inhaled, you now have to throw a couple other factors in because it's not just the amount, right, but it's the concentration in the air, which would be the amount, and how much you're breathing in and out, as well as how much of a given inhalation is absorbed or maintains contact with a part of the respiratory tract, and how much is then exhaled. And that kind of speaks to how we would want to treat people who have been exposed to an irritant or a toxin or a toxicant through the inhalation pathway, is if you keep breathing it in and out, then you're going to continue the injury, continue the exposure. So the first tenet of treatment is to get them out of the area of exposure. And while that seems pretty obvious, I'll go through a couple of examples where that just didn't occur to people and caused additional harm because of that. So it's not only, again, just the dose, though, it's also who is inhaling it and the circumstances of their exposure. So if you have somebody who's got underlying lung or heart disease and they're inhaling in a pulmonary toxin, then they're going to have more of an effect than somebody who's otherwise healthy. Or a small child who's going to be inhaling and exhaling more frequently and larger concentrations relative to their body size, they're going to have a greater exposure effect than an adult would. And then the property of the agent becomes very important. So we're going to spend a lot of time looking at the first aspect of water solubility. Right? Water-soluble agents behave completely different than agents that are not very soluble in water. And the reason is because the whole surface of our airway and the areas near our airway, like the eyes, are covered in water. And so that's going to make a big difference in terms of how you present. The pH obviously makes a difference because of a caustic nature, direct injury to the lung or tissues that they make contact with, and volatility. So if somebody is very volatile, then it doesn't have to be a gas to end up in the gaseous phase, right? It will become a gas even though it may have started out as a liquid. And where you're exposed makes a difference. If it's a very dense agent, then you're down in a valley, you're going to be more exposed, or if you were down in a trench, for example. And then particle sizes in terms of where the deposition occurs. So all of these things become important features of what the delivered dose is, and that is, as we mentioned already, what determines toxicity. So I just start with the simplest fixings. This is a case that happened just a couple of years ago up in the northwest of our country. This was is an ice cream salesman, so he wants to keep his product cold, and he had dry ice, which is just solid carbon dioxide, but he left it in his car, several cakes of it, and then had his family members sitting in the car. And when he came back out, they were unresponsive and dead because they had been inhaling carbon dioxide, which had displaced the oxygen as the dry ice sublimated and became carbon dioxide. This has actually been used sometimes intentionally as a way of killing other people and leaving no trace. So it's a potential problem in a number of settings, but certainly when this is used inappropriately, an industrial compound basically, used inappropriately, that becomes a problem. And the simplest fixing is, they're not irritating. People did not become aware that they were in a harmful environment because of irritation. They became aware, if they became aware, because they were experiencing air hunger. They felt like they weren't getting enough oxygen, which is true, they weren't. But the trouble with carbon dioxide is it's also a bit of a narcotic, so it can actually depress your ability to respond before you will appreciate that you need to respond. Treatment, as I already mentioned, is pretty simple. And there's a number of examples of this, of carbon dioxide, nitrogen, methane, the inert gases, which are used in a lot of industries to establish a non-reactive environment, to do very precise metal working, that kind of thing. So helium, argon, xenon, those are all potential sources of a simple asphyxiant exposure. Respiratory irritants, as mentioned, these are the largest group of chemicals. And this is just a listing over a number of years of exposures that have happened in the United States where there have been releases, and as unintentional releases to the air, generally air for these compounds. And this, in the first column, there is the name of the compound. The second is the number of exposures over this 5 to 6 year period. And in parentheses are the number of deaths that occurred with those accidents or releases. And the areas that I've highlighted are all respiratory irritants. So these are some of the most common agents that we have exposures to in an industrial basis, and then it gives you an idea of the magnitude of those exposures. But we'll go through a few examples of some of those that are on the list. And the ones that, or the way to differentiate them, most importantly, is on this slide. So the things that have high water solubility are going to cause symptoms early, because when you are exposed to it at the mucous membrane of the eye and in the nose and in the throat, you're going to be irritated. They generally have a good warning properties because of that. Sometimes it's just the irritant nature, but often it's also the odor associated with them as well. And they will cause mostly upper airway injury because, or irritation, because you're going to get out of the environment if you can. Now, if you're trapped or if you're unable to extricate yourself, then you will end up with delayed, or not delayed, on lower airway injury as well, because you'll keep breathing them in and out. But these are often agents that have sufficient warning properties that people will notice them at very low concentrations and then get out, but they're irritated enough they'll come and seek care. But you want to know the people who you need to provide a lot of time and attention to, from those that are just crowding because they're worried, because they've smelled a bad smell, or because their eyes are irritated and running, and not get distracted by the very large number of people that come with very mild symptoms. That's in contrast to those agents that have low water solubility, where people will often continue to breathe them in and out during an exposure, during a fire, during a workplace exposure, or a common source in a large building, for example, because the agents do not dissolve in water very well, and therefore they're not irritating. And if they don't irritate, people won't recognize that they're causing injury or damage, and they'll continue to breathe them in and out. And as they breathe them in and out, they're carried down deeper into the lungs for a longer period of time, multiple breaths, and that will result in injury predominantly to the lower airway, so more pulmonary injury. The clinical marker of somebody with an exposure to high water solubility, if they've had enough time to get some significant exposure, is going to be the inflammatory response at those surfaces. So they'll end up with red eyes, tearing. They'll end up with wheezing because of noisy lungs, because of the response to the bronchospasm, as well as the increased airway water. The hallmark for people who come in with low water solubility exposures is that they've got hypoxic symptoms, because they now are having a progressive inflammatory process in their lungs, which often is presenting with either pulmonary edema or fibrosis, depending on the delay. And they will show up with decreased exercise tolerance, cough potentially, and then findings on auscultation and x-ray. So very different presentations. These are just some examples. So as a school teacher, this is a woman who came in to see me complaining of chest tightness after she'd been cleaning up the classroom. She said that she'd mixed a couple of cleaning agents and scrubbed some desks to get rid of some graffiti that people had put on the desks. And when doing her review of systems, she mentioned that she had some eye irritation. Now, normally when people come in saying to triage, I'm having chest pain while working, people are kind of channeling towards the idea that this is a cardiac complaint. I was working, I got chest pain, sounds cardiac. So she had an EKG, she had a pulse oximeter, she had her vitals taken, and then she was in a room. EKG didn't show anything, and it was only when I actually wasn't thinking of the chemical exposure particularly, but I was asking her, well, if you got chest pain and EKG look okay, maybe this is a viral thing, maybe it's pleuritis, so you have any other symptoms, been having a cold, a sore throat, anything else? She said, well, the throat bothers me a little bit, but my eyes are really stinging. And then it's like, oh, well, maybe something else is going on here. And once we asked what she'd done, she told us that she had taken, which two cleaners do you think she took in order to mix them together and cause an exposure to an irritant? Right, so she got exposed to chlorine gas, but yes. So exactly. So she took bleach, sodium hypochlorite, right? And then she mixed it with an acid, and she liberated chlorine gas. So she was scrubbing while inhaling a war gas. Not a good idea, but that's what she did. So, and she did fine with just a little ventilator, a little albuterol. We irrigated her eyes because they were symptomatic. She didn't have any, corneal injury, but she was just mildly symptomatic.
Can I make a comment? We had a case about 2 weeks ago. I was working a shift with Dr. Tarwat Zahran at the American University of Beirut. It was an Ethiopian woman, came in with severe respiratory distress and wheezing. So she required immediately a BiPAP. So there was a language barrier, and now you have a mask barrier, but they could tell from her that she was not asthmatic, Then we found out that she was cleaning. We asked, what were you doing when this happened? When she stabilized a little bit. She was cleaning, but that's not always, so that's not enough, because we said, what were you cleaning with? So she said what she was cleaning. We had to go find out what the ingredients were. So we sent her family member to the supermarket to go get us the product that she was using. It's a famous product in Lebanon called Yes, Tlitib Wahad. You've heard of it? And then the chemicals in there were not also straightforward. It said anionic acid, so it didn't tell us which acid. And the other chemical she was using contained chlorxylenol. Chlorxylenol. So we assumed that she released chlorine by adding an ionic acid with chlorine-containing xylenol compound. So it's not always as simple as bleach.
So either you can look up, the agent, and they call the Poison Center if you have access. Look it up on, Google's almost always available. Try and see what the chemical compound, or you can listen to the words, right? And we'll get into a couple examples of that. Chlorine. If chlorine is in the compound, it is likely, not always, but likely to be liberated and then cause an irritant effect.
Base, right? It's the potassium hydroxide.
Yeah, and they mix it with a chlorine compound, mostly high concentration chlorides. And we have seen several women coming, maids, and after mixing these in cleaning bathroom, it initiates a reaction, and they all come with respiratory problems.
So I should mention. So we've just talked about sodium hypochlorite and an acid, right? Sodium hypochlorite and ammonia. That's chloramine gas, which actually, in your airways, reacts with water, releases chlorine, right? But it also then reacts with the water to make hydrochloric acid. So, right, so at the end, as far as your cells are concerned, you're being exposed to usually an acid, but sometimes a base. And just like with the skin, strong acids and strong bases are not good, in direct mucosal or tissue contact. And to breathe something in that now is doing that right at the cell surface is a good way to cause injury. I should mention too that hydrochloric acid, right, sounds a lot like hydrofluoric acid, especially if you're communicating over a radio or if there's a lot of excitement going on about a potential exposure. But they're very different. Well, hydrofluoric, as Ziad said, is a very weak acid. It doesn't dissociate much at low concentrations, but it will penetrate deeply to the tissue. Chlorine and chloramine are different compounds, but they act and behave somewhat the same. There are others that we talk about that they just sound similar. So sometimes you can't even depend on the words that are being transmitted because they may not be accurate for what's actually going on. This is a little bit larger exposure, but the same kind of thing. This is somebody who's getting the town pool ready and was now overcome by fumes. Well, getting a town pool ready is an important history to obtain because getting it ready means shocking it to kill off the organisms that have been in it over a period of time. And when you come in, when this person came in, they have a noticeable odor because chlorine and its related products have a very noticeable odor. And that odor is detectable well before it'll become an irritant. But the trouble is the staff are affected because they are seeing how sick the person is, and now they're also experiencing some of the same symptoms, mild, but they're still experiencing them. So you want to not only get the person out of the exposure, but get the exposure away from your staff. So taking off the clothes, doing a limited decontamination in order to remove any remnant is a reasonable thing. And that would be, you know, this fellow. So coming in, he's got enough airway exposure that he's actually got edema at his face and eyes, which of course I've obscured his identity so you can't see his eyes, but airway edema also at the lips and the throat, and you can't actually have people who actually asphyxiate because of upper airway obstruction. And then if they have been trapped in an area long enough, they will continue to breathe in and out, and then you end up with the pulmonary edema pattern that's depicted here. So this can also occur in large-scale events, right? Because chlorine is a major production chemical, and it's used in a lot of industrial processes. So it's shipped by rail, it's shipped by tanker car, and then it's also put into storage vehicles. And this is just actually, if you want to take a look at this, this is the Chemical Safety Board's reenactment of an industrial accident that occurred when somebody delivered a tank car of chlorine and then force fit the connection into the wrong tank and ended up mixing the chlorine with acid. These are just examples of the tankers, and this is what can happen from an explosion. This was I think these were 20, this is either a 20 or a 30-ton release of chlorine that was done with an exercise that was called Jackrabbit to try and look at how these clouds and plumes actually propagated and the effects they'd have. And this is a picture immediately after the release. And this is as the cloud spreads, and you can notice the color. So if people describe the colored cloud, as you were mentioning, to a yellowish cloud, it almost always means chlorine. As with the example of the mustard agent, though it might not only be chlorine if other things are mixed in with it, but that's a chlorine cloud, and you don't want to breathe that in. Even by the time it disperses and the color lightens a little bit, that's still a lethal concentration of chlorine. So you would not want to be out in that. It's actually, they have a monitor measuring on inside of that vehicle, that's the roof that's shown there, and a sheltering place in a vehicle with the windows up and the vents closed is a relatively protective thing, but it's all relative. You can still end up with an injurious concentration if you stay there too long. All right, so water-soluble respiratory irritants usually lead to escape because of the warning properties that you will experience in your upper airway, but it can get to be more serious than that. Treatment is pretty much irrigating the eyes, bronchodilating, but mostly getting people out of that area. And ammonia, chlorine, sulfur dioxide, formaldehyde, and methyl isocyanide, as Ziad was talking about with the Bhopal event earlier in the day. So water-insoluble respiratory irritants, they were also used as chemical warfare agents in World War I, and that's the best example is phosgene. But it's also present in industrial processes and farming as well. So you can end up, I'm sorry, not phosgene, but you can end up with other water-insoluble irritants like the oxides of nitrogen from storage of wet, especially wet grain or silage. If farmers pull it in quickly and then are stirring it up to kind of dry it, the process will lead to oxides of nitrogen. And so those two different chemical compounds will also present somewhat the same way, which is a delayed onset of respiratory symptoms. Again, I guess it's a general rule, you never want to breathe things you can see, and this is a nitrogen dioxide exposure from a fire in the lower picture, and this is actually a Russian. Everybody in Russia has, the dash cam, so you catch a whole. I don't know why that. Well, I do know why that is, but so you catch a whole lot of video there. But this is a truck that was just leaking nitrogen dioxide, and right behind that cloud is an apartment building. But you'll notice in the fire on the left here is people are not, all running away from the visible cloud, because it's not particularly irritating. And that you could see with, say, an old X-ray film repository if that caught fire. And the reason for that is, and it's just a chemical reaction that's shown here, is you do get some hydrolysis to hydrochloric acid from phosgene, but it's very slow, and it's not going to cause warning or development of irritant symptoms unless it's a very, very high concentration exposure. But what happens over a longer period of time is that phosgene reacts to amine groups, which are present in all of your cells in things like DNA and RNA and proteins, and then it covalently binds them and then releases additional hydrochloric acid. So you not only get the dysfunction by your cell molecules being bound together, but you also get additional hydrochloric acid exposure. But because of that, the injury is deep, and it's more slow in onset, and it's characterized by pulmonary edema over a couple of days time. And this just shows one progression and kind of a poor X-ray, but the development of additional infiltrates over hours that were not present earlier on after exposure. So summary for that is just here. Again, bronchodilators sometimes have a role, but mostly it's oxygen supplementation, and steroids probably play a role if you give them early enough, as you would for other inflammatory lung diseases. And just to emphasize, this is the difference between the warning properties for the compounds and their actual toxicity. So the listed number down there, the acute exposure guideline levels, these are determinations that will identify time frames. So this would be like 15 minutes before you would be exposed to a potentially life-threatening dose at these given concentrations. So you can be exposed to 1,000 times more ammonia before it'll harm your lungs than you can for phosgene. But you can't stand to be exposed to that much ammonia because it would be so irritating. So it's very, very noxious, but not as harmful in terms of lower lung injury. But phosgene is not going to give you the warning properties. And that makes it a little problematic because people can get much more injury without being aware. So this is just a quick summary of some of those agents we've talked about. Ammonia methyl isocyanate that Ziad had mentioned with the Bhopal event. And the difference again on this whole list is phosgene is a delayed onset, delayed recognition, insoluble irritant, while all the others are water soluble, more or less water soluble. And then HF, or hydrofluoric acid, has additional systemic properties that Ziad already mentioned that distinguish it from a lot of the others. And then Ziad had wanted me to include, and actually provided many of these slides, some of the issues regarding other irritants that are unfortunately a common source of exposure, a common source of clusters of illness, and those would be the riot control agents. You also mentioned the smoke bomb. So, this would be important for, again, the names of things. So, Ziad, this was a case report you guys had put together with...
This is zinc chloride. And this was a person who was an illegal immigrant in the U.S., was running away from the police, hit in a storm drain, and to smoke him out of the storm drain, the police used this smoke bomb inappropriately. So he went to the ER, coughing and short of breath. They gave his X-ray was negative. They gave him steroids, antibiotics, and took him to jail. Came back within 12 hours in this shape and form. Severe illness, 23 days intubated.
Smoke bombs. Again, the importance of the names of products. Those are usually zinc oxide plus a chlorinated hydrocarbon, so hexachloroethane, right? So a very chlorinated hydrocarbon. Now, so you think, well, the chlorine, then maybe that becomes relevant. Zinc oxide I mean, you can use that as a protective cream on your skin, right? That's what could be the harm of that. Well, much like we think of, for those of you who were here yesterday about the lung injury associated with the cannabinoid vaping products, vitamin E acetate. Vitamin E is also just fine to ingest or put on your skin, but you probably don't want to be inhaling it into your lungs. So zinc oxide as well, you don't want to inhale grease into your lungs, but that's not the major issue here. If you combust zinc oxide and hexachloroethane, now you end up with chlorine exposure. So you end up with acute lung injury, and the combination is no better because you've now exposed yourself to zinc chloride. And zinc chloride is a very irritating product in a closed space. In an open air, not so bad, but closed space, not so good.
Use it for smoking people out, for drills and for signaling.
Yeah. So to simulate like the fog of war, fog war, that kind of thing, it's different than the riot control agents because it's an obscurant. So it might be use it on the battlefield as an obscurant, but you could also use it. Well, here I guess. Yeah. Well, so we prize our actors, so we try not to injure them, I guess. So that's usually something. Usually that's something else. So with you or the stage scenes at where you have the smoke, as it were. That's often, I'm trying to remember. I don't know. Dry ice can be used, so it can be carbon dioxide, which again could be a problem if you had enough of it. But the smoke stuff that's used on stage, I've forgotten what that is. It's usually not. Yeah, not the pyrotechnic smoke, but just the stuff that's done for mood or effect. It can also be irritating in sufficient concentration, and more so at the eyes. And we've had actually people who've gone out to dance parties and then have shown up with injuries to their eyes and skin where they've ended up, especially skin with with water, from tearing or in the creases. From contact with that agent. It's all a concentration effect, right? It's still dose. If you do that in the open air, it disperses, not much of a problem. You do that in a small space and people stay there, it can be more of a problem. So riot control agents, tear gas it's not a gas, it's a solid, but it can be aerosolized or made into more dispersible product. And these are just some of them. The ones that we pay most attention to, the ones that we end up having most exposure to in our country are the pepper sprays or the oleoresin capsicum, which is mostly pretty well tolerated. I mean, it's an acute irritant, but it doesn't cause long-term effects. The CN and CS are a little bit more problematic, with CN being more potent than CS, but CS having a potential problem for a delayed onset pulmonary edema if there's been a sufficient exposure. This paper, actually, if you want to pull that out, the British Medical Journal from 2009 is a review of a number of these different agents and talks about the time to onset and the duration of persistence or usual. Sometimes that can be a little bit longer, especially if it's in a closed space. So again, the name, right? Chlorobenzylidine malonitrile. Well, that just rolls off the tongue, but chloro, right? So it's got chlorine in it. That's the important part. At the other end of the word is nitrile, and we didn't really talk about this, but nitrile products that's cyanide. That's CN. But this is not a source of cyanide exposure. Right? It is a cyanide molecule in this compound, but it doesn't cause the harm. But you can see that if you just look at the name, people can carry away the wrong message. But when you say, what are people experiencing, then you're going to say, well, they're complaining about their eyes, and they can't irritate. It's tear gas. After all, they're all irritated there. They can't see. In their nose and their throat, they're coughing. Maybe if they've got asthma, they're going to end up with more problems because now you've got a reactive airways condition that you've precipitated an exacerbation of. And there are people who are more at risk for some of these effects, as noted here. Contact lenses, that's an important one to remember. If people have contacts, those need to be taken out, and then the eyes irrigated to prevent any more long-term effects. So the environment, the nature of the exposure is also important in addition to the dose. And management, I mean, is pretty much, if it's been a gas that they're exposed to, they probably don't need much decontamination other than, well, actually no decontamination at all. If it's a vapor, they need to have their clothes removed, the external clothing at least, so that you don't have any trapped in the folds and whatnot that now contribute to secondary contamination. Wet decon is going to be needed for exposed surfaces like the eye, but may not be needed for the whole patient. And supportive care is important. Oh, and I guess we've just finished with this. So you already mentioned that the vesicants can cause pulmonary injury as well as skin and eye. And the best predictor, from my understanding, and we've been contracted to do a little bit of work to try and identify the risk of chronic effects following an acute exposure from a number of these agents, is the degree of symptomatic exposure to the eye and the extent of skin vesicles and blisters if they develop. But that can be so much moderated by the amount of clothing and protective gear that people are wearing. The eyes have become maybe the better predictor. But pulmonary and eye injury, delayed and progressive, especially eye injury, is related basically to what Ziad already mentioned in terms of the damage. So you're initiating damage immediately. But why is it that 15, 20 years later, people are developing significant keratopathy and corneal ulceration and things like that? And some of the reason for that is that some of that initial damage that's occurring is taking out stem cells. And if stem cells are not there to replenish, you're retiring and apoptotic cells as ongoing injury occurs over life, you're going to end up down the road with a less reserve, less ability to manage the daily issues. And those become now long-term effects of the acute exposure. And I think I'll end it with that. Right.
Thank you.
Thank you.
Any questions or comments from the participants before we break for lunch? Dr. Aaron. No, I think it happens with the chemical irritation that happens in the inflammation. You get the pneumothorax, and then he had bilateral pneumothoraces and pneumogystinum, and he had chest tubes and from the damage, I think from the chemical damage to the tissues.
Okay, thanks.
Other questions? Masad?
Thank you. Because recently, as everybody knows that...
Can you please speak up?
Yeah. Recently, as we know that there's a lot of demonstrations in some of the countries, and there's a massive use of smoke grenades. So regarding the tear gas, regarding the toxicology side of these smoke grenades, anything as a physician, as first responders need to be aware about, especially the smoke grenades?
Yeah, so most of those riot control agents delivered by, an explosive or under pressure release, then you end up with, ideally, these are developed and marketed not because they cause permanent injury or death, but because they cause an acute onset. And the table, Caron, C-A-R-R-O-N paper from British Medical Journal is a good resource to go to compare them and contrast them. But within seconds onset, but within half an hour offset, right? So short-term irritant effects because they're very water-soluble compounds. But if you now deploy those across a population that includes, and a lot of the demonstrations you described, young children, mothers, the idea that if people go en masse to protest, nobody would hurt them, but maybe that isn't true. But now you're exposing populations that are not young military recruits, that the idea was that's where it's going to be deployed. So you can end up with people who have asthma. Well, they're going to potentially have persistent effects. Or people who just try and run away and hide or go off in a corner and stay in, if they especially drop down into an enclosed space, they're going to have a persistent exposure, and persistent exposure to an irritant can cause injury. So I think it's more that, not that the compounds themselves are inherently super toxic, they're not, but you can expose susceptible groups and the circumstances of exposure.
And Dr. Othong, who's actually now in snake inflammation, he taught me one lesson. In his hospital, was very close to the Prime Minister's location in Bangkok when there were demonstrations protesting his presence in that office. They would come quickly to the emergency department. And before complete hydrolysis, so this is not a gas, it's powder, and it hydrolyzes rapidly. So if you get the victim quickly, or the responder is there quickly with the victim, there may be still ongoing hydrolysis and release of the irritant.
So there's secondary exposure, and we've seen that even with pepper spray. Is,
yeah.
People will come in, and if they come in quickly enough, and enough of them, you get a little irritated in the room. Right?
So
Pepper sprays are way down here compared to CS and CN.
You have to do wet and dry. So the idea is you have to do dry decontamination is not enough potentially. You have to do wet decontamination, which is lacking in some places.
So while you're doing the wet decon, though, right, they may complain of more symptoms, but that doesn't mean stop. It means you need to do more. Like it's kind of like we're often asked on chemicals. Well, aren't there some chemicals you should not, wash with water? And it's like, well, technically, yes, right? You should not take phosphorus, or you shouldn't take sodium and lithium as a metal and dab some water on it. But turning a fire hose onto somebody with a little bit of that on it is fine, But if you've been exposed to pounds of this stuff, maybe water shouldn't be used. So it's all a relative thing. Persistence in a given area versus removal of it rapidly.
Yeah.
Dr. Hamoudi.
Yeah, thanks a lot. In my country, many people exposed to this steer agent, many protests. And so many people ask me, my friends, are there any rule for the Pepsi can or baking soda to ameliorate the burning pain sensation? Scientifically speaking, I didn't find.
I don't think so.
So for inhalation of chlorine, sodium bicarbonate added into the nebulizer, if you've got people with persistent airway symptoms for that, there's case report data that suggests it works, and there's no reason to think it would harm people. So that's probably reasonable. Decontamination, if you're talking about things you can mix in with water or add or substitute, the problem there from my perspective is that anything you do that delays application of the water is going to increase the time of exposure. And so even though it might be that some things, like CN, for example, will hydrolyze better if its pH is up, 9 or so. But if you have to go hunt around for stuff and then get a basin from somewhere and then pour the water in and and mix it, and it takes 10 minutes to do that, it would have been better just to put a lot of water on them 10 minutes ago. So that's how I'd answer that.
People who were exposed to tear gas in the last events in Iraq, they experienced Pepsi was very effective.
Which one? Pepsi?
So that may be readily available.
That was a standard.
Were they drinking it?
Everybody had a bottle of Pepsi in his pocket. So it was effective, and they immediately washed their faces with it.
In Lebanon, they're using basal, onions.
Well, that's just to get the substance P up there.
And charcoal. Some people have been bringing charcoal to the demonstrations.
Everybody in the United States carries a bottle of water because we're all in imminent danger of dehydration all the time.
Bottle of water is okay, but now they found out that Pepsi was effective.
I think we're all in imminent danger of hypoglycemia and dehydration right now after a long morning. Thank you for our speakers and participants. Let's have lunch. Come back here to start at 1:15.
Dr. Waxson. But just in case we merge seamlessly, I'll introduce him now. So Paul Wax is the executive director of the American College of Medical Toxicology, and he's a medical toxicologist out in Phoenix, and also with UT Southwestern, with a
running the toxicology clinic and practicing there when he's there practically, it seems, every other month. So this is going to focus now on the cluster of neurologic symptoms. And again, we'll try and keep that same format of a broad differential and some of the importance of not only the chemical compounds itself, but some of the other issues that can come up in the differential diagnosis, and then how to sort all those out. So if I could have the slide set.
Chuck, and it's been, again, a great meeting, and I thank Dr. Kazi for all the speaking opportunities that he's provided me as well. Hopefully you're not too tired of hearing me speak at this meeting. It's been a great meeting. I've learned a tremendous amount from everyone here, and the faculty is really to be commended. So we're going to shift gears from inhalational and pulmonary to neurologic, and what we decided to do is Dr. McKay was gracious enough to put together part of this opening talk. So I'll just go over the goals and objectives and turn it over to Chuck for a few of the first slides. But there's a large differential diagnosis when it comes to clusters with neurological complaints. I mean, the brain is so essential to our own being, and many, many things can affect the brain. So we're going to recognize that there are many components to someone that might present with some sort of nervous system perturbation. We're going to divide it into these toxic syndromes, as you'll see, and discuss sedation, convulsions, and hallucinations, and go into that in some detail. But before we do that, we're going to discuss briefly radiation syndromes that may affect the brain, and also, very importantly, infectious disease processes that may affect the brain. So with that in mind, why don't we turn to the next slide, and Chuck, you can go over the next few slides if you'd like.
Sure. All right, so somewhat similar to the respiratory issues, although people would necessarily have a lot of concern about a radiation exposure and people presenting from it because of their concerns about secondary contamination or just the issues of dealing with a patient who's been exposed to radiation, it is very, very unlikely that anybody who's had a radiation exposure is going to come in with predominant CNS symptoms. And if you think about that, it sort of makes sense the way we think of radiation as interacting with our cells, is that cells that are very, very rapidly dividing, cells that are very active in terms of metabolic processes, are the cells that are more likely to be impacted by radiation. Now, I would hope that most of our brains are active, some of the time anyways, but the sensitivity of the CNS to radiation is not the same as, say, the GI tract or the bone marrow. I know Zia didn't really mention, but the most early measurement for a radiation effect in terms of some of the common tests we might be able to do, do you guys know what that would be? What blood test do we depend on for early evidence of a whole body radiation exposure? So lymphocyte, right? So you're looking for a depletion of the lymphocyte count. And if you think about lymphocytes, they are not an active, I mean, they do divide, but they're not the most actively dividing cell. They actually have a long residence time and circulatory time. But if you think also of what the lymphocyte looks like, right? It's a cell that has 90+% of its volume taken up by the nucleus. So it is, with a radiation hit, it is much more likely that that cell is going to be impacted in its nuclear content and therefore have an impairment in its function than a cell where the DNA is all tightly wrapped together within the nucleus, and you're more likely to just hit water or something else within a cell. So the lymphocyte is a very early marker. The CNS is a very uncommon organ to be involved. And this table is just a part of the presentation that's up on the Radiation Emergency Medical Management site, like Ziad showed you with the Chemical Hazards Emergency Medical Management. This is something that's housed at the National Library of Medicine, has a slew of information in it, but it's best to go looking for that before you need it, because it's hard to navigate if you're in a stress circumstance. But they have a lot of charts and a lot of graphics, and one of the things that I just will emphasize here is that, that the likelihood of a CNS component, so this neurologic issues showing up with radiation exposure, is not till you're up in the 10 gray or even a little bit likelihood in the 8 gray range, which is a whole body radiation exposure range that is lethal, uniformly lethal. So if people show up with CNS symptoms, it's because they've had a lethal exposure, and they will be manifesting other evidence of radiation exposure by that point. It was significantly the drop in the lymphocyte count. So it is not something we need to spend a lot of time with. Having said that, people who have had a potential radiation exposure are going to be very upset, nervous, and also they may have all of the sympathomimetic or other kind of features going on that might make them look like they're stimulated or otherwise impaired, because of the issues. So they may have vomiting either because of radiation exposure or because they're very nervous. But vomiting and emotional status doesn't affect your lymphocyte count. So, you still have that to go back to. On the infectious side, of course, it's a lot more complicated. Altered mental status is a hallmark of bad systemic infections, and it doesn't have to be a CNS infection. So, sepsis is going to induce altered mental status. So it's always something to keep in the differential diagnosis, and whenever we're called on people who have altered mental status and some elevated temperature, it's always a consideration, but oftentimes, we were thinking of it when we have patients with, say, serotonin syndrome or neuroleptic malignant syndrome from exposure to some antipsychotic. But again, if you're talking about a cluster, it would be unusual for multiple people to show up with, a simultaneous serotonin syndrome or something like that. So keep it in mind, usually you're going to have a fever and some prodromal symptoms like I was talking about with the respiratory issues, but keep it in mind, it can sometimes be an issue. And one of the ways to rule it out if you're talking about a larger group of people is just comparing, the time, the epidemic curve, as it were, right? A chemical exposure generally causes a lot of symptoms in a large group of people within minutes to hours, and then it tails off over time, with very rare exceptions like Ziad already mentioned earlier this morning, like dioxin or methylmercury, where you have a delayed onset symptom. But for the biologic agents where you have an infectious process, you need to have the latency time for organisms to grow and reproduce, produce their own toxins and cause effects. And so that's going to be days to weeks. And if it's a transmissible illness, that's where you're going to see a weeks-long epidemic curve, not just an hours-long kind of curve. So keep that in mind, and that'll help sort that out. Oh, it really likes that one. So the chemicals, and the things to remember here is that if we say, well, it could be a chemical exposure, that could be true, but how are you going to keep track of hundreds of thousands of chemicals? And the answer is you can't. But when you're thinking about chemicals that have now exposures that cause CNS issues, and it's a cluster, this becomes a lot more manageable. We hope that it is more manageable. Because if, again, you're not likely to have a large number of people exposed to a chemical all at the same time, so that's a medication, unless there's been adulteration of the food supply. And in that setting, the most important thing is to kind of keep it in mind. And if somebody comes in saying, I think I may have been poisoned by something I ate, drank, a medication I took, you have to consider the likelihood, but how likely is that? And one of the mechanisms or processes we use to think about that is the what's called the production distribution bow tie, in terms of looking like two triangles brought up together, evaluation. And if something were affecting, say, a food contamination at the production side, where you have a few ingredients that are put together and then distributed to a large group of people, then you would expect a large number of individuals to be affected. If it's tampering with a product after it's already been placed into the store, for example, then you expect a small number of people involved and in a very localized area. whereas if it's something at production side, it's been distributed to many, many areas, and then you'd expect multiple sites and multiple people. So those kind of things, just kind of bringing it into the realm of what am I going to do and still take some action, helps with that. So if you think about this just in terms of what might happen when you're next on duty, if 5 people are unresponsive at home and paramedics are responding or they're being brought to the emergency department for evaluation, think which one of these things is more likely. They all have serotonin syndrome because they're all on antidepressants and then took some dextromethorphan. Well, sure, I guess maybe it could be, but probably not. Actually, almost for sure not. Fentanyl analogs, well, that could be, right? If they were all using at a drug house and they all became overcome, that's how we actually recognize a new fentanyl analog being introduced into the heroin supply, because many people are affected all at once. So that's a possibility. But again, if you find out that it's 5 people that are all related to each other and they're multiple generations and it's a nice home, not a drug-using house, well, then that's less likely. So circumstances, remember, it's not only the toxin, it's also the circumstances and the nature of the patient, the host, those 3 things together. So carbon monoxide, that actually would fit really well. You've got 5 people overcoming a house because of some problem with the exhaust of the heating system or the oil or gas burner, that kind of thing. And we've had this happen repetitively, enough so that it's a real concern, public health concern, in terms of keeping people safe by putting carbon monoxide detectors in their house. And the thing to remember is that if you have many people involved like this, is that if you're responding as a paramedic, you do not want to be in that environment for very long. And we've had, unfortunately, people who have tried to resuscitate responsive parties in a home and get overcome themselves because they were in that environment. So just a way of looking at that, and again, the reason to do it is because it allows proper care and protection of staff as well. Paul, I think take over now.
Yep. Okay. Yeah. Okay. Can you hear me? I think yes. Good. Great. Okay. Yeah. Thanks, Chuck. So as described, the CNS is immensely complex. Billions of neurons, and many things can affect the brain. And we'd like to kind of clump them together to better understand how it affects the brain, and also how we will proceed with the management of a patient or a cluster of patients who have been affected. So one way to look at this is look at the excitation and the inhibitory influences. There's a variety of neurotransmitters. Some of them are more excitatory, others are more inhibitory, and there's a balance between these two. So GABA, for instance, is inhibitory, but glutamate is excitatory. And you take away GABA, you take away glutamate, you add GABA, you add glutamate, and depending on the cocktail, will either lead to more excitation or more inhibition. So there are also other neurotransmitters that may not cause excitation or inhibition, but in some other ways affect the sensorium and modulate the thought processes. And neurotransmitters such as serotonin or acetylcholine are major players in this sort of sense. And in this case, you may get neither inhibition or excitation, but some disorganization or frank hallucinations. And we'll talk more about that in a couple minutes. So too much inhibition can lead to sedation and coma. Too much stimulation can lead to convulsions. And altered modulation of thoughts may manifest it as hallucination. So those are kind of the 3 main subtoxidromes under the CNS alteration that we'll discuss with some clinical examples. And we'll start off talking about sedation and chemicals and drugs to sedate. Now, a prototypical chemical, which may not affect a cluster unless multiple people are drinking, which is not uncommon, is ethanol. And the important thing about ethanol is just to reiterate the idea of dose response. ethanol is a toxin that it really requires a large amount to cause some sort of alteration. I think I may briefly mention this the other day, but we measure ethanol in grams, and one beverage, one bottle of beer or a glass of wine is approximately 12 grams or 14 grams of ethanol, depending on how you measure it, which is 12 or 14,000 milligrams of ethanol. So it's a lot of ethanol to cause perhaps a little bit of intoxication with one drink. As you drink more, particularly if you drink it all at once, you'll be much more intoxicated, and then to a point of incoordination. And finally, with a large amount, you may have coma and respiratory arrest ultimately. And that usually requires a very large amount of ethanol. But depending on someone's tolerance as well, someone who's not a drinker may succumb to much less ethanol than someone who's a tolerant drinker, and it may require quite a bit more to cause the same effect. So the first example, and I mentioned this earlier this week, I think it was mainly some of the students that I was discussing this with, but what happened in Moscow in October 2002, and I think most of you probably recall this or have learned about this at one point in terms of the effect of some sort of gas on this whole theater. So as you may recall, the Chechen terrorists took over this Moscow theater, and the Russian military wanted to put down this terrorist event, and they attempted, for them was a novel approach, which included the installation of this gas into this theater. Unfortunately, although they were successful in putting down the revolt and killing the terrorists, many of the theater goers were also killed as well, which was not what they were hoping for. And there was much secrecy about what sort of gas this was. Initially, people thought it might be some nerve agent, but nerve agents cause seizures. They generally don't initially manifest themselves as coma, but these people fell asleep and had CNS sedation, and many of them had respiratory depression, and those that died from hypoventilation and respiratory arrest. And as it turns out, it wasn't a nerve agent, it wasn't a benzodiazepine, it was an opioid, but this opioid wasn't given through a needle parenterally or through a pill, it was given as a gas, and that's what kind of surprised everyone, because there wasn't a lot of attention to the fact of using an opioid through a gaseous route of administration. And the gas that it was hidden in much secrecy. It seemed to be some sort of opioid. Folks suggested it was fentanyl, because fentanyl is very potent, but in this case, it actually was one of the fentanyl analogs, which was carfentanil. And carfentanil is an opioid that works just like morphine, but it is much more strong at an equivalent dose. And as you can see in this table that I put together some years ago, one aliquot of morphine is 1/10,000th the potency of carfentanil, which with the same amount is so much more potent. And that's why these people in the U.S. and elsewhere have been dying from fentanyl and fentanyl analogs, because these drugs are just so potent. Now, as it turns out, the carfentanil was initially developed to be used as a veterinary agent, and it was used to sedate very large animals, like elephants, for instance, or bison. And that's how potent it was, because when you're dealing with a 3-ton elephant, you need something that will knock them down without expending a tremendous amount of volume. And that was what was called wild nil, appropriately named the trade name for this carfentanil. So if one came upon a scene and there were a bunch of casualties, people with hypoventilation, with CNS depression, one should think, could this be an opioid? Important to certainly recognize that, because opioids do have a specific antidote, and regardless of the potency of the opioid, if you give the antidote soon enough, and if you give at the dose that might be required to block the receptor, you can reverse the intoxication with the opioid. So using naloxone, which is quick on and relatively quick off, is the approach. What happened in the Moscow theater is that the healthcare providers and the first responders weren't informed that the Russian military was using the carfentanil. So these people came out of the theater, they weren't equipped with the naloxone, they didn't know what they were dealing with, and that's what led to many of these casualties. So how else might we recognize an opioid intoxication? The three cardinal features are CNS depression at high doses, respiratory depression, and then particularly the meiosis that might occur with the eyes. It doesn't occur with all opioids. Some opioids, like meperidine, for instance, there may actually be some mydriasis, but classically with the majority of opioids, you'll see meiosis. Now, you also see meiosis with a nerve agent, part of the cholinergic response from a nerve agent is meiosis. So it's not pathognomonic for an opioid, but someone who has been exposed to some sort of cholinergic agent is going to act very differently than someone who's exposed to an opioid. That's why the initial reports in the Moscow theater that it could have been a nerve agent, because they had small pupils, but didn't make any sense. Okay, so that's briefly sedation. Many things cause sedation. We'll use a couple other examples as well, but there is increase in the inhibition, and the naloxone helps to reverse that effect. Other things that are important along with the naloxone for the opioids is supportive care. And if it's a non-opioid where there's no specific reversal agent, then supportive care is the primary management. And supportive care includes respiratory support, and then in cases with hypoventilation, ventilation, and it's critically important and may make a very big difference. Historically, it's of interest that years ago, with a lot of stimulant poisoning, with a lot of barbiturate poisoning, which is a sedative, the thought was the treatment should be to use a stimulant to reverse the effects of the barbiturate overdoses. And the morbidity and mortality from barbiturate overdoses did not decrease despite the use of stimulants. And that was in part because these patients were then developing stimulant poisoning and developing seizures and convulsions and dying from the treatment, while they should have just been given supportive care and ventilation. And one of the major breakthroughs in the history of the treatment of poisoning was the so-called, what they called the Scandinavian method, which was to abandon the use of the stimulants to treat the sedative patient and just to support them with airway and ventilation. Okay, so turning our attention then to convulsions and differentiate between convulsions and seizures. So inhibition of inhibition, if you take away the inhibition, you may then have a seizure. And this occurs pharmacologically in many examples. And there's a whole list of chemicals and drugs, pharmaceuticals that can cause seizures. And this is an example of a case of mass poisoning through this rodenticide, which was used to poison and many people developed seizures. And initially, these first few cases that occurred in the U.S., in fact, one wasn't sure what exactly they were dealing with, but as it turns out, they were dealing with a chemical with the abbreviation of tetramine, and this is a very seizurogenic sort of chemical. And there was this fellow in China that was using this to kill some of his competitors, and led to killing over 38 people in this one event. So tetramine is a very strong poison. It was used as a rodenticide, but banned years ago. But it was still available, and this caused this mass poisoning. This is another case of 61 students felled by this rat poison. One thing I should mention about rat poison particularly is there are lots of different types of rat poison. So rat poison is not one specific chemical or one specific drug. Many of the rat poisons used historically were extremely toxic, like the tetramine, but they included chemicals like arsenic and thallium. And typically nowadays, the rodenticides are somewhat safer. We heard, I think earlier this week perhaps, about the brodifacoum that was used to contaminate the synthetic marijuana in Chicago and elsewhere in the United States. And that's one of the safer rat poisons, but it's a very potent anticoagulant, and if you take enough of it, again, dose response, it can anticoagulate a person as well and lead to significant bleeding. But this is an older rodenticide and causes seizures. So this is a list of some other chemicals that cause seizures, back to the stimulants again, and some of the agents used for nerve agents, which are organophosphates, the nerve agents, or the pesticides, and we've heard a lot about that this week, organophosphates and carbamates. At low dose, depending on the chemical, seizures may not be evident, but as the dose increases, or if it's a more potent organophosphate, seizures certainly could occur. Same thing with nicotine. Now, of course, nicotine is ubiquitous as a chemical within tobacco. People that use tobacco tend not to seize, but if they use too much nicotine, certainly this can cause seizures, and people have gotten into nicotine. Young children can get into nicotine, or even adults. Nicotine has been used as a pesticide in the past, and if someone deliberately ingests some of the nicotine, that can cause seizures. Hydrazines are also chemicals that cause seizures. Hydrazines we find actually in some types of mushrooms, and also we find hydrazines in rocket fuel, and if someone was exposed to the hydrazines, they can cause seizures. Camphor is an old-fashioned mothball that it tends not to be used anymore, in part because of its toxicity, but is also very seizurogenic, as well as organochlorines and strychnine. Now, strychnine is interesting because from a mechanistic standpoint, strychnine doesn't cause electrical seizures in the brain, but because of its effect on neurotransmission peripherally, patients become very stiff. They seem like they're having seizures, but they're really not seizures per se, but clinically they manifest as similar to someone who was having a seizure. Okay, so what is the management of someone with convulsions? Is to sedate. So before we talk about sedation, the management is not to stimulate, it's to support them, it's to use an antidote if it's a opioid such as naloxone. But with seizures, we don't just support them, we have to control the stimulation, and so sedation is quite important. I think one of the major advances over the last 30 years is the recognition that this is really of critical importance, that one needs to sedate the patient. You can't just put them into physical restraints, but you need to chemically sedate them if they're agitated, or certainly if they're having seizures. So a good first line approach is the benzodiazepines. It doesn't always work. It works much of the time, but not always. There are other drugs that can be used, such as barbiturates or propofol, which is used in anesthesia. But these chemicals are important to consider, particularly if the benzodiazepines are not initially working, because of the emergent need of controlling the seizures. Again, you can't have someone seize for too long, otherwise they develop complications, mainly hyperthermia and rhabdomyolysis from all the muscle agitation and acute renal failure. So a lot of significant complications if someone's not emergently treated. There are certain circumstances where pyridoxine might be useful. Certain drugs such as isoniazid, which is used in the treatment of tuberculosis, and overdose of isoniazid doesn't immediately respond to benzodiazepines without providing the critical cofactor, which is pyridoxine. Okay, and then finally moving on to drugs that, or chemicals that neither sedate nor cause stimulation, but may manifest it as hallucinations or some sort of alteration, such as that. And as mentioned at the outset, there are a lot of different neurotransmitters that come into play here: serotonergic, sympathomimetic, anticholinergic, and even anesthetic. So not one common pathway, but they manifest it as an altered mental status, neither sedated nor stimulated, but more having hallucinations. And some of the drugs that have been abused in the past and even today at present, including drugs that affect serotonin, like LSD, for instance, or the tryptamines, this can cause significant hallucinations where the patient is just not there and is not interacting normally. The military actually used LSD in some experiments back in the 1950s. They thought it might be useful to use in the battle and put down their opponent. A lot of that research was done in secret, and as far as we know, wasn't continued after the 50s and 60s. But if there was a number of people who were suddenly hallucinating, one needs to think about something like LSD or similar chemical. And these chemicals are extremely potent. It takes a very, very small amount to cause the hallucinations. We'll just move on to the anticholinergic hallucinations. Now, this is through a different mechanism. We've talked about the effects cholinergically and what happens with a nerve agent poisoning or organophosphate poisoning. Well, if you block the receptor, if you block them, in this case, particularly the muscarinic receptor, you'll develop what is described as an anticholinergic toxidrome. And one of the features of that anticholinergic toxidrome is what would be described as a delirium. These people are often awake, and they just don't interact normally. They talk very funny. It's kind of gibberish. They're making no sense at all. And they can also get somewhat agitated, but they don't even need to be agitated to be very symptomatic, and it can be quite dramatic. We see most of this with pharmaceuticals that have anticholinergic properties, particularly diphenhydramine, but it also occurs in certain plants, Jimson weed, and if there was a mass, if there was a picnic or something and someone inadvertently contaminated the flour with something that contained scopolamine or one of these belladonna alkaloids, there might be a mass outbreak of what would look like anticholinergic poisoning. And this is the mnemonic that we often use to remember the clinical effects of the clinical effects of anticholinergic poisoning. Not only are they delirious, but they tend to be very dry and hot, and they may be unable to void. So there are a number of features of anticholinergic poisoning, but the more severe manifestations are usually the CNS alteration. So this was hundreds of years ago in Jamestown, Virginia, in the U.S., but there was a picnic of some sort, and they accidentally contaminated the salad with the Jimson weed, and all these people developed what we would consider now to be anticholinergic poisoning. And this has not only been used historically, but in the Balkans War in the late 90s, these same agents were potentially used, and BZ, which is an abbreviation for a long chemical name, which is not a benzodiazepine, is actually an agent that was developed for military use, and its effect is to cause an anticholinergic syndrome, not necessarily to kill, but to cause this delirium. And you can see the dose of BZ, which is effective, is a very, very small dose. So theoretically, if you had a mass casualty event where there are a number of people acting delirious, one might want to consider BZ. And that was another agent that was considered with the Moscow theater event, but the patients, the theater goers were not acting. They were not acting with any sort of delirium. They were all sedated. So it didn't make any sense that it was BZ. So treatment strategy for hallucinations is kind of dependent on the exact agent. If they're agitated at all, one would want to calm them down. Benzodiazepines would be a good first-line approach. If one knew that they were dealing with an anticholinergic agent, antimuscarinic, if you use something that will overcome the receptor blockade, that may resolve the delirium very quickly and efficiently. And we often will use physostigmine. So physostigmine is a carbamate, so it's related to the pesticides. It's related to the carbamate pesticides, and in fact, it is a carbamate. And by blocking acetylcholinesterase, it leads to an accumulation of acetylcholine, and the acetylcholine accumulation then can help with overcoming the muscarinic blockade. So if the patient is truly anticholinergic, and you have to be careful about this, because if they're not anticholinergic, then you'll make them cholinergic, which is not what you want to do. But if they're truly anticholinergic, a small dose, 1 to 2 milligrams of physostigmine, may totally reverse the toxicity, while Benadryl, it's not working. Okay. Okay, so again, the dose for physostigmine is approximately 1 to 2 milligrams. We reserve it when we're fairly sure that it's an anticholinergic poisoning. And if it is an anticholinergic poisoning, and if they are agitated and hallucinating, the judicial use of physostigmine may very rapidly, within 3 to 4 minutes, reverse the delirium. So concluding thoughts here that the CNS is a unique target organ. There's a lot of different presentations as just described, and the management generally is symptomatic. There's a selective use of certain antidotes, particularly naloxone, if it's an opioid poisoning, and perhaps physostigmine if it's an anticholinergic poisoning. I think I'll end on that note and open it up for questions. Thank you. Any questions?
Let me go ahead and introduce the next section. Sierra has put together a group of speakers for what he's called the special topics area. Just some issues that for a cluster of illnesses presenting over time, other things that may not fit ideally within some of our organ system approach that we've used up until this point today. And so first we'll have Dr. Bruno Megabain come to the podium, and he will be talking about ricin. I think we have Dr. Megabain's presentation coming to us from Paris, France. And I think both of these have worked. And who's going to talk on ricin?
Ricin, yes. So good morning, everybody. I'm very pleased to be here with you, and we'll talk about ricin in a few minutes. So the story started in 1978, and you know that the first person to have been poisoned with ricin, or supposed to have been poisoned with ricin, is Markov, a BBC journalist, but from Bulgarian origin, and he was stabbed in the thigh with an umbrella while waiting for the bus at Waterloo Bridge in London, and he died a few days later from multisystemic organ failure. And on his autopsy, it was found a metallic pellet of platinum iridium, and it was presumed to contain ricin. Then, a few years later, in Iraq, the old regime, the previous regime of Saddam Hussein was accused to have prepared liters of concentrated weapons-grade aerosolized ricin made in Iraq, ready to be used. I don't know if they really existed or not, I don't know, but it was supposed to be. And of course, there was many incidents involving ricin, and if you go to Wikipedia, you see that there was at least 26 different events during the history where ricin was supposed to have been involved. And the most recent episode in Europe was in Germany in 2018, where an Islamic terrorist bought 1,000 grains of ricin and used instructions he received from the extremist Islamic State group and was preparing a bomb, but hopefully he was stopped before using this bomb. So ricin is a bioterrorism agent. It's, of course, a biological toxins. And you see that bioterrorism has include not only bacterial, but also viral and biological toxins. like botulinum toxins and ricin. Ricin is classified by CDC in the B category. That means that it is moderately easy to spread. It is responsible for moderate illnesses with a relatively low death risk. But when you look at the dangerousness of the different biological toxicants based on their median lethal dose in mice, you see that ricin is well positioned. Probably the most toxic toxin is botulism toxin A, and more recently botulism toxin G, which is much more toxic too. Ricin is toxic mainly if it is inhaled or injected, while if it is taken by oral route, it is less dangerous than cyanide. So it is still dangerous, but less than cyanide. What is ricin? Ricin is a component of the seed from Ricinus communis, and it is found in the castor oil, which comes from this plant. It is produced in the world with 1.3 million tons per year to produce lubricants, cosmetics, and even pharmaceuticals. It has been, for instance, experimented to treat pain and prevent graft versus host disease, and also as cancer chemotherapeutic agent. So it is easy to find. Its toxic properties were identified in the last part of the 19th century by this German scientist Stillmark. And now, of course, its mechanism of action is more known. And you see that ricin is a lectin with two glycopeptides bound with a sulfide bridge. And one part, the subunit A, allows the ricin to link to the membrane, while the second subunit can go through the cell till the endothelium, the reticulum, sorry, and then it will inhibit in the cytosol the ribosome activity. So it is glucosidase, and it inactivates the ribosome subunit by modifying an adenosine, by removing an adenosine in the RNA ribosomal 28S. And then the protein production will stop and the cell will die. So that is the mechanism of action. So there are three routes of exposure to ricin. The first one, which is not so rare, it is the ingestion of castor beans, generally for a suicidal attempt. So symptoms occurs about within 4 to 6 hours after the ingestion, up to 24 hours. Normally, the seeds are relatively bitter, but to have toxicity, you have to masticate. So it is not so easy to masticate the seed. And it is estimated if you masticate the seed, then 3 seeds are enough to kill a child and 8 to 20 to kill an adult. So the toxicity has 2 phases. In the first phase, you will have irritation of the oropharyngeal mucosa, rarely more severe corrosive lesions, and then colicky pain in the abdomen with vomiting and important diarrhea. In the second phase, you will develop fluid losses, dehydration, hypotension, electrolyte imbalances that may lead you to hypovolemic shock and multi-organ failure, mainly acute renal failure. There may be also a risk of hemolysis, seizures, cardiac arrhythmias, and in case of fatality, patients will present diffuse intestinal hemorrhage. But this is relatively rare. In case of injection, which is more rare, but still possible, then you will have more severe features. initially non-specific, like fever, headaches, abdominal pain, and then rapidly hypotension, with intravascular hemolysis, acute tubular necrosis, and of course multi-organ failure leading to death. You may have also local tissue damage, and death is relatively rapid within 2 days, like it occurs with the Bulgarian journalist. And finally, exposure after airborne, intoxication after airborne exposure. So this is a very rare situation. There is no case report with airborne exposure, but it is supposed to be the way by which ricin could be used as weapon, as bioterrorism weapon. So symptoms will occur rapidly within 4 to 6 hours, and it started by cough, dyspnea, arthralgia, fever, then rapidly respiratory distress, multi-organ failure, and death. The patients will develop profuse sweating, and then he will have pulmonary edema, necrosis, bleeding, tracheobronchitis, and of course interstitial pneumonia leading to the death. It has been estimated that possibly a few people were contaminated by ricin by this route in Soviet Union, in a factory that was supposed to produce ricin in the 50s, but there's no case report. So all the data coming from this route of exposure are only in rodents, and by extension it is supposed to be like that in humans. So when you look at the review of all ricin poisoning reported in the literature, and this is an interesting study, so it is like 1 century of cases. You see a total number of cases of about 875 cases. Most of them are accidental and by oral route, but there are some intended cases and some cases by injection. And you see that in the majority, the accidental oral cases are benign without death, while almost all the fatalities occur if the patient inject the ricin, and mainly in a voluntary situation to suicide. Diagnosis is difficult because, as you understood, there is no specific manifestations. Generally, the patient will come with cardiovascular failure and hypovolemic shock, or multi-organ failure. So it's difficult to diagnose. If the history is not clear, it is difficult to diagnose ricin poisoning. But if you suspect the diagnosis, then you have several methods of diagnosis. The immunological methods, they are very sensitive. They are relatively rapid. They could be used as multiplexing methods. They are fast and they allow fast and on-site detection. There are spectrometric identification that are with more limited sensitivity. They are relatively rapid in 8 hours. Also could be multiplexing, but they are much more specific. And finally, you have the functional methods. That means that you have to assess the ability of ricin to depurinate ribosomes. So it's a real-time cytotoxicity assay. It's sensitive and specific, and it is mandatory to determine the biological threat level of a sample. So normally, you have to combine an immunologic or spectrometric test with a functional method. Because as you understood, ricin could be present everywhere. So you need absolutely to show that you have a functional positive method. But all these methods are not available routinely and only in very specific laboratory. For instance, in France, only in 2 or 3 laboratories in the whole France. So you can use surrogate methods. And this is the case of ricinin. It is not ricin, ricinin, which is another compound of, that is present in the seeds. It is an alkaloid found exclusively in these seeds, but it is by itself not toxic, of course. So it can be present in different castor oils, cosmetics, and medical products. So if you use this test, you may have some false positive. And of course, you can also find some false negative if the toxicant was synthetic ricin and not castor seeds. So its use is still questionable, of course, but it is easier to use and it is available in more laboratories, possibly in MENA region, I don't know. So what are the management of these patients? First, of course, in case of severity, the patient should be admitted to the ICU. And this is the case following an exposure by ingestion or inhalation in the presence of severe diarrhea, cardiovascular shock, respiratory distress, hypoxemia, massive hemolysis, and of course, organ failure. The patient have to be transferred to the ICU. Treatment is based on decontamination, and of course, if the patient ingested the seeds, you have to use activated charcoal, as usually recommended. There's no specific recommendations here, and you understood that normally by oral route it is not dangerous. No role for cathartics and whole bowel irrigation. Then, of course, in case of symptoms, you have to provide supportive care based on fluid resuscitation, vasopressor supports, oxygenation, mechanical ventilation in case of pulmonary edema, and of course, hemodialysis in case of acute renal failure. Are there specific therapies? To date, there is no available antidote for ricin toxicity. However, some treatments have been suggested to be active on ricin. Sorry. No, it has this one. Okay. So, N-acetylcysteine and liposome encapsulated N-acetylcysteine showed promising results in rodent models. Milk, lactose, and galactose seems also to inhibit ricin B subunit to bind to the cell. So these are experimental in vitro studies. Dexamethasone and vitamin E seems also to have shown some extensive survival in experimental studies. But of course, none of these therapy is systematically recommended in humans. Are there specific therapies that could be more effective? Possibly. There are, of course, antibodies. These have been used in animal studies and have demonstrated the possibility of protection against inhalation and parenteral administration of ricin. There are several methodologies of administration. Passive immunization, and these methods show a protection before exposure to ricin using humanized animal-derived FIB and recombinant antidotes. And of course, much more interesting, active immunization by inducing adequate levels of ricin neutralizing protective antibodies. This could be useful as a vaccine therapy in people like military at risk of ricin exposure. There are also non-antibody small molecules that could be effective to inhibit protein-mediated effects of ricin. But to date, all these therapies exist only in mice and rats, nothing in humans, of course. What to do in humans? Of course, rapidly, you have to use the adequate personal protective equipment on the scene. Normally, you should use level A, especially if there is a risk of contamination by respiratory route. So you have to protect your skin, your respiration, and you have to use a breathing system. You have also rapidly to decontaminate the environment and to decontaminate the dermal surfaces of any patient by removing the contaminated clothing and by washing the skin with soap, with water, and of course putting the clothes in a double bag that is labeled as contaminated. And you have to clean all the surfaces and clothing with a solution of sodium hypochlorite for at least 30 minutes that will inactivate ricin. So in conclusion of this presentation, you understood that there are development in biotechnology that allows to date probably the obtention of ricin easily from the seeds, but also by synthetic production in a laboratory by a possible terrorist state or organization. So this creates very aggressive bioweapons, and to date, some states or terrorist groups are accused to try to obtain such biological weapons, despite prohibition. Ricin is active in the absence of any producing organism. It is highly toxic at extremely limited doses, and it represents a challenge for clinical diagnosis and detection. Immediate identification is recommended to contain any further dissemination. And of course, as you see, the treatments are still difficult. That's why WHO is urging all the countries to strengthen preparedness plans to prevent such contaminations. Thank you. I don't know if there are any questions about ricin. Of course, all our experiences are limited in the field, but recently in Europe, following the production of a possible bomb in Germany, ricin become on the top of the issues, and the states and the governments try to reactivate all the specific diagnostic means, laboratories, possible therapies to fight against this possible risk. But to my opinion, it remains limited risk.
So Bruno, you'd mentioned the difference between the castor beans themselves and then the ricin isolated from that as a water-soluble product. Most of what we've had in the U.S. has been people who have obtained castor beans and then ground them up or sometimes ingested them whole, which often is they're asymptomatic. But we've had events in Las Vegas and a few scattered events elsewhere where people individually have done preparations either in their home or in hotel rooms. And it has raised a question about the level of response, often after the fact, because sometimes people aren't told immediately what's happened, and then after the fact, somebody goes in to try and clean up the site. Do you have any comments on that other than the general recommendations as far as if people have disrupted the shell in terms of responding to those events?
My experience is limited, of course, but normally you see you need a big amount of seeds to extract the ricin from them, then it is not so easy to produce an aerosolized bomb. Possibly, and that was the case in the US, they put it in envelopes, or they put it on doors or on the shoes of people that they want to be assassinated. But so they suppose that the person will contaminate himself because it doesn't cross the skin, so by oral contamination, thinking that the ricin is sufficiently concentrated to allow this. Because if you swallow a seed without mastication, you have no toxicity. So I don't know really if these means are effective to allow a fatality, because it's more frightening, I think. And in many such situations, such people use this ricin to frighten the people. I'm not sure that this really results in a fatality. The only way is to inject or to inhale. And as explained, if you use the seed to have the ricin, then the ricinin is present, and you can use ricinin as a diagnostic tool. But if you use synthetic ricin, but this is only performed by a state, not by a private person, then ricinin is not useful tool. So you have to measure the ricin directly. And you need, in both cases, an analytical or immunological test and a functional test. Because, as you understood, if you use only an analytical or immunological test, they may be false positive, because ricin or ricinin could be found in different situations in a market. There is a study that tested for ricinin, and about 2% were falsely positive. So you need a functional test also.
Thank you. Any other questions?
Okay, thank you very much.
Good afternoon. I'd like to thank again the Scientific Committee for inviting me here. My name is Robert Hoffman. I'm a pediatric emergency physician and medical toxicologist. I'm the medical director of the Cutter Poison Center. I'm going to discuss a topic that there's a high chance, if you're a toxicologist or an emergency physician, you might have seen some of this information previously. Some of these slides are actually slides that I just presented here at this conference. So if you attended the previous lecture, you'll see some similarity. I don't have any conflicts of interest to disclose. I will disclose that some of these slides are actually from a World Health Organization template that I've used before, and that's widely used to discuss this same topic. So some of these slides are not my original slides. They're actually WHO slides that are freely available for people to use, and I've used in training previously. But basically, I'm going to discuss some unique aspects of anatomy, physiology, and development, as well as behavior that poses some specific issues with regards to children in RIMIC situations. And then a few specific details of exposures that are unique, and then discuss how this relates to pediatric cluster illnesses, or how it would impact our management in pediatric cluster illnesses. So this is these are just some older paintings, and the reason it's included in these slides is if you look at the older one from the 1300s, you see that the child is actually just a miniature adult, and the exact purpose of this discussion is to explain why that's actually not the case. So kids are not just miniature versions of us. There's significant differences. So some of the differences relate to exposures. So there are different pathways of exposure. So some pathways of exposure are actually antenatal, so antenatal or postnatal. So transplacental as well as breastfeeding. More likely to occur on a larger scale is our children's behaviors, so exploratory behaviors, hand-to-mouth behavior, putting things in their mouth that aren't food items or aren't made to be ingested. their location, their physical location, meaning being on the ground, so either crawling on the ground or just being closer to the ground, even if standing. Higher surface area, so relative to us, surface area to volume ratio. And then kids are preambulatory, and most kids who are going to be exposed to something, including in the US, if they're not pre-verbal, they're poorly verbal. So if you think of kids who are 4 years old or less, they have very limited ability to speak or give their own history. And then if it has to do with adolescence, high-risk behaviors or kind of behaviors that might result in exposure or dangerous exposure that could have been avoidable. So I have a few slides about breathing, because this is one of the key things that differentiates younger children from adults. So I won't go through all of them in detail, just try to give you the specific point, which is minute ventilation. So children's uptake of toxins is faster, and that's kind of specifically related to their position close to the ground and minute ventilation. So this is actually from a pretty cool study that was exposure to chlorpyrifos, so chlorpyrifos sprayed on carpeted floors and toys, and the uptake by children. And you kind of see the peak the peak is kind of right there in the center, as opposed to older children or 10 to 25-year-old patients had very little uptake of chlorpyrifos. This slide is a size and surface area slide, so relates to what I just mentioned. So smaller children, especially a baby, has a very different volume to surface area ratio than adults. This is more significant when it comes to dermal exposures, but it is one of the key things that we consider when we consider pediatric exposures in poisonings or mass casualty situations. So one thing about children has to do with behavioral differences. So younger children either can't recognize danger, or maybe older children, like an adolescent, recognizes but ignores something that's dangerous. And I won't read through all of these, but younger children can't specifically remove themselves from a dangerous situation, and actually won't necessarily know that a situation is dangerous. And like I said, adolescents have risk-taking behavior. So, so xenobiotics are handled differently by younger kids as opposed to older. And again, I won't read through the slide, but just there are some significant differences when it comes to both uptake, metabolism of poisons, and then excretion of poisons. So minute ventilation, which I mentioned before, is significantly different. So the younger the patient, so the closer to infancy, the much higher the minute ventilation. And an analogy to this would be, you've heard the term canary in a coal mine. So, an infant literally is like a canary in a coal mine if you were thinking about something like CO, or a toxin that's going to be taken up specifically by the respiratory route. Some other considerations have to do with in-hospital care, staffing, and resources. Lack of pediatric EM specialists is pretty universal throughout the world. It's not common that a child would reach an emergency center in most countries and actually encounter a specifically pediatric EM physician. They're typically going to be seen by a pediatrician, general practitioner, or maybe an EM physician. And there's a little bit of a difference in each of them. There's maybe some advantage and some disadvantage to each, but there's some distinct differences in what they're capable of providing for the child. The other kind of specific issue faced is when children do get to a hospital, it's not really, there's no guarantee that hospital actually has specialized services that are able to care for critically ill children, meaning it's very possible that the hospital doesn't have a dedicated PICU or neonatal ICU. And besides being able to manage those as inpatients, it might not have other things that are necessary, which might be people able to do ECMO for children, or respiratory services able to keep children ventilated. This is from my talk yesterday. Even some simple things like just supplies. So the reason I showed that blue top tube, it's not specific to a RIMIC situation, but it's That blue top tube is, you'll recognize that's an adult vacutainer tube used to check coagulation profile. So to fill that, and it's necessary to fill that tube to a specific volume to ensure the anticoagulant inside is exactly the right amount. Now the difficulty with these tubes comes in, it's very possible if you have a young child, an infant or neonate, you won't be able to get enough blood to fill that tube, and resulting in a lab error. So there are a lot of simple things that you would think are simple, but actually can become problematic when we're managing children in these situations. Another consideration has to do with developmental or cognitive capability of the child. So typically, children have to remain with the caregiver. So if you're talking about or considering a mass casualty event, you actually have to consider, so are children going to be transported without an adult? And then if decontamination is needed, who's actually going to take a child who's alone through their wash, through the decon? And then, further considerations would be, well, if there's an adult there who wasn't exposed, but they could go with the child, does the adult go through the decon and potentially get contaminated? So there are really a lot of kind of developmental or cognitive questions that come up when managing kids. Once the patient's inside the hospital, we face the same thing. Who's actually going to stay with the patient? It's not really feasible to have a one-to-one nurse for every unaccompanied child. And then other issues of consent, capability of consenting to procedures, consent to a hospital to a level that provides higher care. Specifically, it's issues come up with regard to antidotes. And it's mostly not availability of antidotes, more familiarity or unfamiliarity with antidotes. So for any given poisoning, it's likely that an ICU relative to a PICU probably has more experience applying that antidote. So anyway, this is the second of the pictures that I just showed you, and this is a more realistic picture of a child, which is, a child is kind of like an adult, but a distinctly different entity. That's actually the last slide I have. Happy to take questions. Thank you.
Hello, everyone. I hope you are still awake. So I've been asked to give a talk about paralytic syndromes related basically to toxins exposure in general. And so I'm going to talk in brief, basically. I'm not going to burden you with all of the information related to all of this, but we are going to speak a little bit about Guillain-Barré syndrome, the barium toxicity, botulism, and we had quite extensive talk about botulism in the last workshop. Tetanus toxin, tick paralysis, saxitoxin, and then tetrodotoxin, because we had an outbreak of tetrodotoxin. I would like to share that with you, and then cons if we have time. So Guillain-Barré syndrome is basically the most common cause of an acute generalized paralysis that we see in the emergency department. It's usually commonly missed diagnosis because most of the time we don't know what is going on with the patient initially. And it is associated with significant morbidity. And it's basically happened due to inflammatory peripheral neuropathy, which could be related to virus-induced, bacterial-induced, or toxins. There are four main phases for this disease. They usually start with the interval of an infectious prodrome that happens initially, and patients usually does not know that they are going to develop, or there are no signs of symptoms that they are going to develop this kind of paralysis. But then eventually they progress into weakness, which manifests as symmetrical limb weakness, diminished or absent tendon reflexes, and then, but they have a minimal loss of sensation despite the paresthesia. So that's one of the things that you might put in your mind when you are looking at the differential diagnosis. And these symptoms usually last for about 4 weeks or so. And then they have the plateau phase, and then after that, the recovery phase. The main challenge in this is the clinical diagnosis. So if you have a high suspicions of Guillain-Barré syndrome, you will be able to pick this as early as they come in the initial presentation. But they might have also abnormal nerve conduction study in the assessment. And when you do a CSF analysis, you will find a high protein analysis and a low WBC. And the treatment most of the time is supportive. You can use immunoglobulin, and that's with a high efficacy, especially if it's administered within the first 2 weeks of starting the symptoms. And there have been trials of using plasma exchange as well in such cases. Barium toxicity. So barium basically used as a pesticide or insecticide. The feature of the barium makes it a little bit you know, it looks like a powder, a white powder, like a flour. And then most of the time, people might miss this with the usual flour, and that ends up by an unintentional poisoning. The barium by itself, it can cause competitive blockade of the potassium rectifier channels. So it will decrease the potassium efflux out of the cell. So most of the time, the potassium will be built inside the cell, and there is a decrease in the level extracellularly. And this will cause an increase in the vascular resistance, leading initially to hypertension, and reduce the blood flow, leading to metabolic acidosis. It also indirectly affects the potassium by increase the membrane permeability to the sodium, and so increase the sodium-potassium bond activity, leading to the further influx of the potassium inside the cell, and so decreasing the potassium level extracellularly. And usually, the hallmark of diagnosing barium toxicity is the hypokalemia associated with it, which will lead into overall result, cellular depolarization and paralysis. And that's the main reason behind the paralysis, is because of the hypokalemia rather than the direct effect of the toxin. The clinical presentation, it can cause fixed proximal weakness, also abdominal pain, nausea and vomiting. The hypokalemia can lead into ventricular dysrhythmias, and then death may be related to it, associated with hypotension. And the main thing is that they develop a flaccid muscle weakness and respiratory failure as well, which can also lead to the death in such cases. Diagnosis is clinical, and also there are some centers that they can do the blood level or urine level of barium. The treatment is mainly supportive with aggressive correction of the hypokalemia and mechanical ventilation for the respiratory failure. There are evidence that enhanced elimination like hemodialysis and CFFH might help in such cases. Botulism toxin, again, we spoke about this earlier. Botulism is quite a nasty toxin that, if happened, can cause great fatality. It's the most lethal toxin known. You need only a small dose of this, like a human oral lethal dose will be 1 microgram per kg, which is quite, scary. The mechanism of toxicity, probably you know this, it's usually, we need acetylcholine in the neuromuscular receptor agents. So what will happen is that you have at the nerve or at the neuromuscular junction vesicles that contain the acetylcholine, and then you have proteins. I don't know if this will show, but you have proteins at the end here. That protein here, let me show you. So we have these proteins here that they can carry the vesicles and goes all the way down, and that will enhance the release of the neurotransmitter. What will happen is with the botulism, they are going to affect the protein there. Okay, so that will end up by having the vesicles flowing up there without reaching, the acetylcholine will not be released. And that will end up basically by decreased level of acetylcholine and causing paralysis. So clinically, they will have a decreased symmetric paralysis, descending symmetrical paralysis. They will have normal sensation, and that might be a clue to diagnose botulism. Normal reflexes compared to the previous two, and they might have early cranial nerve palsy or cranial nerve involvement. And eventually, the cause of death is basically because of the respiratory compromise and respiratory failure. Diagnosis, we talk about this, but toxins are detected in the serum, stool, and the food. And also, you can grow the bacteria by itself in the stool or in the stool culture. And the treatment is mainly supportive. You can use botulism antitoxin if you have it, and that will shorten the duration of the illness and the morbidity as well. Or you can use also IV botulism immunoglobulin. Tetanus is another cause for paralysis. Tetanus by itself, it's an extremely potent neurotoxin that produced by the Clostridium tetani in an anaerobic conditions. And usually it presents with an acute onset of hypertonia, painful muscular contractions. So you can see that, the classic posture of such patients, and it can cause generalized muscle spasm and increase reflexes. The diagnosis is mainly clinical, and the treatment is supportive. Using the tetanus immunoglobulin might, shorten the duration of the illness as well. And of course, the main thing is the prevention with vaccination. Tick paralysis, again, it's basically peripheral nerve effect due to the one kind of ticks called Dimacentor tick species, and these are basically cause ascending symmetrical paralysis, ptosis, again normal sensation, and respiratory failure leading to death. Mainly the diagnosis is by identifying that these symptoms related to the tick. You need to look for it and try to remove it. And of course, there are certain techniques that you need to apply in order to remove this tick. And usually the other investigations are within normal, including the CSF. The treatment is by tick removal and supportive care until the effect is completely resolved. Saxitoxin is a paralytic shellfish poisoning, and is basically formed by the dinoflagellates in the shellfish. It can cause ascending symmetrical paralysis. So you can see is almost all of them, they can give you a similar clinical picture, which might, a highly suspicion of certain diagnosis will give you the clue about what is the exact cause for these symptoms. For this patient specifically, they will have burning and tingling sensation around the mouth and the lips, and maybe in the foot at the beginning of the illness, and this can be used to differentiate between it and the other types. It can cause altered mental status and respiratory failure. So in this way, you can see it's different compared to the botulism and the tetanus, basically. Diagnosis is clinical suspicion. The toxin can be detected in the food, water, environmental samples. There are certain centers that can send and test even the urine sample for saxitoxin, and the main treatment for it is mainly supportive care until complete recovery. Tetrodotoxin, this is basically, we had an outbreak of 6 cases last year of tetrodotoxin related to fish ingestion. They didn't know that it was a buffer fish. And so tetrodotoxin by itself depresses the action potential generation by the fast type sodium channels in the neurons and the skeletal muscles, leading to that kind of paralysis. So usually the patients will have, the initial presentation in our cases was initially GI symptoms, nausea and vomiting, little bit of dizziness, and perioral tingling sensation. And then after some time, they started to feel this ascending paralysis. And that happened within 30 minutes after the ingestion. You usually expect the paralysis to start within 1 hour to 3 hours from the time of the ingestion. And we feel that this presentation was quite quick, maybe because they ingested quite a good amount of the toxin. So they develop ascending symmetrical paralysis with cranial nerve involvement. And then eventually they started to have respiratory failure, and then they lost their consciousness. And this is one thing that you might also consider in the differential diagnosis, that these cases, they will develop eventually altered mental status and coma. Again, the diagnosis was clinical. We had to say that this was tetrodotoxin based on the history and the examination, but we were able to send the urine samples to be tested, and it came positive for tetrodotoxin. If you have the facility, that's okay. Otherwise, it's mainly clinical diagnosis. And the treatment was mainly supportive treatment. We did a trial of using neostigmine to overcome the effect of the tetrodotoxin on the neurojunction and neuromuscular junction also, and we also considered dialysis, but we were not sure whether this intervention was the cause for the quick recovery. Most of them recovered within 48 hours. The last one is Konzo, and Konzo basically is a highly dietary, caused by highly dietary cyanogenic cyanogens substances in what is called cassava roots. Okay, so these patients whom they ingest cassava without being processed in a certain way to degrade this toxin, they will end up by developing symptoms, which is basically upper motor neuron symptoms. So they will have abrupt, irreversible, non-progressive, and symmetrical spastic tetraparesis, increase in the reflexes, and then tropical ataxic neuropathy. So that's very classical for Konzo. Again, the diagnosis is mainly clinical. You can detect the cyanogens through the food sample if you have that facility. And the treatment is mainly supportive with higher education on prevention of, higher education basically on the way to prevent the development of this disease, and maybe the control of control the way how this kind of fruit being prepared. So I guess that's the end of my presentation. Any questions? Sorry. No? No questions?
So, Dr. Nelson is going to be coming up, and I don't know that all of you have heard him over the last couple of days, but he's going to be presenting from Sandia Labs and a little systemic issues regarding an emergency response.
All right, I realize it is the last series of talks at the end of the conference, so we need to wake up a little bit. All right, everyone has a pad of paper and a pencil. So I'd like you each to take a pad of paper and a pencil, and everybody stand up. All of you, stand up. We're gonna do some artwork here, right? The art of medicine now. So take your paper, put it over your head. All right, and draw the biggest circle you can with your pencil. All right, congratulations, you just drew your face. So now, as physicians, I'd like you to draw your eyes, your mouth, and some hair in that circle. All right, let's take a look. Very nice. Okay, that has no meaning in life whatsoever, just to wake us up. So, as many of you saw on the first talk on Wednesday, I'm a scientist. I represent Sandia National Laboratories, and this is science. Well, kind of art. I don't know, a little of both. But I'm here to talk about security principles. And I acknowledge that as physicians, most of what I'm talking about today, you won't ever actually probably do on your own, but know that there are resources out there to help you if you ever see a security problem in your own hospitals. So we at Sandia teach a comprehensive risk assessment approach. We typically offer courses that are about anywhere from 3 to 5 days long on all of these topics primarily, again, with scientists, but I think there's a lot that we could offer to physicians and hospital settings, which I'll talk about now. So we usually teach 5 questions. What do we have? Meaning, what dangerous substances, be them biological, chemical, radiological, do we have in our hospitals or patient clinics? What can they be used for? Again, it's kind of a heavy topic, but what could someone use these for to hurt someone else with? What could bad guys use them for? How badly does somebody want it? Why would someone want to come steal it from you? And how can we protect against these bad actors? So again, in the patient setting, we find chemical substances. This could include fentanyl, chloroform, a lot of the dangerous substances we talked about today. Biological agents, of course, you have patients coming in that are exposed to Ebola, hopefully not Ebola, but various dangerous viruses. And then radiological, many hospitals have cesium-137 in the blood irradiators. You might also find Tech-99 and various other radiological substances. So question for you. If I told you I wanted to work with a flammable liquid, an extremely flammable liquid, or a combustible liquid, which of these 3 do you think is worse? Which is the most dangerous of these 3? None of the above? So as a chemist, I think of the difference between flammable and combustible. And these words have slightly different meanings. And then the word extremely. Well, the challenge with this is that depending on where you look, which reference you look at internationally, you get a different response. And there are some chemicals that if you look at US-based regulations would classify as flammable, and then even other US-based regulations would call it combustible. A perfect example of this is acetic acid, or commonly referred to as vinegar. Now let's take it to poisons. What if I wanted to work with a poisonous liquid, an extremely toxic liquid, a very toxic liquid, packing group 1, or a hazard category 4 liquid? Which of these is worse? See, I have no idea, right? And that's the point here, is that it depends on where in the world you are. So some chemicals could classify as all of these. So if you have a very poisonous chemical, it could be classified, depending on where you are in the world, as extremely toxic or packing group 1. So because of this is why the international community came together to develop the global harmonized system. Because within certain countries, the US is a great example, and then between countries, so if I were to ship a package from the US to Turkey, we had different laws, different regulations. So in the US, we would label a toxic chemical differently than here in Turkey. So this system was developed by a lot of input from around the world, along with the United Nations, to try to minimize some of those problems. So this has now been implemented in many countries, but the Middle East still has a long ways to go with this. And many countries are starting to implement, such as Egypt is in the process of implementing GHS, but they haven't fully integrated it into their processes. So one of the really cool things about this global harmonized system is that it standardized what we call a safety data sheet. How many of you have worked with a safety data sheet before? Conversely, how many have never seen a safety data sheet before? So I met a couple of your colleagues here this week that had never heard of a safety data sheet before. So what this is for any material, it has known hazards. And what the global harmonized system did is it standardized these hazards. So it makes it easier for people around the world to identify the same concerns. Now, under all safety data sheets, on the second line, you find hazards. And this will include toxic hazards, chemical hazards. And so they've come up with a very systematic approach where anything, if you see the word H300, or the letters in the code H300 means fatal if swallowed. So that would have an LD50 of less than 5 milligrams per kilogram. Fatal if in contact with skin, it's code H310, and then H330, fatal if inhaled. So these values are all available online, and they allow us to quickly attribute toxicities to various chemicals. The way that this is determined is by a lot of mechanistic, deterministic toxicology, which is really the field that I come from, where there's a systematic approach where you do an animal study or various other studies, you find the toxicity of a chemical, and then if you find that it has an oral toxicity of less than 5 milligrams per kilogram, you call it a category 1 toxic, and so on and so forth. So what this means for you is it makes your life easier. Now there are pictograms, or these pictures, that are associated with all of the hazards that we need to be most concerned about. For instance, if something is acutely toxic, you'll have the skull and crossbones. So that means it has a very high toxicity. So this helps you in your labs. You can go around, or your clinics, or wherever you may be, you can walk around, and if you see that picture, you immediately know this is a safety concern. It also could be a security concern. The issue with security risk assessment and security management is that some chemicals may not present as acutely toxic originally, but they're very easy to convert in simple chemistry to extremely hazardous chemicals. Case in point is mustard, which we heard about earlier today. In one step, you can convert a very simple chemical, dimethylamine, into mustard gas. So dimethylamine is not particularly dangerous, but if you convert it into mustard, of course, we saw today, it is quite dangerous. So there are many resources out there to help us identify these chemicals that are known to be precursors. For example, the Organization for the Prohibition of Chemical Weapons has lists that they have published that help us identify these chemicals. Turkey is a member of OPCW, as are most countries in the Middle East. The only country who is not a member is Egypt. Switching gears a little bit to biological hazards. For something to become a hazard, it's going to depend on, one, its transmissibility, its lethality, treatability, latency, a lot of these different factors, which is kind of outside of the scope of what I want to talk about today. But the reason I bring it up is the security we have around it is the principles are all the same. Radiologically, the hazard associated with a radiological material is going to depend on its half-life. How long is it present? So if you have a compound like fluorine, radioactive fluorines for FDG imaging for cancers, the half-life of that is in the order of about an hour. So if someone were to steal a large source of fluorine, they'd have to have a very well-orchestrated plan to actually do anything wrong with it, because by the time they got to their intended target, it would be gone. Similarly, with a compound like, with a radioactive isotope like uranium-238, is a half-life in the order of billions of years. So in order to be a radiological hazard, you would have to have huge quantities of it, at which point the metal toxicity outweighs the radiological hazard. So the half-life is important in determining this. It just so happens that cesium-137 is one of those radiological materials that is a security concern. The physical form of it is important. If it's a gas and it just disappears like krypton, you're not so concerned about it, or radioactive argon, not so concerned because it disperses very quickly. And then activity level. Of course, if you have a very small concentration or activity, it's not going to hurt someone. We're less concerned about it as opposed to these high activity. And again, this leads us back towards cesium-137 for blood irradiators in hospitals, which here's a picture of those. So next question we would ask is, how badly does someone want to take this from us? And there's unfortunately a lot of different types of bad people out there with a lot of different motivations. Some are opportunistic, some are very motivated. We have individuals all the way up to state governments that could have very localized, all the way up to very widespread impacts. We've heard about a lot of these today. It says there's World War I, chlorine gas exposures, with Syrian exposures, and then with organized groups such as ISIS that we heard about earlier today. So a lot of this makes sense to us, but what it means for us in the clinical setting or in our own laboratories or wherever we may be is understanding why us. So that leads us to a discussion about why why us in the patient setting? And really in hospitals, you're relatively vulnerable in the sense that your mission is to serve patients. You have to be open to the public. Your mission is to take care of people, so you always have people coming in. Whereas in my institution, I can shut the door and keep people out, so I have much fewer people coming in and out. We know that you have toxic chemicals in hospitals. Certainly the quantities are smaller than you'd find at like a chemical industry. We know you have radiological materials as well as infectious agents, though, again, most of the infectious agents, you don't have a lot of control over what comes into your clinic. So that's a little bit harder to predict from a threat perspective. And of course, equipment is always important. So if we wanted to reduce the vulnerabilities in the medical setting, we have a number of different tools to do that. Physical security, so this is adding more doors, more locks, more gates. Transportation security, so this can include protocols on how you package materials to ship them. Inventory management, which I talked about on Wednesday. Personnel management, this could include wearing things like badges. How do you ensure that the people that are coming into your hospital are entitled to be there? And then lastly, information security. Just random question. How many of you have changed the passwords to your email in the last year? Yeah. Last 6 months? 3 months? 1 month? Last week? Okay, so that's impressive. A lot of places we go, people have never changed their password before. I guarantee you that your password is out there on the dark web. And actually, there are now tools. A lot of banking applications will search your credit history and tell you whether your passwords have been hacked or not. And that actually just happened to me a couple weeks ago, so I quickly changed my password. So anyway, there's really 4 principles that we need to think about when we're trying to improve our security. The first is balanced, second is layered, third is graded, and fourth is hierarchy-based. And I'll go through each of these briefly. So by balanced, we mean you don't want to make your facility into a nuclear security facility. It wouldn't work for your needs. So you need to balance the mission of your institution. Again, you need patients to come in and out. And also, the other aspect of balance is that we need to think about our facility in 360 degrees. For example, there was a famous case in Brazil where there was a large bank that had built extensive security around their vault. But the problem is they built their vault in the basement, the very bottom of the building. So some criminals bought a house within about a kilometer. They set up a landscaping company and then started digging out dirt over about a period of a year. And they were slowly digging a tunnel a kilometer underground and came out underneath the vault. Now, it turns out the vault had no security looking downward. So you have to think about the vulnerabilities all around your facility. You don't want to put all your efforts on the front door if you've got an open back door, for instance. With layers, this is the onion principle. I don't know if you've ever received a package, like a gift from a friend, and it's a box, and you open it up, inside's another box, and you get really frustrated, and then you get another box, and eventually you get down to like piece of trash or something, you know. But the point is, it takes forever to get to that present in the middle because there are more and more layers. So the more layers you have, the more difficult it is to access something that's higher risk. And layers is not necessarily doors or gates or locks. It could be a number of things, such as having security guards that walk around or having badge systems. So we're making things more and more complex. So just to look at a clinic setting here, this is looking at a blood bank. Down in this bottom corner here, we have a blood irradiator. And if we wanted to really look at the security of this, we'd want to think about how many layers do we have. So if we break this down, we see that there's 3 layers of physical security in some regards, but we'd really want to know what's down here. How easy is it? Is there a window right here? Maybe there is. And if there's a window right there, we really only have 1 layer of security. So we've got to think about these layers in 360 degrees. And then we need to think about this idea of graded or risk-based protection. These are just a few examples of chemicals. Certainly there are other things out there, but, and this will depend on the situation in your own country, your own region. I recently went to a laboratory in Kenya, and they had chloroform in the laboratory for many years, but then there was a trend where people were stealing chloroform from laboratories around the country so that they could then kidnap people. So they made the decision that this was too high a risk and they got rid of it. But you know, that could be, in that setting, obviously a high-risk chemical, whereas saline, it's not high risk. So you don't want to protect saline unless, of course, there's a theft situation for it, but that would be a different, different discussion. And then the last major concept is hierarchy-based. So this really comes from the field of industrial hygiene or occupational hygiene. I'm sure in most of your countries you have access to occupational hygienists, so if this concept is of interest, please do reach out to them. Similarly, I'm happy to discuss with you further. But really it's this idea, I like the STOP principle, the stop sign. This comes from the Germans. Substitution, technology, organizational measures, and personal measures. And I'll show you an example of what I mean by this. So if we're looking at radiological hazards, the most effective thing you can do is to substitute the radiological hazard. So if you have a blood irradiator that's based on cesium-137, that is a pretty high-risk material to be taken. But there are alternatives, right? You could use an X-ray-based system that doesn't require radioactive material. So you've immediately reduced your risk. You could also put in administrative controls or badge access controls, and that would help lower your risk. And then lastly, you could protect the actual individual blood irradiator. Similar with chemicals, you could choose different types of chemicals that are known to give similar medical effects. Substitute the higher hazard chemical for a lower hazard. You could also, eventually the last thing you want to start doing is putting in personal protective equipment like goggles. I'm not saying they aren't important, but they are the last barrier. So you want to think higher if you can. And then biologically, if say this is more for a research setting, but if you're studying typhoid fever, you could use a surrogate, a different lower hazard bacteria like typhi, Salmonella typhi instead, and so on. So the idea is to really think about getting rid of the hazard if possible, substituting it, and then thinking about administrative controls, engineering controls, and then lastly, PPE, personal protective equipment. So again, there's really 5 questions we ask with security. It's what do we have? What can it be used for? What harm could come from it? How badly does someone want it? Why us? So this is a really important question. Think about what weaknesses you have in your facility. And then lastly, how can you reduce them? And particularly when it comes to this last question, how can we reduce our vulnerabilities? I wouldn't suggest that you start designing your own systems for that. But certainly these first 4 questions, you're very capable of doing. All of us are capable of asking these questions. And then reaching out for help. Reach out to your security personnel. Reach out to Sandia. Reach out to Ziad. He can put you in contact with other people as well. So the main point is just like you're in the clinic and you can see these problems arising. So speak up about it. Ask for help. There's plenty of resources out there to help make your work environment a safer place. So any questions you have, please feel free to email me, write to me, WhatsApp me as needed. Yes, Ziad.
Have you talked about, sorry, I was outside finishing up some administrative stuff, but have you talked about
the... You missed our artwork.
Did I miss?
You missed the artwork session.
Oh, okay, what about the video? Do you play the video? No.
Oh, I did not play the video.
Have you talked about the role of emergency physicians and the role of emergency responders in detecting chemical or biological or radiological incident breaches?
Not exactly. No,
can we
be a great
bring
time
that up?
To bring it up, yeah.
Can you bring that up a little bit?
No, yeah, but it'd be a great time to bring it up, sure.
Okay, so we have a role as healthcare providers in this area. Can someone tell me why we have a role? Why do you think that we have a role in detecting a chemical incident breach or biological or radiological?
Because we are the first responder. Nobody will know if we don't recognize it. It comes to us as a first, guys. And if we don't raise the issue, maybe it will be missed.
Very good. That's the one point. So detecting the actual illness. Tim, are you trying to answer? Go ahead.
It takes a long time for a hazmat team to sit up and do entry. They got to do vitals, get in level A suits, get downrange, get back, sample, that kind of stuff. And typically, I'll tell my guys to call the hospital and ask what the syndrome looks like before they go downrange. Because typically, the medical people have an idea long before the hazmat team makes entry on what they're dealing with.
And what about our role in detecting something suspicious? Can you imagine a scenario where we actually enter the scene and see something, not we, the first responders enter the scene and find something suspicious on the scene? And many times the paramedics are there before the criminal has concealed the evidence. So if a criminal is doing something, they don't have time to conceal it when they get injured and the paramedics arrive there. In the emergency department, we also should be suspicious about, presentations that are odd, something that doesn't fit, an explosion at a home. Why was there an explosion? A chemical burn that is from a weird chemical, or a chemical that's not supposed to be as a household chemical. A group of people exposed to a chemical together, and if they're working on something. So all of these are reasons why we can potentially play a role in this chemical security or biological security or radiological security ring.
And I want to expand on that point that with most terrorist attacks, they're more predictable than you might think, in that they don't just happen overnight. There's always a planning phase, a testing phase. So if you think about the process, first someone has to acquire, let's just choose a chemical example, for instance. First they have to acquire some knowledge about what chemical they're going to use. Then they have to actually acquire the chemical. And then they have to develop some sort of a delivery system. So in this process, there are many opportunities for them to be exposed themselves. So there's always the possibility that they might splash some chemical on them. And if they come into your emergency room and they have some weird chemical burn that doesn't make sense, especially in line with their occupation, that's a red flag. We'd call that a red flag in the US at least. But that's a suspicious warning sign. Then, most of the time, during these attack cycles, they also test it, a small-scale test. Again, another opportunity to see people coming in that have some sort of a strange exposure. And this always happens before the larger planned events. So there are many opportunities that you as physicians are uniquely situated for to actually identify big attacks before they happen.
Thank you for expanding on that. And also, the other thing that we need to know about is who to report it to. We did a survey of emergency responders in Atlanta about these topics, and it's being published in a journal issue that Andy is editing, I believe.
It's actually available online right now.
It's already available, correct. And you can look it up. And you can use that survey if you like in your own community. That'd be nice to do that. So a couple of things came out of that survey. The first thing is that people were, responders did not know who to contact. We were surprised to see that. Mm-hmm. Do you know who to call if there's something suspicious? If you see something suspicious other than the police, who do you call? No, what if you did know and you suspected something? Our responders didn't know who to report this to. The other thing that we noticed in the study is our responders felt a little bit ethically undecided. Is it ethical for a responder that goes to save someone's life or take care of somebody in their home to report on them, even if they suspect a criminal activity? If you see something, say something motto, is that ethical for a paramedic to do this who's already awarded the faith, the faith and the confidence of the community? Are they violating that faith? That was the second thing that I thought was interesting.
That's a really tough problem too, because you could also look at it the other way. By not acting, you're potentially harming other people. So it's and no one can make that decision for you.
No, for example, in the U.S. we have some joint we call them like joint hubs of law enforcement and fusion centers. We call them fusion centers. But people are not trained in this, responders, and we ask them, they're trained in hazmat maybe, they can recognize toxidromes, or they train in toxidrome recognition, but they don't train in chemical security. So chemical security training is lacking for responders and physicians, certainly, and nurses.
I have the video with us, so we can watch it after the break.
Yeah, maybe we'll watch it during the discussion. Sure. And don't worry about being a little bit behind. This is part of the discussion that we're going to have. So let's go ahead and take a break right now for 15 minutes. Come back at 3:30, or 20 minutes. Come back at 3:30 for the final PPE session. We have Dr. Anwar Al-Wadhi, who's one of our disaster medicine experts from Kuwait. He's going to talk a little bit about chemical hospital preparedness. Dr. Abdilhal Attas from Saudi Arabia is going to talk about biological hospital preparedness and biological transportation of biologically infected patients, such as Ebola. And then at the end, we'll just kind of do an open forum together and maybe show the video.
Yeah, perfect.
We'll try to get you out of here at 5:30, if not 5:15, hopefully. Thank you.
Koenig and Dr. Schultz. He is now in Kuwait. He actually went back to Kuwait right away after he graduated to contribute to his country. And he currently is the advisor for the Emergency Medical Services and HIMSS for the Ministry of Health of Kuwait, and is actually in Department of Emergency Medicine at Mubarak General Hospital. He is going to share with us the perspective on the hospital response or hospital reception of chemical emergency victims, and then he may show us some videos, I believe. Yeah, so thank you, Dr. Anwar.
Thank you. Thank you, everybody, and welcome. I know it's the end of the conference and you guys are tired. It's the afternoon. I promise I'll make it short. So basically, the talk is about hospital management of chemical incidents and the reception of the victims of either industrial or warfare or might be like terroristic attack. This is I want you to imagine if you have a facility and you get called in today that something happened at the facility and you are actually, either the medical director or the actual disaster manager thing. This happened at one of the oil field refinery just 2 days ago, which is on February 20th. We'll watch like really short videos. So this is actually the CCTV camera of one of the sites. This is actually 2 days ago. And this oil refinery is due to, next video. So this oil refinery actually is due to, this is all taken by individuals. I'm sorry, no. Yeah, so this is all taken by individuals. Actually, some of the videos might be uploaded already on the internet. Regardless, the good thing is this facility is not functional yet. So it's not up and running. So there wasn't a leak. It was all major, structural damage, and thankfully nobody got injured. You can go third video. I'm not sure why it's not projecting, but anyway, that's fine. That's it. You get the idea. That's fine. We can go back to PowerPoint slide. Something with a projection. Okay. So imagine yourself, this is actually another refinery. This is in Philadelphia many years ago. But anyway, so the actual thing when you start is actually you get a notification. The regular channel for this, so for example, Dr. Ziad just mentioned if you're at a chemical incident just before the break, what would you do? Are people aware how to manage these type of incidents? Are they trained to a specific role in a specific agency? So the idea is if you get something like this, you obviously, you call the emergency line. Usually all companies run their own thing unless it goes out of resources, which is by definition is a disaster event when you have requirement and resources. And you make a call to 112, which is the dispatch for many countries, or 911 in the United States. And by the way, 112 is actually international. So if you call apparently 112 in the United States, it goes to 911. And you you report the incident, and the 112, whether it's the emergency dispatch, it contacts your EOC, Emergency Operations Center, at the EMS department. And the EMS department asks a few questions. They're trained, they know how to scale up and down, and then they activate hospital or multiple hospitals under HICS, Hospital Incident Command System. And if they think the event is actually really large, they activate the ICS, the Incident Command System, which is a multi-agency approach to certain incidents. Now, you can always activate it, and if the incident is really small, there are no people are being harmed, it's only fire or it's only building collapse, then you can, downscale it. But if you do not, and something gets leaked, like, gas or oil or chemical or fire, so to speak, it's very hard, to catch up with the event itself. So the main thing, actually, once you activate all of the system, is patient safety and your staff safety. If you miss on these two, it's actually, you're multiplying the effect. So let's say we go back to our incident, you have to establish your zones. So hot zones, warm zone, and cold zone, you can mobilize or demobilize as much as you want. If you don't do that, something might happen to what similar happened in sarin gas attack in Tokyo. Remember? The average was 200 at the event in 1995, but by the time they reached the hospital, there wasn't a proper, people are not used to that kind of scale. The average number was 5,000, including staff and patient and relatives also. Some of them actually taxi drivers who transported those people. So staff and safety security response to the objective. What kind of incident? This one is hazmat, hazard material. And then you activate the incident management, and then once you manage the role, let's say it's only fire, then you transfer of command to the fire department. And then obviously incident recovery, which is you learn, lesson learned, incident action plan, and everything that goes after it. So we go back. So HICS activation, Hospital Incident Command System, you need as much as intelligence, you need to know as much as information, because actually you can manage more in the field while en route, and you actually can, reduce the effect of all of this to your hospital. So one of the things, if you think this is like really, something that could contaminate your hospital, you can go and activate hospital lockdown policy. Now, hospital lockdown policy has many objectives. It has for active shooter, threats, leak of, let's say, radiological material from your nuclear department, many reasons. But in this scenario that we're going to talk about specifically, we're not talking about biological or radiological, we're talking about chemical incidents. So you can activate lockdown policy. The other thing is you always, if you need, ask for help. Remember, we go back to the incident command. If you think the scale is large, then you can ask for fire department, National Guard, whoever does hazmat too. So you can have a field zones and decontamination at the site if your decontamination units at the hospital will be overwhelmed or people will flood your hospital being affected. So once you activate the decontamination unit to the hospital, whether it's in the field or mobile units, you also want to know more about the agents. Is it liquid? Is it vapor? Has it been, what type of contamination? Was it inhaled, ingested? Was it contact? Was there a spill? All of these, obviously, make a difference in the management. But you go back to the basic thing, which is ensuring patient safety and staff safety and security. So PPE, personal protective equipment, and you scale it up and down. So if you think it's really, one of those that needs level 1, then you go level 1. Our colleagues will probably demonstrate, the type of suits and the scubas and how you use it. The basic for hospital staff, if you don't know, you can go to level D, the basic, which is, goggles and face mask and apron and gloves and all of that, right? Now, luckily enough, now you have to detect, let's say, chlorine or other, leaked gases. You have many companies that provide chemical kits for that, that's good enough. However, there are many chemicals that's out there, and the majority, they don't have the antidotes. And the majority of the management for these things are actually conservative, which is supportive care basically. But one thing stands. So if you're let's say you're in your PPE, and you activated your decontamination unit at the hospital, but many patient comes in, so you actually go to, this is MCI, like mass casualty incident, which is more of a disaster event. You go to reverse triage, so you want to go through, green, yellow, red, and black. So for example, if a patient comes in at the hospital and you have resources and you're not overwhelmed, so priority resuscitation goes the top priority before you look at, you decontaminate him totally. I mean, you can do both at the same time. In the decontamination unit, you expose the patient, but if the patient is cardiac arrest, you absolutely jump to resuscitation. Make sure resuscitation comes first, as long as you are having your basic protective equipment. Now, there are actually some of the lists out there, like Kim Intelligence Syndrome list, which goes actually through the major thing when you ask the paramedic in the field, or if the patient arrived in the hospital. So you ask for vital sign, mental status, pupil, mucous membrane, lungs, and skin. Those are major parameters, and if you link them, you will find a way of, okay, I'm dealing with, opioid toxidrome, or I'm dealing with anticholinergic. So the Kim list helps you to do that. So what are the major lists that we are looking at? I'm sure like all of your colleagues have gone through all of these, and I'm not going to repeat them, but we'll mention them briefly. Knockdown syndrome. Classic in where an industrial site. People walk in, a guy, drops, the other guy wants to help him, he drops him. Before you know it, you have a lot of people, dropped at the site, and you cannot help them because people don't know what kind of agent. The other agent, like pesticides, people work on farm, but also naval agent when it comes to warfare, and specifically now, a fourth generation, which is odorless and you cannot detect it. Then solvents and anesthetic and sedative. The anesthetic and sedative is commonly what we use in the department, like halothane, propofol, and benzodiazepine. Then you have irritant gases. Irritant gases commonly now, it's actually in riots. You have people going riots in many countries, unfortunately, and then you define them between upper and middle and lower airway according to their volatilities. Then opioid syndrome, we all deal with this in our facilities every day. The unfortunate part is, unfortunately some terrorist attack might use some of the opioids for terroristic reason, like carfentanil, right, which is probably like more than 250 times more than opioid, and they can vaporize it, and presumably it happened in one of the terrorist attacks in Russia. The anticholinergic syndrome also, and then convulsant syndrome. So now we go with the initial assessment. So you want to make sure that resuscitation is your priority. So airway, breathing, circulation, but D is actually not disability when it comes to ABS, it's actually decontamination. And the drugs, you need to know, do I have the antidote for this, or this is conservative management? If I have the antidote and I'm receiving many patients, I probably need to ask for to stockpile those agents. Now, you can go through the asbestos mnemonic. Now, agent is what type, and what's the LD50, and what's the status? Is it liquid, vapor? What's the type of contamination to the body? How severe is it? The time of course, is it delay or is it acute onset? All of these actual parameters, and obviously synergistic and combined effect or delayed contamination, right? People were not exposed properly, they can have delayed contamination for that. Then you can go through poison, which is, what type of it? Is it outside? Is it internal? What's the sequence of event for that? Do we have other differential diagnoses, right? And the net effect for both the patient and actually for cross interaction between chemicals. Like, for example, this facility, if it had multiple towers, one is chlorine, the other one is H2S or something, or ammonia, you will have probably a mixed range of victims. So we go back, and now we're going to go through them really quick because I'm sure my colleagues have covered all these syndromes. But knockdown syndromes is, as we mentioned, it's usually in the industrial site. People walks in, they drop down. The actual mechanism behind that is usually, for hydrogen cyanide and hydrogen sulfide. The major mechanism is actually toxicity to mitochondria, so they cannot utilize the use of oxygen. So it could be simple as cellular asphyxiant or hemolysis that goes into hemoglobinopathies or anemias. Now, the other one is pesticide, or what's known as cholinergic or nerve syndrome. I mean, most of you have dealt with this, especially if people work in rural areas and people still use pesticide, for farming. And the only thing that we all know that you need quite, large amount of atropine. And if you're lucky enough that you have 2-PAM, pyridoxine also. And then obviously for muscle spasm, people have spasm for a long time. So think about rhabdomyolysis, think about renal failure if you need dialysis. And obviously, you can work on that. The other is, aggressive supportive measures like circulatory and respiratory measures. And obviously decontamination when indicated, which is probably most of the time it's the case. The other one is organic solvent, aesthetic and sedative. So industrial will be like, the gasoline, the toluene, the carbon tetrachloride, and freon, like used in freezers. And the medical will be nitric oxide, in anesthesia department, halothane, isoflurane, the stuff that we use every day, like etomidate, barbiturate, and benzodiazepine. So there are specific drugs like benzos, you have flumazenil, but all the others, most likely you will end up doing supportive measures like aggressive ventilation, oxygenation, and circulation measures. Irritant gases, the major categories will go probably upper, middle, and lower airway. So ammonia, chlorine, and phosgene, and it's all divided according to their volatility. So if somebody inhaled, was it only inhalation, or is it actually skin contact? We go back to when we were doing differentiation for that, right? And some of it actually industrial, and other, unfortunately, could be used in riots or actually just household leak, like chlorine, for example. Now, ammonia, if you have, it's actually erosive, so we know that, especially with mucosal membrane. So irrigation, people could inhale it. Specifically, they end up with massive laryngospasm and actually respiratory arrest. The treatment, again, is like decontamination when needed, hydration, and obviously supportive measures. Chlorine, on the other hand, might have a yellow to green color to it. It's non-combustible with a very specific odor. Yet again, it mainly affects the middle airway, and it can cause respiratory spasm, which is acute, and the respiratory failure. The treatment, again, for it is actually supportive and aggressive measurement, but there is no specific antidote. The other irritant, which is has low volatility, is actually phosgene, which settles in the lower alveoli. It's colorless, it's non-flammable, and it can also lead to suffocation. Now, again, you need to decontaminate when needed, but aggressive supportive measures. So this covers basically the pulmonary irritants. We go back to tools for identifying these agents. Use them if you have them. If your facility has, obviously the funds to get them, that would be great. If not, just use your basic parameters that we discussed in the field, that you look at the vital sign and the names to identify which one of those 7 or 6 toxicodrome that we talked about. Now, opioid is another one. You guys are very familiar with this. If you have we have antidote for that, which is naloxone. However, if you experience a patient coming with ramifentanil or just fentanyl, now, unfortunately now fentanyl is being sold everywhere over the internet, or carfentanil, which is much worse, then you probably won't, revert that person with few naloxone antidote. You have to watch, you have to ask, you have to get collateral histories, but it can be challenging, even with the availability of the antidote. And obviously, you guys are the expert when it comes to opioid toxicodrome. Anticholinergic, obviously, it's the sympathomimetic without having a wet skin. It's rather dry. But basically, what really bothers the patient is actually the altered mental status and hallucination. And what you need for that is actually aggressive hydration, you need benzodiazepine, and if people go into rhabdomyolysis, they probably need dialysis for that. So, but the major mainstay of treatment for the anticholinergic is conservative management. Convulsant, on the other hand, now it affects the central nervous system. So you have glycine and GABA antagonism, which is they desensitize the nervous system. But if you have something against that, then it's excitatory effect. And the opposite, the same. Glutamate is excitatory, because if you have antagonism to that, then you have depression of the central nervous system. So it's actually, the toxidrome for that is the opposite of what's the available physiology for these things. So where are they found? They're actually found in the industrial chemicals, and they can be in chemical warfare or terrorism attack. And what happens actually, again, aggressive measurement, hydration, supportive measure, and respiratory support. And remember, for people, because they go into excitatory phase, they might end up with status epilepticus with unknown cause. But when you need is conservative management, benzo, barbiturate, and if you suspect something like INH toxicity, you probably add pyridoxine to that. So in summary, you have to have, when you receive a call for these type of incidents, you need to have a high index of suspicion. Gather as much as information as possible, because the only way that you can actually manage these events is you can scale it. So let's say you're at that facility, that hospital, and they called you about the incident that we saw a few minutes ago. You can actually make a call to the EOC, say, even though I'm the closest to the facility, I need the support of the Incident Command Center, and divert the cases like green or yellow triage to other facilities, right? And even if you know the chemicals and you have stockpile, you can share it through your incident command system with other facility, especially if they're receiving the lower acuity one. Now, request for support is very important. If your fire department, or if your National Guard, or if your civil defense use hazmat team, use them, because that means probably the lower cases, that are not severe, they can be treated at the field by going through the hot zone, warm zone, and cold zone. Identification of the patient. If you go through the parameters that we discussed about those 7 toxidrome, then you probably have a good chance of managing these events. If you don't have the tools like kits to test them, that'll be fine. You just have to do the basic conservative management, fluid, aggressive hydration, and circulatory management. And manage per incident. So if this incident that we saw just now was a fire, and then you activate incident command system, you can deactivate it. But if it's a fire that led to structural collapse, and you have victims, trauma from structure, and then you have victims from toxic inhalation, obviously you're going to run the full incident command scale for that. The evaluation of the incident is extremely important. A lot of people mention this is like lesson learned, but it's more than the scientific word. It's experiences gained through incident action plan. So when you demobilize, you sit down and you look at things, and how did we do? And this is probably one of the most important things to learn, and how to manage that type of large scale and complex event. And I would like to leave the last few minutes for questions. It's a little bit of a complex topic, but thank you for your time. It's the end of the afternoon. Thank you. There is.
Let's have Dr. Ibtihal do her lecture, and then we can have the discussion. Maybe that will stimulate more. So Dr. Anwar will stick around with us until we do this. It's my pleasure to welcome Dr. Ibtihal Attas. Dr. Ibtihal Attas is currently at King Abdulaziz University in Jeddah, and she is deputy director of EMS at that hospital. Ibtihal completed a residency in emergency medicine at Emory University, followed by a fellowship in emergency medical services at Emory, and then moved back a couple of years ago, and is here with her lovely family, her husband, Dr. Sultan Wajih, and her daughter, Acil. So, Tihal is going to talk about the biological side of things. Well, yes.
All right. Good afternoon, everybody. We're just going to switch gears and we will concentrate on the biological incident. So the biological incidents, we have many, either it's man-made or actually was done by the nature. We have the incidents in '84 where like a couple of salad bar restaurant in Dallas was infected with salmonella because of like some political group. Then we had since 2001 the anthrax. After that we have the SARS, the outbreak of coronavirus, and lastly recently the other coronavirus, the novel one. Yes, the viruses actually. So when we want to think about the biological attack, it's really similar to the infectious disease outbreak. The only different is like the scaling of the surveillance and how you're gonna act with the public health authority will be just more skilled. So how you gonna identify the incidence if it's biological? We have like mainly two sources of the to identify that. Usually the 911 centers or any call center in the country they have their like geographical mapping of where is the call is coming from. So usually the program that they have or the mapping will show them if multiple people have like presented with the same symptom, and this will alert them that, okay, there is a possibility of like an outbreak here or a biological incident. And usually if you have a call for one patient, it's a regular day. 2 patients, it's a little bit suspicious. If you have 3 patients, like on the same, on 1 hour or 2 hours, this is usually activate the hazmat or like hazmat response or something like that. So the authority will be just at least notified of it. The second place, it's the ER actually, and that's why we're saying that the emergency physician are the first line. They are the most important people to identify if there is incident, because you can have increased scale the number of patients presented to you. And all the infection control in the hospital, they will notice that, okay, from the surveillance of the disease, we have this month couple of people presented, or in this week, we have a lot of like respiratory symptom or gastroenteritis more than what we usually suspect in this time of the year. So for chemical, like for the biological wise in the community, what is the sign that make you suspicious that it could be an attack? If you have a bombing that didn't make a major destruction for the place, you can think that, okay, maybe it's a dirty bomb. If there is in the neighborhood unscheduled spraying for insecticides, it's like a different, like a weird time, weird place that they usually do not do the spraying, then people have to be suspicious. If there is if they found anything like thrown in the floor, like a discarded PPE, any biohazards bag, this is also suspicious because it shouldn't be in the community. It has its own way to be discarded. And if there is also like multiple insects in the same place that it shouldn't be, like if you have like a lot of whatever, fly, whatever, it's like in a place without plants, then this could be suspicious. If there is a lot of dead animal from different species, so if you have like a lot of like birds that getting sick or dying in the area, you need to take this in consideration. And lastly, the outbreak of the respiratory symptom. If it's in the winter, this could be normal. But if it's in the summer, then it has to be suspicious. For the epidemiological part, the clue usually that if you have a disease in multiple people are dying, sorry, it's a little bit small. And if you have a single case of uncommon disease, like if you have one patient with anthrax, one patient of smallpox, this is will activate the incident. And then lastly, if you have a zoonotic disease that shouldn't infect the human, but it's now in the human, this might be a biological attack. For the CPR&E, the scene management, as the doctor before me mentioned, you usually isolate the area, control your access, establish your communication, and this is how you kind of go in the scene. You start communication and you have your risk assessment, but then you implement your treatment, doing your triage, and try to do the victim evacuation. And this is how you kind of controlling this is how you set your control zone, where you have your hot zone, warm zone, and cold zone. Unfortunately, for the biological incidents, all of this is like not gonna happen. It's most likely for chemical, or if there is a bombing or something else, because most of the infectious disease have an incubation period. So the patient will actually come to the ER with the symptom, and they already exposed, like anybody exposed to them, and you don't really have to do all of this stuff. So how you gonna think of the bio stuff in your response plan? You have to put a plan how you're gonna recognize if there is an attack. So you have to have a plan for this. Like you put a syndromic syndromes specifically, you educate your staff about that. How you're gonna get your prophylaxis? If you want antibiotic, if you want a huge amount of antitoxin, how you gonna get that? If there is a large number of dead people from infection, what you gonna do with them? And how you gonna deal with the public? How you gonna control the area of the attack? Like these days, what they are doing in China, and how they like isolated most of the areas, and how you limit the access to the area of the attack. And you have to have a plan how you gonna quarantine the possible exposed patient, like the possible exposed people actually, because not everybody gonna listen to the quarantine order. It's not isolation because they didn't show the symptom yet. So you need to have a plan for that. And most importantly, the safety of your worker. Adding to all of that, for the bio incidents, you need to add for yourself more stuff. So it will be how you're gonna transport these patients, and if you transport them, you need to prepare your vehicle, and what special equipment you might need to do, how you're gonna disinfect your equipment, what you're gonna do with the waste management, and lastly, post-mission surveillance, which you need everybody who transported a patient, you need to put him under surveillance for a possible appearance of the symptom after that. And it's really, basically, it's the infection control if you think of it. It's very simple. If you are doing your hand hygiene, you have your precaution appropriate and your PPE, and you have your prophylaxis and the vaccine, then things gonna be easier. Just a little quick about the mode of transmission and precaution. We have, as we know, the droplet and the airborne, and in the droplet you actually have like more than 5 millimeter of the droplet itself, and it's enough for it to do a face shield, a mask, and a regular gown. But when it's airborne, you actually need to have like N95, HEPA filter, and all of that. For your standard contact stuff, you need your gown, gloves, your face shield again, and your regular mask. Hand hygiene, it's the most important, and don't forget that. So if you detect an outbreak, after that, what is the appropriate response? So you have to notify the authority. They're gonna start their epidemiological investigation. They're gonna look for how many patient is affected, what is the sign and symptom of the syndrome that they are developing, what is the exposure route that they have, and they will do a rapid lab identification. Then they're gonna release for you what is the treatment, what is the antibiotic or the antitoxin you need to use. If they suspect that this area is contaminated, authority have to map this area, and they need to answer many questions. It's usually they get the answer after they have like multiple sampling from the place. Is the incidence was spread by liquid or powder, or it's any change in the physical or biological thing of the bacteria or the virus, make it more virulent or make it resistant to treatment. They have to answer this. After you have this answer, then as a medical provider, you will issue your correct PPE, you start your first aid and treatment for the patient, implement the decontamination. And remember, the decontamination here is different because you have to include the building from inside and outside, especially if there is a gas or air stuff, and for your vehicle. So, like really in conclusion, if we think about decontamination, it's really needed if there is a chemical exposure or a nerve gas agent or whatever, and we don't need it if this chemical is gas or if it's biological incidents, and we can actually delay it if we have a radiation incidents after we treat the patient and save the patient. And there is multiple methods that you guys know, the dry and wet, but for biological, we're gonna add like the normal sterilization stuff that we do in the hospital and the autoclaving. So I'm going to talk now about the Grady experience. Actually, Grady EMS, they are the hospital care provider, the pre-hospital provider for Atlanta City in Georgia, USA. So they developed this team, what's called biosafety team. It's mainly made after the attack of September 11, and they actually, initially it was like a SWAT support team, but after the SARS attack in Canada, they start thinking, okay, what if we had to deal with a SARS patient and we have to transport an infected patient? What we're gonna do? We need to protect our staff and ourselves, and we need to help the patient at the same time. So they developed this unit, and the leader for the unit is Dr. Alex Isakov. So actually what they do, they train their paramedics, a couple of them, and they teach them the nature of the disease. They're going through courses, and they teach others also in the area. Their experience with the Ebola patient, basically, in 2015, they transported the two Ebola patients to Emory University Hospital. So what they did, actually, they have 5 steps in their plan. How they're gonna prepare their ambulance, what is their PPE, and what is the role of each one in the team, and how they're gonna prepare the patient inside the ambulance. And here are some pictures of their publication. This is actually the inside, the ambulance from inside. So what they did is, they are using the regular ambulances that for the daily operation. They didn't buy like an expensive unit or like wasting a lot of money. So what they did is the ambulance, and they have like a plastic, very thick plastic draping, and they actually wrap the ambulance all over from inside as a capsule. They remove everything out, the suction, the oxygen, anything the patient might need it, and they wrap it up in plastic so they can use it. And this is the ambulance from inside. And actually, if you notice from the top, this layer also can, like when we close the door, it covers the door completely. So there will be no contamination for the ambulance whatsoever. Because even if you didn't do that, the ambulance have a lot of small spaces, and the infection will get somehow, it will get contaminated, and it will be very difficult to disinfect. Okay. After that, how they prepare the patient. So they suggest 2 things. If the patient can walk, he can actually wear the Tyvek suit, because for the Ebola patient, some of them, they're having vomiting and diarrhea, and some of them, one of them was very weak to walk, and the other one was fine. So if the patient can walk, they can wear like the suit, which will be easier to transport the patient on, and it will make the transmission less. If the patient cannot, they actually grab up the patient with a cover, and they covering him completely, as you can see in the picture. Also, for the mask kind, if the patient have no vomiting, they actually can put a surgical mask. If the patient is vomiting, they are actually giving them like a very thick bag so they can vomit in it, and they're not contaminating everywhere in the ambulance. So they're trying to keep the ambulance inside clean. The PPE that they use, actually the Ebola was, as you guys know, it was a contact mainly. So they used the Tyvek suits, double gloves, the hoodie. It was actually felt that the goggles and the mask, the N95, were more than enough, but they choose to use the paper. The only reason they use that, because it's environmental thing, because Atlanta is very hot. So if you think about it, when you are putting the goggles in, you will have the vapor, and then you cannot see. Then what's gonna happen with the paramedic? If he wanna move the sweat, he will do like this, and then he might be infected, and he will infect himself. So they don't want to have this movement from the staff at all. That's why they use the paper. It makes the environment cold for them inside, so they don't have to touch themselves at all during the transport. The last thing is the staff. So the staff of the unit, actually for each transport, was 4 healthcare workers, 2 paramedic, and 1 a supervisor, and the EMS physician. The 2 paramedic, so the first one will be fully in the PPE full, with the paper and everything, and he's the one who's going to take care of the patient. The other one will have the same without the paper, just the mask and the goggles, and he will drive the ambulance. If the patient needs 2 paramedics, then the supervisor will don his PPE and he will drive the ambulance, and the 2 paramedics will be inside the ambulance. If not, then the supervisor and the EMS physician will actually follow the ambulance in the supervisor car. And mainly the reason for having the supervisor, he's acting as a safety officer. So they have this checklist when they are donning and doffing their PPE to make sure they are following the protocol specifically and they are not missing anything. And that's how they transported the patient successfully without getting infected. So lastly, just remember that the biological incidents, it's really like infectious outbreak. You need to be just cautious, always maintain a high suspicious. If you have multiple patients with different symptoms, think of chemical versus biological. If you have a patient with abnormal rash, with respiratory or neurological syndromes, all the syndromes that they describe in the morning. And remember, first responder is not the first one usually who counter these patients. You are the one, the physicians and the nurses in the hospital. And decontamination is really not necessary initially, but after they know the attack. And any questions?
Andy?
First of all, I want to say thank you for your wonderful presentation. You highlighted a lot of really important topics related to what I would call biosafety. And I just wanted to point out to the audience that biosafety is a very complicated area. And although we're all capable of understanding this, we're all trained in the concepts of biology, many of the topics that were listed there, there are full courses on waste management, full courses on PPE. And I just wanted to point out a resource for all of you. There is a website, it's the internationalbiosafety.org, internationalbiosafety.org. And on there, there's actually a list of certified biosafety professionals. Many of your countries are represented. Turkey is on there. I believe Jordan is well represented. So you can actually go to this website, find the people that are already trained in that, and call them or email them so you don't have to recreate everything yourself. So thanks again for your presentation.
Thank you, Andy. I was interested in the ambulance, so I'll ask this question to Dr. Ibtihal and Dr. Anwar. Have you seen or heard of a special ambulance for chemical? I mean, I know for biological, you've retrofitted this ambulance. And I know in Los Angeles, actually, they actually made a biological ambulance. What about for chemical or radiological? Have you seen or heard of anything like that? Tim, maybe Dr. Anwar, have you?
We go back to the basic decontamination site and in the hospital. If you do your contamination outside, it's more than 90% done.
What if you don't?
Well, what if you don't and they jump in the ambulance? Then you have to, first of all, identify the agent, the offending agent. Is it something that's only inhaled, or is it actually skin contact, or is it actually, as Dr. Ibtihal mentioned, like airborne or like droplets or something? So it depends on the actual, agent.
What about you, Tim? Have you heard about the ambulances?
If we only have 1 or 2 patients, some of the ERs in the Chicagoland area, especially DC, et cetera, have preset decon rooms. So if we can notify the hospital.
You mean the ER?
With PPE.
What about the ambulance?
Yes. So they have the decon rooms, and they can set up faster than we can pull a hazmat team to the scene. So we drape the ambulance very similar to what she demonstrated for Ebola. And we drape it like that, and we can do that faster, put them in the ambulance, and decon them faster at the hospital than bringing, especially in the winter, and then bringing out a full decon team and trying to decon somebody when the temperatures are below freezing outside.
So it's primarily contact protection?
Yes.
Nothing else, so basically just drapes.
Yeah, so what we'll do is then, typically we'll only do that if we know the agent,
Right.
as the doctor said, so we know what level of protection, because you don't want to be in an A suit in an ambulance.
Absolutely.
If you can work in a C suit, I'm all good with that. I've worked for 4 hours in a C-suit with a cooling vest.
Right.
So we'll put the transport medics in a C-suit, drape the ambulance, and then decon them inside of the hospital in a preset decon area, and it's much better for the patient than try to decon them in the ice and the cold.
I think for radiological, if somebody's contaminated, you don't necessarily have to do that. You can just wash the ambulance, because of just a bunch of dirt, basically. But it's interesting for the chemical. Mark, were you going to say something?
More directly to your question about a specific ambulance specifically for a chemical incident or a radiological or a biological. The answer is yes. There are specific units that have been designed for this purpose. They're marketed by various manufacturers, but there is no standard. So each unit is designed per the subject matter experts that particular manufacturer was reached out to or worked with. And most oftentimes it's for a specific jurisdiction that came to the manufacturer and said, this is what we want, this is what we would like it to be able to do, this is the features that we want in it, and then they customize and build the unit and sell it to them. I know they do exist in the U.S., they exist here in the MENA region. I know that Abu Dhabi has actually a fleet of them, both domestically and for the military. So the answer is yes, they do exist. Can you just order one? The answer is no. Yeah, they're going to force you for
I wonder if
liability
they're
reasons.
necessary. Yeah.
Mark,
I wonder if they are necessary.
For 99% of all events that we're aware of historically, I would say no.
And are they meant to protect? The drivers in a plume, or are they meant to protect the patient from, or the staff from the patient?
It's based on the request. I can tell you that because I was part of the team that helped design some of them, I know the military ambulances, for example, that UAE has, and this is public information, they do have special filtration systems for the engine and for the cab so they can drive into contaminated areas. But the civilian civil defense and EMS units, they don't have that particular capability.
They don't need it.
It's all internal.
Thank you.
Actually, Dr. Ziad, I will add just one or two points. At the end of the day, it depends on the budget. So if your agency has, quite a bit of budget, you can do whatever you want. For us, we have like decontamination unit for the EMS department, but our turnover number, let's say per hour, is no match to the fire department, and the fire department is no match to the National Guard, at least in where I'm from. But in other agencies, probably the military has much more resources. So we go back to the presentation, is ask for help. That's why you run incident command system. You ask all these agencies to buffer, because the last thing you want is you contaminate few ambulances, and you still have to run day to day and actually minute to minute operations. So
that's a good point.
It depends on resources, basically.
All right. Big hand of applause to our speakers. Oh, did you have a question, Mazda? I'm sorry, I didn't see it. Go ahead. Okay, so let's go ahead and move on to the last part of our day with Mark Chambers and Tim Conley. Both of them are long-standing colleagues and partners with Minatox through the company Response Systems International. They are very active in the MENA region, actually, and do a lot of training on PPE, on decontamination, disaster preparedness and response. And actually, in the U.S., they do participate in disaster response for the federal government when needed. Their objectives are to show us some of the PPE that they have. Level C is what we're going to do.
We'll go through all.
Okay, very good. Do you want a microphone? You have. Would you like the one that you put on the ear?
About the suits, we'll actually start with the level A suit, and then the B suit, C suit, etc. Explain a little bit of each suit, but then focus on the level C. Level C is most common in the first receiver field. Or in the hospital setting. Well, there's a big difference in where you come from on your resources. Where I work, if you ask for a fire department hazmat team, you're waiting for an hour and a half. They're not fast. In most cases, the hazmat team will be committed to the scene. So now you're waiting for a farther away team. So our hospitals have to have their own decon capability and have to have their own teams. And Mark and I have actually taught at a number of hospitals together to build that capability. So we'll start with the suits. This is a level A suit. And Mark, you want to hold it up? Level A suit is one of the safest and most dangerous suits at the same time. And it's safest because it completely creates your own ecosystem. Nothing can get in, nothing can get out. It requires you to wear an air pack, a self-contained breathing apparatus with pressurized air. So the benefit is you're safe from nothing getting in. The downsides are your core temperature is going to go up fast. You know, you are your own ecosystem. Nothing escapes. There's no air movement. You know, so your core temperature goes up, the humidity builds up, your vision is off, and you have a very limited work time. So if you're wearing what they call an hour bottle, which means if you were sitting in a chair perfectly still in 100% shape, you could work for an hour. It's not true. Because you're moving, you're working, you're sweating. You all know as physicians that with your core temperature goes up, your tidal volume increases, you're burning through more air. All right? You also have to allow for decon time because you can't run out of air while you're being deconned. So you have to watch your air carefully, and I've seen people run out of air in the decon process and it does not go well. Okay? So it takes a lot of practice. In order to wear this suit, you have to, in the US, you have to go through almost 100 hours of training just to be able to wear the suit. And then in the states that I work in, you have to do 20 hours a year of continuing education to work in this suit. So it's not something that you can just jump into. Additionally, it's twice a year, Mark, you have to pressure test the suit. So 2 times a year, you have to test the suit, make sure it doesn't have any holes in it. Now, when you test the level B suits or the JS list, it's pretty simple. You can use flashlights, you can use other tricks. These actually have to be pressure tested. So that's a complex process in itself. It depends on your resources. Some larger organizations have the ability to pressurize it and test it. Some places do have to ship it out. But it's not something you can just do. You have to be trained in that process too. Okay? Again, the suit's fully integrated. You have gloves, you have boots. You're still required to wear the over boots that have the basic chemical protection and the over gloves that have the basic chemical protection. Also, where we teach people to wear medical gloves and then like a silver shield glove under that, and then a medical glove over that to help with dexterity a little bit under this. And then you'll have another glove over this. Well, technically you only need to wear 3. I always wear extra medical gloves over it. Reason being, the silver shields is what we call them. You have no dexterity. I mean, it's really hard to work in those. Where if you take a medical glove and put those over the silver shield, it helps with the dexterity and you can work a little bit better. I kind of do the same thing in level B suits, is I take the medical glove, go over the top of everything, and because that helps with the dexterity also.
The silver shield gloves are not fitted, so they're kind of floppy on your fingers. So that's why I said.
I'm going to ask a question here. I was in Abu Dhabi at the Ruwais Medical Center. Maybe I believe you all worked there a little bit. Yeah, in Ruwais.
Is that the one we taught it?
In Ruwais, and they have they actually put they want to insert IVs with these suits on and intubate. And is this realistic to insert an IV with these 3-4 gloves on?
Not to do an IV, but to do an IO, it is. So what we typically teach is you can do, I've intubated in level A suit. I would prefer to put an iGel in because initially that's just as effective. You can do tourniquets, you can do countermeasures, you know, Mark 1s or dual kits. You can do IOs. You know, if somebody needs an IV, they're gonna take an IO in that situation. So you can do IOs. We train people to do bleeding control, rotate tourniquets. So if somebody has massive arterial bleeding, put a tourniquet on, bring them into the decon process, decon them, apply a second tourniquet, remove the first one, decon them again, and they're good to go. So you can do a lot of treatment, and actually that's one of the things that we really push hard is by the time, if you have a number of patients, by the time they get through the decon process, they're going to be dead. So treat them before they go to decon. That's actually one of the principles Mark set when we was teaching in Abu Dhabi, was triage outside. So you're getting the right people to decon first. You know, don't try to treat everybody, use common sense. But stabilize the patient best you can before you get them into decon
or you're going to have a lot more fatalities.
What are some of the more common indications for the use of the level A suit?
So level A suit, I hate a level A suit. Everyone loves to put a level A suit on because it's cool. It looks hot, it's cool, you see it on TV. I hate level A suit. Level A suit I only wear if I have to make entry and I don't know what the product is, or as Dr. Nelson talked about, the SDS sheet says this is really bad mojo, that you need that level of protection to go in. If there's any way I can bump down to a B, especially a C, I do it as quickly as I can, just because of the work time and that kind of stuff. So level A, to answer your question, is you don't know what the stuff is, or it's so bad
And
that you
what are
can't
some
get in.
examples, some chemical examples of so bad?
Well, off the top, if I was making entry into high concentration parathion or marathion, something like that, or
Nerve agent.
what's that? Nerve agents, absolutely. Or the simple trick is, and this is what I call common sense hazmat. If you look in a room where there's a release and everyone's dead, it's immediately dangerous to life and health. That's a clear indication. Well, you got to go in eventually. But if you look in and they're still alive, that room's not an ideal H environment. So you can you can go in a B or you can go whatever if you don't have the A resources available right away.
What is the cost?
That one I'm going to turn over to Mark because I don't know that one.
So the cost varies. And PPE in general, like Dr. Nelson said, it's a whole other world of details and intricacies and references. So a level A suit, for example, is called a level A because of the respiratory protection as designated by OSHA standards, not necessarily because of the chemical protection. So it's completely self-contained, has an element of chemical protection, and that's why it gets the level A designation. Now, however, the suit material itself can be a number of different materials. This particular one's a training suit. I think it's made by Kapler, maybe DuPont or Lakeland.
Yeah, it's DuPont.
It's DuPont. So there's several manufacturers that use proprietary materials to make their suits. And then they publish the breakthrough times of some of the more common chemicals that hazardous materials professionals would use the suits for, and that's kind of how you pick. So back to your question, when would you need a level A? I'll give you three scenarios. One will eliminate hospitals. There's virtually zero scenario in which hospital staff would need a level A. In the field medicine and responder world, we can get into this, but number one, it's a completely unknown agent with suspected IDLH levels of some sort. That's your level A. And number two, you know the agent, and the concentration dictates the use of a level A. So those are the two times you would want to use a level A.
Yeah. No, agreed. And just to reinforce that point,
you don't need it. You don't need it.
You know,
There's and the only way you would need a level A at a hospital is if the incident occurred at the hospital, and in that case, still the hospital staff would not be the ones responding to the incident. It would still be an outside agency that does this coming in. The hospital staff would be more in a reactive isolation, avoidance mode, protecting the area, getting people out and making sure that the contamination was controlled as much as possible so that these guys could come mitigate the actual event.
Yeah, just to reinforce that point a little bit, there's two scenarios where you get patients in ER. They're gonna self-transport to the ER, which is what 90% of them do in an emergency or a disaster. I think it's 93% is what the average is. If they were exposed to something, no matter how bad it was, and they were able to self-transport or get to the ER, how much exposure do they really have? Okay, they made it to the ER. They're still alive. They don't have a tremendous amount. They're not going to off-gas. They're not going to sing. So a level C is absolutely appropriate for that. The other scenario is they go down on scene. the fire department or the first responders or whoever are going to show up and decon them and then bring them to the facility. So again, you're only doing a secondary decon in level C. So I agree with Mark and Dr. Kazi. There's absolutely no reason to have anything more higher than level C at a healthcare institution.
And you do not need a level A for a radiological incident.
No. I would go in radiological. I personally would go in level C with a PAPR.
Level C on the scene and level D at the home.
Yeah, absolutely. Whenever you're talking about hazmat suits, you can always decon at one level lower than whatever the suit is. So if Mark's in a level A suit, I can be in a level B suit to decon him. Okay. All right, so any other questions on the level A suit? Okay, so level B suit is, it has splash protection as a suit. Would you mind, Mark? Sure. Okay, but you can see it does not have integrated gloves, boots. It could, but not all of them do. That kind of stuff. So it requires a little work or a little love to put it together. So there's gloves, you would wear medical gloves, and then the silver shield typically is what we would wear, and as Mark described, and then the outer glove, which is, I'll hold this, Mark, if you want to show them the outer glove over there.
An example of an outer glove.
This is butyl rubber. This is butyl rubber.
This is not butyl, this is another type of rubber. But butyl is, butyl's the gold standard for chemical. So if you know it's chemical, and you get a choice of glove, then butyl is what you want to choose. But this is your standard hazardous material glove.
Okay. So you're going to have those gloves. Because it's not a fully sealed suit like a level A suit, you're going to need to tape the gloves, the boots that you'd wear over the suit, you need to tape those on, and you use chem tape. And a lot of people say it's duct tape, but it's really not. The chem tape has been rated for chemicals, just like the suit and the boots, because you can't just buy boots at Ace Hardware or at the hardware store and put them on. Those are rated boots, and they meet federal standards or for, go ahead, Mark.
I was just going to say, there's only two types of boots, at least available in the United States, that meet the chemical standards for chemical response. One is manufactured by a company called On Guard, and these will always be yellow or green with a yellow sole, so they're easy to recognize. The other is a boot called Tingley, which is an orange boot with a white or eggshell colored sole. So you can spot the real boots a mile away.
I didn't realize you were into fashion, Mark.
A little bit. Little bit.
Mm-hmm. So the chem tape, again, the ones I've always seen have been yellow, and they say chem tape on them. And if you know the chemical, take a minute and research the breakthrough time on the tape too.
What
Just
about
don't
for
rely on
biological?
the suit.
What tape for the biological?
So biological, and feel free to jump in, please. Biological, the chem tape will cover it. If you've got a Ebola patient or something like that where decon is appropriate, the chem tape, all the same procedures will cover it. And I've never seen a biological agent that had a breakthrough time. So.
Yeah, but
yeah.
For bio, any tape that can stop airflow is sufficient. Duct tape's going to be the main one you're going to see in bio.
Yeah, I don't stock duct tape on mine just because I don't want people to get confused on game day at 3 o'clock in the morning when they haven't done this in a while, because then they might accidentally grab the duct tape and use the chem tape. It's kind of like train how you fight kind of deal. I made a mistake once. I was teaching somebody to operate a fire pump, and I didn't want to pull all this hose off, so I was showing them a lever to pull, so water would go out a different spot. Then we had a really big fire with people trapped, and he couldn't get water because he was pulling the lever he pulled in training and not the one he was supposed to do. So I kind of believe train like you fight. So if we're going to train, let's use the real stuff. So on game day, you use the real stuff.
So this tape, by the way, is the only tape in the world made specifically for chemical response with ratings. So if you look, and we can pass this around if you like, right here on the label, it gives you the chemicals that it's been tested for, and it's a minimum breakthrough time of 480 minutes. So it doesn't, there are a lot of other chemicals it's fine for, but it just lists the main ones that's been tested for, and it doesn't make the list unless they can hold for at least 480 minutes. So you can.
Yeah, one more point on the level B suit, is that one requires a self-contained breathing apparatus to be considered level B. So you have to wear an air pack for that. And go along with that, you have to do fit testing and physicals. And before you put any suit on, you should do vital signs measurements and that kind of stuff before you put the suit on to make sure the patient's healthy to put the suit on. The funny part is, though, everyone sets a level of tachycardia. And on game day, everybody's tachycardic because something bad happened and they're putting a suit on. So, all right, so we'll talk about level C. Level C actually is the same suit. The difference between level B and level C is respiratory protection. So for level C, you can have two different types of respiratory protection. You can have an APR, air purifying respirator, and this is an APR. Okay, this is actually my deployment APR, the one that I bring with me when I'm deployed. Okay, and then this is a filter. It screws in here on the side, and we're actually going to address some sort of volunteers up in a minute. They kind of, well, you were voluntold. So, but this is a filter that you screw into here. And this filter is a CBRNE filter. If it's dry, it's rated for 7 hours on most chemical agents. If it's wet, that cuts it down to an hour. So if it gets wet, your evacuation time is a lot faster. It's not comfortable. No, with the product. Yeah. So this is, I mean, I've worked in this for probably 45 minutes to an hour comfortably. The difference between this and a PAPR, is everybody familiar with what a PAPR is? Is anybody not familiar with what a PAPR is? Okay. I can work much longer in a PAPR than I can in an APR. Because in an APR, I'm pulling air through the filter with my respirations. So without realizing, you're going to fatigue faster. You're going to dehydrate a little faster between that and the suit. So it works, and it's very safe. And I'd rather be in this than an air pack because I still have more work time, and I don't have to worry about running out of air. But I'd much rather be in a PAPR. I mean, I've worn a cooling vest. So in the U.S., they have a training facility, CDP. And I go there every couple of years just to keep my skills up. And a couple of years ago, I went to the hospital training program, and I worked during an exercise in 4 hours in Atlanta in August in a level C suit. And I was okay because I had a cooling vest on. And the air is moving in the suit and all that. So I would much rather be in a PAPR than an APR. But again, my deployment one, if something happens, I can put it on very quickly, and I'm good to go. Okay? All right, and we'll go through more of the level C when we bring our volunteers up and and we'll go through this soon. We'll have Mark be our trained observer. One of the practices that I like, and it was a big topic during Ebola, is a trained observer. Somebody just standing back and just watching and make sure we're doing it right. Simple things with the chem tape. If you don't put a tab on the chem tape, you can't get the suit off. And people make that mistake at 3 o'clock in the morning. Have you ever made that mistake, doctor? Thanks for being honest about that. All right? So simple things like that. If you're doffing your suit, did you just make a mistake? Stop. Because a lot of times you make a mistake, you can fix it before you go to the next step. It's, okay, we're going to change the order of things. So the trained observer for biological chem, I think, is a really good idea. Okay? So this is JS list. This is military protection. Okay? JS list, Mark, do you remember when he switched from MOP gear to JS? 04. Okay. JS is a joint service list, so all the U.S. military got together, and they wanted a common system. So this is it. This particular one is missing its suspenders because it's kind of a teaching one and actually not a real one. But it's an absorbent kind of protection, which is a little bit different than how the civilian systems work.
It's charcoal lined. So it's a completely different approach to protection. It has a barrier like the other suits, but it doesn't have the same type of chemical materials. It's designed to breathe, so air can move in, but liquid has trouble, and liquid gets caught with the charcoal.
And you can wear this actually with VX.
Yeah.
If you have the appropriate CBRNE filter, you can.
Yeah, if you were in an APR, I'd be very comfortable. To be honest, I'd be as comfortable in this as I would in most of the other hazmat suits. This is actually reusable. You can wash it 6 times and keep reusing it. You can wear it for 24 hours in a contaminated environment. So it's actually it's very safe. It's got cinching, so you can cinch up under your boots. And actually, when you wear the coat, there's a strap. Would you mind showing them the strap, Mark, that goes on between the legs? There's a strap that goes between your legs to pull it in tight around your waist. It's actually, if you think about it, it's one of the best designs. It's flexible, it's easy to use, it's reusable. You can take it off, you can put it back on. Okay? Anything to add on the JS list, Mark, you can think of? All right. And then, Mark, would you mind showing them the vacuum pack?
Sure. So while we're talking about military, you know, these guys, they often have bigger budgets than the rest of us do, so they come up with a lot of things. They also have the luxury of plenty of experiences to test things. So they teach us a lot. And one of the things that they've taught us is, you know, the bare minimum grab-and-go PPE. They've done very well with that. And so
have a seat on stage.
This is an example of a little bag that they use for their grab-and-go PPE. You would put an APR, which is a mask and a filter, an FR57 from 3M, a CBurn filter, something like that. You would have your inner gloves, a pair of basically hospital, healthcare gloves. Throw your outer gloves in there. A vacuum-packed suit, rated however you want with chemical protective fabric to whatever degree you want. Maybe level B, maybe level C, whatever you want, but your suit's right here. You can use your regular shoes that you have on, and you throw these booties, rubber booties over the shoes and then tape, and you're ready to go. So all this fits in a nice little bag. You can keep it, wherever you need to keep your emergency supplies, or in your vehicle, or at the nurse's station, Starbucks, wherever you want. You can do that. And before they do the demo, I wanted to talk a little bit more, just for a minute, on the selection of PPE. So you've got the A, B, C, and D, and the good doctor earlier talked about D. D would simply be any level of outer protection you desire, but no real respiratory protection. Possibly a mask, but not a fit-tested mask. So it's just a very rudimentary level of PPE. Throw on a rain jacket and a surgical mask and some hospital gloves, you're in level D PPE. So, you know, it helps, but it's not a real solution for anything. So when you select your PPE, you have to know that there are dozens and dozens of suits that are level B. And you have to select the one, you know, that works best for your application, which is very difficult when you don't know exactly what your application will be. And so that presents a problem a lot of times. Tim talked about the trained observer. Each piece of PPE has its own very specific donning and doffing procedures. Every single suit is different from the other suits because it's based on the way that it's manufactured. Maybe it has integrated gloves, maybe it doesn't. Maybe it has a D-style hood instead of a Q-style hood. Maybe you use chem tape or duct tape. They're different procedures. Maybe you use these orange booties, maybe you use these boots. Depending on your application, maybe your gloves go, maybe your arm goes over your gloves, or maybe your gloves go over your arm piece. So you guys have to know this in hospitals. Based on your selection of PPE, you have to put this together. This is not commercially available. The donning and doffing procedure for your specific PPE, for your filter, for your mask, for your suit, for your hood, for your boots, all of that. And that's very difficult. We learned that we learned it long ago, but we relearned it during the recent Ebola crisis. And thankfully, one of our flagship universities, Emory, has a stellar interdepartment group that put together a very specific set of PPE that worked with the proper donning and doffing procedures. And they went several steps further, and this is available through Emory. They have a scenario-based chart or matrix. If we have this situation, we use this PPE, and this is the donning and doffing procedure for that. They furthered that, and you talked about earlier the trained observer. A trained observer came out of Emory's effort in better preparing the donning and doffing of PPE. So now there's an actual position in the process that has the procedure in front of them that watches you specifically and says, okay, step 2, you do this, and they make sure it's done correctly. Okay, step 3, you do this. This way, the wearer of the PPE isn't burdened by having to do all this mentally on their own. So the takeaway from that is be very specific and selective on what you choose for PPE, and also understand you have to generate procedure and policy based on that decision that you made. Otherwise, it won't work for you. It won't protect your employees or your staff from what you want to protect it from.
I'm going to go over putting a level C suit on with the APR. So before we put the suit on, a couple things we want to do. We want to get his vital signs, make sure he's fit for the suit. If he's got a fever, tachycardia is one of the things. If they're grossly tachycardic, don't put them in the suit. But to be honest, who's not going to be a little tachycardic when you're putting a suit on? So unless you do it every single day, you're going to be a little tachycardic. You got the stage fright going, exactly. Make sure that he's not dehydrated, he's not hypertensive, all those kind of things. Hungover. Not that that ever happens. Okay. We're also going to want to make sure, at this time while he's getting him dressed, we're also going to want to be looking at the patients, and we were talking about this a little bit last night. When you have an incident, the fire department or whoever's on scene is going to take a long time to set up, to get down range, to meter. If they're coming to your hospital,